I'm Michelle Minton, and welcome to the last day of the Global Forum on Nicotine and the last, or the second to last commentary session, I believe. I'm Michelle Minton, and with me today we have Professor Marwa Glover, and Charles Gardner. I'll let both of you two, with your illustrious careers, introduce yourselves. So why don't we start with you, Marwa? Why don't you talk a little bit for the people who don't know you yet? Tell them a little bit about yourself.
Oh, I'm from New Zealand, and I've been working on reducing smoking for 30 years. My PhD was in smoking cessation, and we've been looking for other accessible ways for people to quit and to help people. You just need a fuller range, and so in New Zealand we've been pushing for Swedish snus to be there. Unfortunately, the government never allowed it. And then when vaping came along, many of us in New Zealand began to look at that. And, wow, we're just having so much success with vaping. We also have the heated tobacco products as well, but they haven't really taken off. Most people don't know about those. And vaping is really what is bringing our smoking rates down.
That's excellent. Thank you. Charles, why don't you tell the world a little bit about yourself and INCO?
So I'm Charles Gardner, and I'm the executive director of INCO, which is a nonprofit organization with 37 member organizations around the world. And we're all ex-smokers who use safer nicotine. So we support the rights and well-being of 112 million people worldwide who use safer nicotine to avoid toxic forms of tobacco. And our rights are being challenged. As people who have lived experience, who have shifted away from, in most cases, from smoking, and experienced our own health improved, we understand that a lot of the misinformation that's being given to the public is in fact misinformation. And this is troubling.
Yeah, absolutely. So, well, now that we're in the final day of the Global Forum on Nicotine, I want to ask you guys, before you got here, the theme is tobacco harm reduction, here to stay. What were some of the things you were hoping to see, your expectations? Both of you have been to this conference many times over. Did you have any specific hopes or expectations this year? What will, even if it was personal experiences, people you were hoping to meet, or things that you were hoping would be discussed? And so I can just open it up to either of you if you have, or both.
I would have to say that, it was quite an overwhelming focus, I suppose, on trying to stay well and not catch anything and get sick. So really wanting to be well for being on a panel. And it's such a shock after being locked down for so long in New Zealand, with very strict sort of social distancing, no touching, and it's been very isolating. So I was overwhelmingly looking forward to seeing everybody again and actually being part of the discussion, because you need that. I need to hear from the consumers. I need to listen to them and the other scientists to where is the state of science at? What's the next research priority? What do you guys need, in terms of research? So I've really been missing that, being cut off down at the bottom of the world.
Yeah, I think that's the thing. At a certain point, you didn't even notice it was happening, the siloing, where everything's over Zoom, so you have to be very specific about who you're inviting into your experience, which is very odd now that we're here, and there are so many people I don't know yet, which is meeting new people is kind of novel after a couple of years of isolation. Charles, how about you? What were you hoping for, expectations for this year's conference?
So we held our General Assembly as we used to do before the pandemic, and so now for the first time back face to face. So this has been refreshing. I've had a lot of hugs. And the social distancing is down. Hopefully this is not a super spreader event. And we elected new board members. There are process things that any nonprofit organization needs to do. We were delighted that Dr. Glover could join us and talk about research priorities. And it is our impression that the world, of course, sets research priorities. I think a probably well over half of the tobacco control research in the world is going on in the United States. So that just looms large here. I spent 25 years working in global health research.
You're a
And so
neurobiologist.
I am a neurobiologist by training.
I don't know. You don't tout that quite so much from what I've seen, but yeah, that's an impressive background.
I studied how the brain develops, so it's a developmental neurobiology, so it's somewhat relevant to nicotine. And but I actually ended up working on HIV, TB, malaria, dengue, rabies, and nutrition, child health. These kind of issues were what I was working with researchers all over the world on this, and the process of setting priorities in research has always fascinated me. And of course, I worked at the U.S. Department of Health and Human Services for 10 years, and was heavily involved in that. I've been involved in meetings where we get scientists all together in a room, we talk about what the priorities are, then we rank them, and these kind of meetings influence the priority setting of research funding agencies like the National Institutes of Health or the medical research councils in countries all over the world. It is our impression that the research priorities that the world has right now in tobacco control, they're not our priorities. They're not asking the questions that we would ask. Some are, and there's some overlap, but the voices of people who actually are influenced by the results of the research actually need to be heard in the process of setting those priorities.
So there's a lot of work called research and a lot of papers being written and published in scientific journal articles that is not science. It's what we used to call advocacy research. Papers that are written to push an agenda, to influence policy development. It wasn't developed or designed from a scientific process.
It's not adding to scientific knowledge.
No, it doesn't add to knowledge. It's purely done to show a politician a survey or poll results that, oh yes, the majority support this ban on flavours or this ban on e-cigarettes. So unfortunately, that's a huge problem for science, and not just in the tobacco control or harm reduction sector, and it needs to be addressed. But the consumer, I really think that consumers should be. You need to set your own agenda and write those, and get that published, even if it is as a booklet or a guideline that researchers like Michelle and I can use to guide us and where we're going to go with our research.
There's no question. There's a lot of advocacy-based evidence making going on here. But so the most basic questions, so we know everything about what's happening with teens, for example. But 9 out of 10 people who are using safer nicotine products are actually adults. We know very little about that because it's not the priority for researchers. We don't know, for example, in any country, exactly how many people have actually quit smoking with these things. Now, wouldn't that be the most fundamental question that we would not want to know?
What is the average time of use before you quit, that kind of, before you transition from dual to...
Right. So what we call the smoker's journey, of course it's incredibly complex and it's different for each individual, but across big populations, we can do back-of-the-envelope calculations. We can look at the National Health Interview Survey in the United States, and we see there are 4 million adults who are using nicotine vapes, which is one safer nicotine alternative, who have quit smoking completely. Well, okay, they might have quit smoking in some other way if e-cigarettes didn't exist, but that's 4 million people. But we also know from other evidence, and evidence that's not yet published, which I talk to researchers all the time, about 30% of people who quit with those gizmos later quit vaping. So you have to add another 30% to that 4 million. We're talking a significant number of people. We know the data is much better in the UK. It's 2.3 million adults have quit smoking because of e-cigarettes. So if you add up the US and the UK, which are only 2 countries, it's 7.5 million people, and at least 3 million lives have been saved, in my opinion, because I believe they are, in fact, safer.
I think that the picture in New Zealand is fairly clear. We had 550,000 smokers, and now we're down to 450,000 smokers. And when you plot that decline in smoking prevalence against the upward trend in vaping, and it's like, you know, and that picture, and you can see it with snus and smoking, the effect of snus reducing smoking in Norway and Sweden. In Japan, you can see the same picture. There's a clear picture. Of course, the anti-vaping, anti-harm reduction people are going to say that isn't causal, it's cross-sectional. Yes, of course. But there becomes, you know, it's fairly obvious to people in the public what's happening, we know. So I have a longitudinal study following people who didn't want to quit smoking or believed that they would not be able to, and we're following them over 4 years, in-depth qualitative study. So we are getting the information that we'll be able to plot that, the journey that they went through, what facilitated quitting if they quit, or switching to vaping if they did that. Do they then go on to quit vaping? Or, you know, so we'll be able to plot that, you know, that what could be complex or could be simple, and that transition. And previous research I've done with Penny Truman from University of Massey University and Trish Fraser in New Zealand, we kind of hypothesized, it looked like from what people who vape were telling us, there was an 18-month transition period then from smoking to vaping, but that was back then. And of course, all the products have changed and evolved, and so, you know, the picture could be very different now. It might be faster.
The anti-vaping messaging is shifting now to really focus on dual use. The argument is that most people who are using e-cigarettes remain dual users for an indefinite amount of time. It's usually based on cross-sectional surveys that can't possibly show that. On the other hand, so it's ironic for me to think about this, and for all of us probably, because the dual use is actually extended, it's created by all the misinformation. So obviously, if you believe that this thing is as harmful as smoking, why should you transition completely over?
It's a misnomer anyway to say dual use. Many people use multiple or different, a range of nicotine delivery products. Even a person who smokes in New Zealand and never uses anything else sometimes might use a patch, like when they go on a plane, or nicotine gum. So the dual use label is just that. It is a label. It's a new tool to stigmatize and shame people and demonize. And it's just a strategy they're using. And I would encourage researchers not to use the dual use label. And anyway, what about the other products that they might be using? And in places where you have,
too, right?
Sure. Exactly.
Poly drug use.
Yeah.
Like, what does that mean? Does that mean caffeine and nicotine? Does that mean marijuana and caffeine and nicotine, or just the drugs that you consider to be under this category of drugs?
And from a harm reduction, if you're coming from a harm reduction perspective, you don't call people users,
Yeah, they're people, not users. It's
people who
in the
use,
mental health, in the mental health profession.
People who vape or people who smoke or, people who drink alcohol. You don't go around calling them an alcohol
Drug
user.
Yeah, and that's something in the drugs harm reduction movement people have been very
user.
carefully trying to fix, is saying we're not drug users. They are people who use drugs.
Yeah.
You're not trying to narrow their entire personality and life experience down to the one thing that somebody else cares about, not the person themselves. And I think that's what we're seeing with tobacco control a lot, is how they are so isolated in themselves, partially because they refuse to speak with just consumers, advocates, other researchers that maybe aren't 100% in agreement with them, so that they have very little understanding, I think. They are reliant, if they even care about the data, on data that is usually years old by the time it gets there, and it's not a very broad picture. Whereas a conference like this, one of the brilliant things about it is that you can have a consumer researcher, an academic researcher, advocates, consumers, new junior researchers, which I was very excited to see. I would love to, their experience must be absolutely wild. Just getting into the field of researching tobacco, for whatever reason, choosing to be rebellious and take the tobacco harm reductions, look at it through that lens. And then I think probably surprisingly to discover the controversy when you're entering into the sciences, you think, I'm just trying to, I've observed a phenomenon. I want to now find data to see, but no, it turns out it's very political and controversial.
Of course, many of us, we got into this work because it's about helping people we love to stop smoking, reducing disease and death, and that's the focus for many young people who come into the work as well. Yeah. So to see that that's kind of put to the side, and it's this fight over, no, my ideas are going to win. Not your ideas.
Well, it's prioritization, right? And I think we're seeing that around the world with the American, both researchers and advocacy organizations in America, where, you look at a country like India, and so one of the shocking statistics that I've heard throughout this conference that really, really surprised me, because I first of all didn't realize we had data on it, but just that, in the countries where 80% of the world's smokers live and die, unfortunately, in low and middle income countries, 70% of the smokers have zero access to cessation therapies, products, services, which is astounding. And you would think for those countries, those areas, that should be the number one priority of research, of advocacy. But instead, you have, the ministries of health focusing on things like vaping, which are honestly, in comparison, not a real issue, right? It's kind of like focusing on the flu in the middle of a monkeypox epidemic or COVID, where you're like, okay, I mean, these are all important issues, but why are we choosing to focus on one thing versus another? And so I found, is there anything that really surprised you so far at the conference? Anything you've heard, maybe? And not necessarily data or research, but just opinions. For example, in one of my panel on the benefits of nicotine, I went in assuming at this conference that it would be different from the general population in the belief that there are no benefits, right? That's very common. Most people have fundamental misunderstanding, misinformation about what nicotine is and its risks and its benefits. And I was kind of surprised at how many people here at this conference still believe a lot of the misinformation that they've been told about nicotine and cancer and it not having any benefits other than ameliorating withdrawal symptoms. So that was one thing that surprised me. Was there anything similar?
Well, I was going to say I was surprised that, no, it's not really surprised, but I'm pleased to see that there was more content on looking at the benefits of nicotine and recognizing that people who smoke or vape or use nicotine, that what they say about nicotine is true. They are getting the benefits that when, in their words, whatever they say, it does for them. It does. It does.
An interesting observation that was made by Dr. Newhouse and also Ricardo Pelosa at that meeting was that, obviously everyone is different. So nicotine may help many people, but it won't help everyone. Ricardo talked about how, some people enjoy coffee and get great benefit from it, so they drink coffee. And if they don't want to have coffee and they don't get benefit from it, they don't.
Or they get adverse effects. They have maybe the jitters. They avoid it.
Yeah. Some people are. One thing that didn't come up in that meeting, which might have been interesting, but I think it's a much broader topic. You could have an entire conference on the therapeutic benefits or lack thereof of nicotine. There's a whole community of people who call themselves biohackers.
Mm-hmm. Yeah, it used to be the better living through chemistry folks.
Discussion there is around how do we extend our lifespan. That's one thing, but the other is about increasing your cognitive capacity.
Yep.
And they talk about nicotine all the time. This is I'm alerted to that as a nootropic, which means it enhances, focus, memory, and attention, and we probably ought to reach out to them.
Absolutely. Yeah. And I mean, I think, what you're saying, believe people when they say, I get this benefit, and you'll have some group, I won't name any particular groups, and they will say, yeah, but there's no data on that. It doesn't matter, right? This is one of the things I was talking about. I use traditional medicine as kind of a stand-in for therapies or modes of treating oneself that are not sanctioned by any other authority. Right? So we now have research on the placebo effect, and in the research community in America, anyway, from what they are having a very difficult time wrapping their minds around this idea that the placebo effect has real beneficial effects.
You don't have to medicalize everything.
Yeah, exactly.
You know, are we going to medicalize food? You know, like the effects of this? Well, of course that is happening in the field of nutrition. You know, blueberries are like, you know, you could say there's all of these benefits, you know, physical, you know,
Chicken noodle
Antioxidants.
soup, like I said, I mean, it's a joke, but I would hate the chicken noodle soup, this mother's thing, you know, there's actual studies done where there are benefits in terms of your immune system when you are ill, even if it's, but I honestly think, and this is true, I think of nicotine, how we use it, matters too, not just what we are using.
That's right, yeah.
And I don't even just mean delivery method, I mean the rituals surrounding it, right? Where, for example, with wine, people who are moderate wine drinkers tend to have better cardiovascular outcomes over the course of their life. Not binge drinkers or heavy drinkers, but moderate. But moderate drinkers who report primarily drinking moderately with friends have even more benefits. So like, that's not medicine, you know, that's not a doctor-prescribed drinking session with your buddies, but that's those things that are hard to quantify in your life that comprise your life have health effects.
But that kind of research is reductionist, just looking at one element out of somebody's life and not taking into account confounding factors. It could have actually been something else, you know, sitting, having a drink of wine with a friend or your partner at the end of a stressful day, and it reduces your stress.
Exactly.
That's what was giving you the health benefit, you know, not necessarily drinking the wine. So this continuous, you know, trying to pin it down to a substance, or
in order to decide, shall we tax or ban this or not, right? That's what we're doing with nicotine. You know, we're saying there are benefits, and one of the reasons we're saying that is because it's true and it should be studied, but also because we're trying to say, don't ban it. And that's, honestly, that's BS, that we have to make that argument, you know, to say, you know, well, we have to pin it down to this one thing. We have to show you it's 100% effective and 100% safe before you will allow people the right to make these decisions, these informed decisions for themselves.
Or just listen to people and understand the context of their lives, the stresses and challenges they're facing, and why they do what they do in their own words and why they say that, you know, instead of trying to reduce it down to it's because they do this or they use that, rather than, hang on a minute, what about all of those determinants, the poverty or the bullying at work or the...
Or the empowerment idea, right? You know, when you have the caretakers, whoever it is, whether it's the Campaign for Tobacco-Free Kids, well, you know, whether it's the Truth Initiative or, you know, this idea that somebody else is responsible and you are beholden to them for your health and your knowledge, just about how to improve your health, how to achieve wellness, is depowering. And that in itself has a lot of other effects throughout your entire life and on your health, mental and physical.
Yeah.
One of the most damning things that we can say about the field of tobacco control is that exposure to messaging from this field over many decades leads to a public that is less well-informed, less accurately informed about the facts. So, for example, we talked in that session about the very high percentage of physicians who believe that nicotine causes cancer or heart disease or lung disease. It's 80%. 80% of American doctors, so 4 out of 5 American doctors are that profoundly misinformed. The public is also misinformed. When smokers are misinformed about the relative risks, then they're more likely to remain dual users. They're less likely to try a safer alternative and quit and save their own lives. So this session was wonderful. I hope that we see more of that. We talked about nicotine almost certainly has a positive impact on weight control. And we do have an epidemic of obesity in many countries, including among children.
And interestingly, like the obesity epidemic, obviously obesity has a lag period, but you know, it started to increase, it was already increasing, but it increased continuously at the same time as smoking, because people were learning about the harms of smoking were decreasing. And it seems almost guaranteed that there's some relationship there.
Yeah, there was a study, they estimated it was about 14%
Really?
The reduction in smoking in the US contributed 14%
That's
to that
actually a lot.
rise in obesity. So it's recognised that there is research on it.
And on that
But it's
note,
not
I think
just
we
the
have
U.S.
to
that
wrap.
problem.
No, of course not.
It's also in low and middle income countries. In India, the obesity rates are increasing dramatically. So it's not just, the wealthy, fat,
Interesting.
rich
Yeah.
people.
Yeah.
But
And on
at
that
the same
note,
time,
I mean, I would
go
love to continue this conversation. I thought 20 minutes a long time, but honestly, it went by super fast. Thank you guys so much for being here and enlightening. And I'm looking forward to seeing everybody at the rest of the conference. Thank you very much.
welcome to this very first session of the last day of the conference. So my name is Kasia Kowalczyk, and I'm going to be the host of today's session. So joining us, there are two Marks. Mark Tindall will join us virtually, and Mark Oath will join us physically. So first, Mark Tindall will deliver the lecture at the keynote, Contradictions in the Health Debate Around Vaping, and then we're going to pass it to another Mark who will give response to that, and then we will have a time for Q&A. So I assume that for many of you, Mark Tindall does not need an introduction, but bear in mind that there are people in here attending GFN conference for the very first time. So let me just briefly introduce Mark to them. So epidemiologist, physician, and public health expert, Dr. Mark Tindall was an early advocate for harm reduction programs. He was at the forefront of North America's first legally sanctioned supervised injection facility established in Vancouver in 2003. Since then, multiple studies have shown that safer injection sites saves lives, reduce transmissions of disease, and help people access addiction treatment and other medical services. As someone who had led the opening of these facilities, Mark is used to working in areas of public health that generate headlines. And we all know that tobacco harm reduction and vaping is particular to that. So, Mark?
Great. Okay. Thank you very much, everybody. I hope you can see and hear me. I guess I'm on a big screen somewhere in an auditorium. I'm talking to you from Vancouver, Canada, and it's 1 o'clock in the morning. So it's really my pleasure to present at the conference. I was last in Warsaw in 2007 at the International Harm Reduction Conference when Jerry Stimson was the executive director of the International Harm Reduction Association. So Jerry and I, if nothing else, are persistent. This year's program is full of people who are very articulate and very knowledgeable about tobacco control, nicotine, and harm reduction. The conference features some of the world's leading experts in these areas, and I am really missing out by not being there in person. I do feel some pressure to add something new and provocative to the proceedings. I plan to focus on some of the contradictions in our response to cigarette smoking, the title in the program, but I want to draw on lessons learned from HIV and how the debate around vaping is really based on fear, blame, and stigma. Can I see my slides there? Great. There we go. I wanted just to put up my conflict of interest slides. I'm very committed to promoting safer nicotine delivery technologies for people who are dying because of cigarette smoking. I have a long history in public health, and I've come to understand that making effective policy decisions means that all stakeholders must be at the table, even if you don't like what they're doing. I believe that we must engage with vaping and tobacco industries if we are serious about phasing out cigarettes. I'm happy to lend my expertise and have consulted with the Vaping Industry Trade Association in Canada, the Canadian Vaping Association, and more recently, Rothmans, Benson, and Hedges. I don't represent these organizations, and the views expressed today are totally my own. So I really want to focus a little bit at the beginning of my comments on HIV. I've said many times to people that my involvement as an advocate for vaping and safer nicotine products have been largely accidental. My career has really been about HIV prevention and care. I started medical school in 1982 when cases of a strange new disease were being described among gay men in New York City and San Francisco. And over the next 40 years, I have had a front row seat as the AIDS epidemic ravaged the world, or rather ravaged specific communities. Fear and blame have dominated the response to HIV, and this has caused so much unnecessary suffering and has cost millions of lives. In the 1980s, it was the 4 H's, homosexuals, hemophiliacs, heroin users, and Haitians, Haitians represented poor Black people around the world. I saw the impact of fear, blame, and stigma on these communities firsthand. I provided care to some of the early cases of Kaposi sarcoma and PCP pneumonia among gay men in Canada. They all died, mostly alone. I've worked extensively with people who inject drugs. In Vancouver, we watched as over 30% of all drug users became HIV positive through sharing needles. Because of prohibition, many people existed outside of the medical system, and even if they did seek medical care, were refused treatment. Many died, again, mostly alone. I provided care for young men attending a hemophilia clinic at McMaster University. All died, mostly alone. And during the early 1990s, I spent 4 years in Kenya working at the largest STD clinic in Africa when people with weight loss and diarrhea were told to go home and not infect other people before they die. They were feared and despised, and so many died, and again, mostly alone. Things are better now. Treatment is widely available, including for people living in poor countries. The blood supply is safe, HIV awareness is high, and people have tools to protect themselves. There has been good progress in the rights of the LGBTQ communities, at least in some countries. Progress has been very much slower for people who inject drugs. Treatment is now easier to access, but I know even in Vancouver, for example, less than half the people who are actively using drugs are taking antiretroviral therapy regularly. It should be noted that this progress has taken 40 years, and some of the gains that have been made are precarious and currently under threat. Now imagine the world's largest preventable health epidemic that kills or seriously maims almost all of its victims, takes at least 10 years off your life, and has an insidious onset that lulls you into complacency before it's too late to turn back. I am not talking about AIDS, I am talking about smoking. Now, we don't usually consider cigarette smoking in the same light as HIV. Obviously, a cigarette is not a virus. But from a purely public health angle, the number of deaths over the past 40 years from smoking has far exceeded the 40 million people who have died of AIDS. In fact, it is estimated that 8 million people died prematurely from smoking on an annual basis. So that would be 320 million smoking-related deaths in the same time period. We think of untreated HIV as a death sentence, and over 90% of infected people will die prematurely. But premature deaths from smoking are also incredibly high, at around 60%. The actual course of illness is not that dissimilar. HIV infection usually occurs without any major symptoms, and the progression is slow and relentless. Compared with smokers, people with untreated HIV may die a bit quicker, but decades of good health are lost in people who smoke cigarettes prior to an early death. Fear and stigma remain high for people with HIV, despite being around for 40 years. But fear and stigma for smokers is also quite high. And speak to anyone who smokes, and they will give you stories of abuse and ridicule from complete strangers. The populations impacted are similar. It is an overgeneralization, but it is the poor, marginalized, and minority groups who are most impacted by HIV and smoking-related diseases. Tobacco control programs have lost sight of the fact that smoking is really an issue of health equity. Effective treatment is by far the biggest breakthrough in HIV and has saved millions of lives. Modern treatment is effective in 95% of cases. Interestingly, that is exactly the same as the estimated effectiveness of vaping for people who smoke, according to Public Health England. A cure for smoking. No need to continue with my talk, and I guess there's really no need to continue with the conference. But wait, the big difference is the uptake of treatment. Through massive efforts and investment, it is estimated that over 80% of people with HIV have access to treatment, compared with less than 1% of people who smoke cigarettes. This lack of access could be described as a type of structural violence. Now, Our approach to all substance use is really described by structural violence. Paul Farmer, a medical anthropologist who I have so much respect for, died in February of this year while working in Rwanda. He often spoke a lot about structural violence and HIV. The definition he used was structural violence is a way of describing social arrangements that put individuals and populations in harm's way. The arrangements are structural because they're embedded in the political and economic organization of our social world. They are violent because they cause injury to people. It is easy to recognize structural violence in the war on drugs. We deny housing, safety, and health because we have created a situation where people are forced to use drugs that are illegal, making them criminals, and basically excluding them from society. Now criminalized, we can waive compassion, empathy, and support because people are doing something illegal. The only option for them is to stop using drugs, but it is often too late. We have justified destroying people's lives because we don't like the drugs that they take. These are pictures from Vancouver, where I work, but these scenes can be found in cities around the world. This is the carnage left by the war on drugs. Now, for smokers, our approach to exclusion is a little more subtle. We are so used to no smoking signs everywhere, we are numb to them. However, they are clearly designed to exclude and shame people. There is really nothing like it in all of public health. What is fascinating is how quickly the signs were updated with no vaping, based on nothing. There is no evidence of any secondhand vape risk, and people can vape nicotine without producing any vapor at all. Someone made a lot of money making all these new signs. We have even created dual smoking vaping areas. It makes absolutely no sense to force people who are trying to quit smoking to congregate with people who are smoking. But structural violence around smoking goes further than the signage. We have created a narrative around smoking restrictions that know no bounds. Much of this is based on an exaggerated campaign of fear around secondhand smoke exposure. Now, I'm not suggesting that we roll back all of the restrictions on where people can smoke cigarettes, but there are unintended consequences. I view these scenes differently now. People crammed into an airport cage, employees huddled outside a building in the cold and rain, and patients standing around the hospitals with IV poles. We can do these things to people because we have become very comfortable with vilifying and shaming smokers. In 2007, the province of British Columbia announced a smoking ban in all hospitals. I was working on a ward of 24 beds that only admitted people who were HIV positive, and most had become infected through injecting drugs. Everyone smoked, and all used the smoking balcony at the end of the hall. I remember that people in my care just started leaving the hospital against medical advice when the new rule was enforced. 15 years later, by far the most common reason for leaving hospital against medical advice is because of the no smoking policy. I have watched as people with endocarditis, spinal abscesses, advanced HIV, and other life-threatening conditions just leave the hospital. I can only imagine how many people avoid hospital care altogether because they will not give up their cigarettes. This policy has directly led to the death of countless people who needed hospital care. This would be the definition of structural violence built into our no smoking policies. This brings me to packaging. Would we put this sort of messaging on boxes of breakfast cereal to discourage childhood obesity, or wine bottles to discourage alcoholism, or car showrooms to discourage reckless driving? Of course not. It would be considered offensive and insensitive. But for cigarettes, anything goes. What are we trying to say with these images? That you are hideously ugly? That you are killing your baby? or that intergenerational smoking is inevitable. These are disturbing images, and I guess that is the point. But how cruel and stigmatizing can you get? And these messages don't even work. There is a campaign to educate Canadians about drug users with the stated goal of reducing stigma. This is another major contraindication, as at the same time, the government actively mounts an aggressive pro-stigma campaign for smokers. This is the latest bright idea, labeling individual cigarettes. Canada is proudly announcing that it will be the first country in the world to do this. By their own estimates, it will have a very limited impact on getting smokers to quit. They know that shaming people doesn't work, but they also know that this is politically popular with the 85% of the population who don't smoke. We understand that it's difficult to quit. We know that people become dependent on nicotine. We have a pretty good idea of how nicotine works. We even know that the majority of current smokers would actually like to quit. So what is this label trying to accomplish? We might as well tell people that they are idiots. We have taken this approach to the prevention of vaping among young people. Only in this case, the anti-vaping crusaders have suspended any sort of reality in their campaigns. It is just pure science fiction. Reprogramming your brain, having aliens crawl under your skin, creating a whole generation of addicts. It is embarrassing for public health organizations that these campaigns actually exist. Unfortunately, this disinformation campaign has worked quite well. This recent study shows what success looks like. Just 10% of people thought that vaping was less harmful than smoking. This is astonishing. 90% of people either don't know or are completely wrong. In fact, 30% are really wrong and thought that vaping was more risky than smoking. It would be like 30% of people thinking that eating a dozen donuts was healthier than eating a plate of vegetables, or that jumping out of a third-story window was safer than taking the stairs, or that getting a COVID vaccine was more likely to kill you than getting COVID. Okay, so that did happen, but the other extremes are obvious. But anyways, the point is that a massive campaign has been orchestrated to deceive the public, including people who smoke. With this disinformation, it is amazing that anyone has switched to vaping. I hear all the time from my medical colleagues that if vaping is such a good way to quit smoking, then why don't more people do it? Well, because you have been lying to them, that's why. It's the people that don't listen to you that are successful. And you can't make this stuff up. This disinformation campaign is global. On May 31st this year, on World No Tobacco Day, the WHO did not even mention vaping or other safer nicotine products in their press release. Did not even mention it. It's stunning. India received a medal from the WHO for banning e-cigarettes. Mexico just banned e-cigarettes, banned them outright. Along comes an intervention that allows people to enjoy nicotine but won't kill them, and countries ban it. Calling this a contradiction is inadequate. It is insanity. This is a very popular graphic, but it deserves repeat showing. Prohibition doesn't prevent drug use and sets in motion a horrible cycle of health and social misery. Mexico, of all places, should definitely know that. Has the president not watched Narcos on Netflix? There was a whole season just on Mexico. Prohibition is a very bad idea. I am sure that cartels are already manufacturing e-liquids and defective vaping devices. What an opportunity. Compared with the relatively limited customer base for cocaine and heroin, the potential for illegal nicotine seems infinite. There's another contradiction for vaping and safer nicotine products, and that is the tobacco industry. Really more like a tragic irony than a contradiction. We have a technology that is a major threat to traditional cigarettes, and governments and public health organizations are actively trying to prevent it from happening. The tobacco industry has a long history of deception and denial and continues to make massive profits despite the devastating health and social impacts of cigarettes they produce. The global promotion of cigarettes has led to the continued growth of cigarette consumption. Many countries lag behind the necessary marketing restrictions laid out by the WHO and other tobacco control organizations. Despite this history, the relationship with tobacco companies must be reconsidered with the introduction of safer nicotine products. It is now counterproductive to isolate tobacco and vaping companies from tobacco control conversations when they are changing their business models to promote innovation and safer nicotine products. Most of the major companies have invested heavily in new technologies and are pursuing strategies that will phase out combustible tobacco production. Without their collaboration, the transition away from combustible tobacco will be much slower or may not happen at all. There are many examples where companies who produce dangerous products are seen as part of the solution. We know that oil and gas companies must change their business model in order to reduce global warming, and governments are eager to support their transition to less carbon-intensive production. Car manufacturers that contribute to air pollution and climate change are being incentivized to manufacture electric cars. Forestry companies who are destroying critical forest habitats are being incentivized to pursue sustainable forestry practices. These transformations would never happen if we simply stopped talking to the companies who are causing the harm. In the bigger picture, we should be working with poppy producers in Afghanistan and coca farmers in Colombia to develop a regulated legal market for heroin and cocaine. But that's for another talk. I want to touch on human rights and nicotine as another contradiction. I know that this is a theme at the conference, and there's a panel discussion following this talk. We are fighting for people who don't have a voice, for those who are dying from cigarette smoking. Now, it is complicated because these are people who like smoking cigarettes, and we don't feel overly compelled to fight for their rights to smoke. Many smokers have long ago decided that it is worth it. Like other people who use drugs, they will do this until there is something better. Maybe not healthier, not slicker, not even cheaper. They will switch when there is something actually better. Before vaping and safer nicotine products, it was unlikely that they would find something better. Now they can. There's a great scene from the 1996 movie Trainspotting where Ewan McGregor sings "Choose Life." Choose life, choose a job, choose a career, choose a family, choose a fucking big television, choose washing machines, cars, compact disc players, and electrical tin openers. Choose good health, low cholesterol, and he goes on. Then he says, I chose not to choose life. I chose something else. And the reasons? There are no reasons. Who needs reasons when you have heroin? The point being that people do have a choice, and they may choose not to conform with your ideas of a good life. Ultimately, smokers have a choice. It is their right. In every aspect of public health, empathy, support, and connection works far better than shame, punishment, and isolation. This Support Don't Punish campaign was launched in Canada to advocate for harm reduction. I have seen this approach work throughout my career. The basic idea of harm reduction is not laying the blame on the person who is suffering. People with drug dependency need empowerment, need to build self-worth, need to be supported. They already feel defeated and worthless. Why would we ridicule, shame, and punish people who are struggling? I have seen people recover from their addiction. I have seen people reduce and eliminate their drug use, but it was never because they got to a point where they were shamed out of it. Shame makes people use more. So where do we go from here? I've created an advocacy ladder, still a work in progress, but it captures my journey from a researcher, medical expert, to a translational researcher, to an advocate, to an activist, and sometimes I get very close to the top rung of this ladder. I do recognize that it takes people on all the rungs of the ladder to make change, and not everyone needs to climb up a level. But I can tell you one thing, the higher you go, the more fun you can have. Thank you very much.
I would like to say a few words from myself. So as someone who does not work in tobacco harm reduction, the things that I have heard over the past days about the level of division and polarization and violence experienced by some working in this field has shocked me and frankly speaking quite scared. But I'm qualified crisis interventionist and psychologist, and I spent much of my career working in this area with people living with obesity, and I've never heard a person saying that yes, being stigmatized actually helped me to deal with my problems. So yeah, but Mark, so now for our first reaction, we're gonna go to you, please.
Thank you very much. I just want to pick up on that point about stigma, because it's so pervasive across society, and particularly around public health and the work I do in public policy. I've lost, when I was in Parliament working there, if a load of puppies came along from the Royal Society for the Blind, every MP and his researcher would be there. But if anyone wanted to discuss the biggest killer in the constituencies of these MPs, they had very little to no interest. But it's also something that is pervasive, this stigma, for smokers themselves. A lot of them are very embarrassed about being a smoker, and that leads on to people who choose reduced-risk products. Like myself, I'm proud to say that I enjoy nicotine, and I've got no plans to stop using nicotine. I use it in a very safe way, and quite frankly, there's other activities I do, such as in the winter throwing myself off mountains, which probably carries a far greater risk. But no government's telling me not to do that, and there's no regulation really around it. I got to be honest, I don't think I was really fully aware how much stigma there was until last September. I was doing what Mark Tindall would call, I think, being a shit disturber. I was on the south bank of the River Thames, and me and some vaping mates had managed to beg, borrow, and steal a van, a generator, and a huge projector with size of the Hadron Collider, and we were projecting onto Parliament, right by Big Ben, an image of Boris Johnson vaping, calling on him to back vaping at COP9. Now, it caused a bit of trouble because some media outlets actually started reporting that Boris Johnson is a vapor. I can't confirm whether he is or not. We actually photoshopped the image. Shows how good the media are at catching up on misinformation. But I can tell you that Boris Johnson likes to party, so maybe he's vaping at those. But I obviously invited some journalists and media to come, and one solitary photographer came, and I did my best. I told them about the campaign. I said, this century, 1 billion people are going to die from smoking. It's the biggest cause of preventable deaths. That if you combine the number of people that die from hepatitis, from malaria, HIV/AIDS, it's less than will die from smoking. I did you proud. I thought no one can argue with that. But his response was, that's different. They did it to themselves. it's their fault. And maybe I was naive before, but I was pretty shocked. And at the time, I was watching a TV program, which I'd implore you all to see, called It's a Sin, a Channel 4 program about the HIV epidemic in the 1980s. And I obviously wasn't around that time. So it follows a story of young men in London who are doing what all young men and women will do, which is chase pleasure, which humans are designed to do, just as when I throw myself off a mountain. And obviously, the result is, sadly, because of poor information, because of stigma, one by one, they get ill, fall away, and pass away. And I think, ultimately, we're in the same situation when it comes to tobacco. And luckily, we've moved on from that situation. But I think we need to change minds and hearts if we're going to have any hope of reducing the number of deaths worldwide from smoking. And I think a really stark example of how this affects our public policy is international development. Britain is one of the biggest spenders per capita on international development, quite rightly. And we spend money on reducing deaths from malaria, HIV/AIDS, malnourishment. But we don't, as far as I can tell, spend a penny on trying to reduce deaths from smoking. And the truth is, the only reason for that is because they see those deaths as lesser. And I can imagine the headlines from the Daily Mail if, we started spending money on harm reduction. But sometimes a good leadership means doing the right thing, even if at first people don't understand that it's the right thing to do. These contradictions go elsewhere as well. Around the time I put the projection of Boris Johnson up on Parliament, an MP asked the government in Britain whether at COP9 they would take a harm reduction approach and support harm reduction at COP9. The government's response was that they wouldn't take a harm reduction approach, but that they would tell COP9 delegates about the role vaping has played in reducing smoking rates, which to me says that the government understands that vaping reduces smoking rates, but it doesn't understand why vaping reduces smoking rates, which is the philosophy of harm reduction. And this has an important impact because not only if Britain doesn't take a harm reduction approach to tobacco, will we be unable to ourselves to reach smoke-free 2030, because we won't be using the opportunity that snus offers, we won't be using the opportunity that nicotine pouches offer, we won't be using the opportunity that heat-not-burn offer, but also it's going to have a real long-term damaging effect on the very countries in the lower middle income countries, because we know that vaping is more expensive than cigarettes in these countries. Britain has been successful because, partly at least, the price elasticity of demand means that people are going to be willing to choose vaping, which is cheaper than smoking. But that doesn't exist in a lot of developing countries. So we need snus and we need nicotine pouches, both to play a role in reducing the billion people that will die by 2100. And I'm afraid that there's failings there in Britain, and there's a huge failing in Sweden, which has been sitting on an absolute gold mine, the ability to reduce deaths worldwide. And weirdly, they have this attitude of, well, we managed to reduce our smoking rate, but don't do what we did. And finally, we have another contradiction, which I just want to come on to, which is around snus, which in many ways is my first love. I switched onto Swedish snus when I was flying home from China after smoking 50 pence a pack cigarettes, and picked up some snus and thought, this is absolutely marvelous. But the British government was complicit in keeping me smoking because I couldn't get hold of snus in the UK. So I'd flipped from getting hold of snus on the illegal market and then smoking, then back to snus, then smoking for 5 years, until eventually I got over my fears of switching one addiction for another and I started vaping. I was very young. But the British government now have said in parliamentary questions that they recognise that snus is far safer than smoking. Yet they do not want to legalise another tobacco product onto the market. And that for me is, I want to take the government to court for that. You're denying an opportunity for people to vastly reduce their harm. And it's baffling. And I just want to, I don't know if Deborah Arnott's watching from ASH, but she says the reason why Britain shouldn't legalise snus is because we have nicotine pouches already. And I can tell you as a snus user, nicotine pouches and snus, they're both fantastic, but the way the nicotine goes into the body is slightly different. And there's another thing that's really important, which is called choice. And the beauty of harm reduction is you leave it to the consumer to choose. And I've been doing some studies of some of my members, and we talk about hierarchy. And some people put snus as number 1 on the hierarchy, and then number 2 is smoking, and number 3 is nicotine pouches. So if you remove the top of the hierarchy, you're left with number 1 being smoking. So I'm very supportive of nicotine pouches. They can do a great job, but just because they're both put into the mouth in the same manner doesn't mean they're the same product. And we need a smorgasbord of options if we're going to achieve what we're all here aiming for, which is to vastly reduce the biggest killer on this earth.
Thanks. So, Mark, the other Mark, yeah? Would you like to comment on this?
Sure. I mean, the stigma part of things is what I was trying to weave through my talk, and how real that is. As a harm reduction person with other drugs, the beauty of the vaping is it is much like the experience people have with smoking. So that the closer you can get to what people are used to, the more likely people will transition. So these other, I think, as far as a choice is super important, but the idea that people can transition quicker from smoking to vaping, or maybe even heat not burn would be even in between there. That's more like what they're used to, I think, is the beauty of what we can offer for substitutes for cigarette smoking, as opposed to, for years and still, all I have for people who want to reduce their opioid use is methadone, which is a far cry from the experience people are getting from their heroin or their fentanyl now. So that's taken me to what we're doing now for other drugs. For opioids, we're actually giving people pharmaceutical opioids, because it's better than the fentanyl people are buying on the streets. It's much safer for them, but it gives them a similar experience than they would from the illegal market. And then you can start, working down to methadone. But often we have our harm reduction ideas upside down. Like, we start from something that's nowhere near like what people are experiencing, such as a nicotine patch. And then if that doesn't work, then we kind of work up. But we should be doing it totally the opposite. The best thing that is for you right now is a substitute or a transition that's much like the experience you're getting right now with cigarettes. And then we start moving back if that's what people want. But I think that's a general principle of harm reduction, to meet people where they're at and try to offer an experience that's much the same. And vape, I'm not a vapor myself, but I've talked to a lot of people that are, and for a lot of people, the experience with vaping is superior to cigarette smoking because of flavors and the nicotine concentrations that they can select, and just the convenience of it. So it's really, from a public health point of view, you could not have devised anything better as far as following the harm reduction principles than vaping. So
I think we might start Q&A part. So if anyone would like to ask a question or make a comment, please raise your hand. Marua, I'm gonna give the voice to you. Just one information for those who are watching us online. You can also place your questions in the Q&A area. So Marua.
Thank you. Thank you for that great talk, Mark. Both Marks. Mark too. No. I'm Mārewa Glover from New Zealand. I've worked in tobacco control for 30 years, and I just wanted to reflect on and maybe give you some insight into the development initially of these very stigmatizing, shaming campaigns. So in the 1990s, we would go to politicians and try and get more funding for tobacco control and our anti-smoking ideas. But there was lacking support in the public because people cared for their loved ones and friends who smoked. They understood why they smoked. So it was hard to get public support. So what we had to do, and these campaigns initially, of course it was said that they were aimed at people to develop, to increase their cognitive dissonance, and then the more that they would feel uncomfortable with and feel shame about smoking, then they would quit. But they were actually designed to incite hatred towards people who smoke, to destroy the compassion that people felt for people who smoke. And having achieved that, having succeeded very, very well at inciting hatred towards people who smoke, we can now do anything we want to them. We can remove the nicotine from combustible tobacco. We can fine them. We can imprison them. We can give death sentences. We can do anything we want. The public does not care. Not that they don't care. They want us to hurt them. They have no compassion. Don't give them vaping. Don't let them have access to something that will help them stop smoking. They deserve to die. This is the way people in tobacco control talk at their conferences, in their papers. And they want the public to do this. And someone was telling me a story, about Hitler and the Jews. This is the same strategy. So those campaigns were not aimed, that's why they don't work, because they were not aimed at people who smoke. They were aimed at everybody else. Thank you.
Thank you, Maria. Any comments?
Well, I think that's really interesting about the rejection of being told what to do, because I know I'm certainly one of those people. And my father used to smoke, and the day that he smokes every year is National No Smoking Day. It's interesting about the Jews and the Nazis, because there's a level of compliance there, and obviously the smokers aren't compliant people. So no, it's deeply worrying. I want to attend one of those conferences where they're like that. I would really like to, be a shit disturber there.
Thanks. Some more questions and comments? Oh yeah, I can see. So first, sorry, I need to stand up because I'm blinded by the light. So the lady there, and then Will, I think I see.
Good morning, colleagues. My name is Tindall. I'm from South Africa. And the research that I did in 3 drug-resistant TB hospitals resonate well with the presence of stigma. It was so difficult for me to get smokers to participate in the study. At first, they thought maybe I'm from the government, and I will identify them, then they will not have access to TB medication anymore, because they knew that smoking is not allowed. So I ended up using the snowballing technique, where, I would privately speak to smokers, and they would see that I'm not from the government, I'm not from the police, and they were happy to let me speak to their friends that smoke. And the stigma they faced in hospital was so bad that they had to, hide sometimes when they smoke. So what I want to say is, while we have policies on tobacco control, they should be accompanied with support. And patients felt that if they can't smoke, they need something to replace smoking with, because they have addictions, so there's that craving for cigarette that they really can't do anything about until they get something to smoke. So it was really amazing to see how much it affects them. I've never been a smoker, so others had to ask me if I've ever smoked. And they were thinking that, it's people like yourself, like me, who do not understand how we feel about it. And others were happy with smoking as a coping strategy for various reasons. So what I would like to propose, as we are all gathered here as different professionals, is that in order to show harm reduction, tobacco harm reduction in the products that are being invented every day, could harm reduction also be part of interventions where there's an opportunity to reduce smoking or to reduce harm? For instance, patients who are admitted because of TB infection, those with respiratory diseases, those with chronic diseases, there could be intervention programs for them, and any other institutions and organizations involved in tobacco harm reduction could be part of that as evidence, because when it comes to politicians and other professionals, the war against harm reduction, they say it's because there is no evidence. So to them, it's still getting people to smoke in a different way. So in order to show evidence, could the campaign on tobacco harm reduction also feature in interventions, within sectors like hospitals where inpatients could be followed up? I've seen a number of studies where they do cotinine testing and get into other means of supporting patients, although it's not sustainable, to be quite honest. And I'm happy with the question on equity that came up. As we get involved in tobacco harm reduction, there is quite vast population in developing countries that is being left behind, and truly that they cannot afford the products. So maybe that could be considered in the future. How could they have access? Because to be quite honest, our government are burdened with so many other issues: health, socioeconomic circumstances, and say violence, crime. So when it comes to budgeting, it becomes next to impossible to be accommodating all other health promotion, harm reduction initiatives. And so I hope that in the future there could be consideration on making sure that even those from low socioeconomic backgrounds could access harm reduction initiatives and products, information, even in their own languages as well. But the specific one is they need practical assistance to stop smoking or to reduce smoking. And if it's too expensive for them, they tend to resort to more dangerous means of sustaining the craving. Thank you.
Thank you. I know that the theme of this session makes us just prone to share us with our statements and comments more than asking questions. So let me, because I can see there are plenty of hands. I think I've promised it to Will.
Hi, Will Godfrey, Filter Magazine. Despite the very clear parallels between tobacco harm reduction and other areas of drug policy reform and harm reduction, which Mark Tindall has just outlined so excellently, it seems to me, in covering the North American movements, that engagement with THR from these movements is somewhat limited, with the exception of some powerful voices like Mark, like Ethan Nadelman and some others. It's sometimes lukewarm, and indeed we even sometimes hear examples of hostility, such as syringe access programs with anti-vaping policies. So my question for Mark Tindall is, how receptive do you find your colleagues in drug harm reduction to tobacco harm reduction? And do you think that there are good prospects for improving integration of THR into wider harm reduction?
Yeah, that's a great question. You might see the brick marks on my head from banging my head against the wall repeatedly with my colleagues who, fully are on point with just the basic stuff of supervised injection sites and needle exchanges. Is just so obvious. But yeah, they draw the line at tobacco harm reduction. They are not generally supportive. I can't understand really why. I think what was talked about earlier, just the deep stigma and the fact that people should just quit cigarettes. Like, they don't really see the need for harm reduction because it's just so obvious that people should just stop smoking cigarettes. And so it is very frustrating. And I am often on my own in group meetings around harm reduction when I've said, we can't, everybody who comes into hospital should be offered vaping product, and they should be able to use them in the hospital. Like I think the UK has some programs like that, but Canada is so far away from that. And people who, and the other, so in answer to your question, it hasn't happened, and I haven't been made much progress with most of my colleagues. And the fascinating thing is that this is, people will die of their smoking, and the other harm reduction stuff we're doing is saving them from their HIV and their drug related things. But we're quite happy to watch people just chain smoke themselves to death, and it's very frustrating.
Thank you. It's really hard to pick. Could you please, as well, say your name and where are you from? That would be helpful, because at least I'm still learning.
Hi, I'm Bengt Wiberg from Sweden. I'd like to make a remark to Mark here. In 1.5 years ago, the European Tobacco Harm Reduction Advocates made the biggest nicotine survey so far, I think, in the world. We had 35,000 respondents from EU nations, whereas those several thousands of them were smokers. And when asked and 60% of those smokers said they wish they could quit smoking. 30% of those said we would be willing to try snus if it was available. I just had a revelation last night. I was watching the Swedish foreign minister on Polish TV saying that, of course, Sweden will accept Moldavia and Ukraine as EU candidates. That is very fine with me. But looking back, you probably all heard that Sweden and Finland is asking to join NATO. So why are we not members of NATO? Because Turkey has a veto right. Turkey wants something. So here's where we're going. If Sweden, to make a decision in EU, for example, to allow Swedish snus, Sweden vetoes a decision which is important for EU. We could then do like Turkey. Please allow snus. We have the lowest smoking prevalence in the European Union, and we have the lowest frequency of all tobacco-related cancer disease. So, Mark, can you remark? What do you think about the idea?
Well, from a real politic perspective, I don't know that Sweden would be gaining much out of it, because they're trying to help other people, and we all know governments tend to act in the self-interest to themselves to try and get re-elected rather than improve other people's health. But I just want to pick on the point you made about the survey. 30% of the people that wanted to quit smoking would try Swedish snus on the ETHRA survey. And I think that's really important because in the UK that translates to there's about 50% of people who smoke in the UK want to quit smoking, and then 30% of them, it's around 1.2 million. So there's a real opportunity there for something different, because I don't think vaping can carry the can all by itself, and I really enjoy vaping. But Mark Tindall, I want to say, is absolutely correct. As a smoking cessation tool, it's far closer. But then I think we're missing out a huge chunk of people that would otherwise be interested. And I've done the calculations. If you had 1.2 million people interested in snus or nicotine pouches, the big problem we have in the UK with Heat Not Burn is because it contains tobacco, you can't advertise it. So no one knows Heat Not Burn exists. I think there's probably only about 50, 60,000 people using it in the UK. But if you look at Japan, whereby it's much more virulent, you've got millions of people using it. And I reckon if more people knew about Heat Not Burn, because what it does do is it it finds a type of person that doesn't like vaping, they prefer smoking, and heat-not-burn is closer to smoking. You probably get 1.5 million people using heat-not-burn. So we're already on 2.7 million people. And then finally, you've got 56% of smokers in the UK either think that vaping is as dangerous or they don't know whether it is. And there's a very convincing study that suggested for every 1%, that led to a 0.7% reduction in number of people vaping. So you're looking there at about 1.5 million people. So right off the bat, you've just hit, in one day's policy maneuvers by us all here today, you've hit like, what, 3.7 million people quitting? And I think the point is that it's not going to happen just by sitting on their hands. It actually takes policy changes and actions that the government needs to do. And frustratingly, they don't see that as a big win. But that leads me to ask the question, why do you get involved in politics if you don't want to actually improve the lot of man?
Thanks. So you sir, you wanted to ask a question? Yeah, and then you, sir, in red vest, I've noticed. I'm just trying to manage.
Hi, it's Andrew Manson from Helpful Consulting UK. I just wanted to put a question through, it's a question and a statement through to Mark. I mean, should we change the conversation a bit around, instead of quitting smoking, just understanding that consumers will continue to use nicotine in the same way that consumers will continue, or people will continue to use alcohol, people will continue to use psychoactive drugs. And the acceptance of that around public health is what we need to establish. And once we establish that, then you can say, we need to offer safer alternatives. Because at the moment, the perception is, you know, people want to quit smoking, and it's the nicotine that keeps them smoking. Whereas there was a session yesterday, a very important session on the benefits of nicotine, and some people derive clear benefits from nicotine, and particularly those benefits are exacerbated with socioeconomic disparities, where nicotine helps many people to get through the day and get through life. We need to accept that, and then governments hopefully would be understanding that we need safer alternatives.
Mark?
Yeah, I think, I think that's a huge obstacle when we're still stuck with governments and many public health people saying that people should just quit using. And so we have not accepted that people will continue to use these substances. I mean, and we have, in some respects, in other drugs, accepted that, okay, people are going to continue to use these. We have to try and give them in a position that makes it a bit safer. But yeah, I think there's still a big barrier there for smoking, that smoking has no use for people. It's just an addictive substance, and they should just quit. And, you know, if you had to pick one thing in harm reduction for heroin users, the biggest harm reduction they have is smoking, I think, because people wake up in the morning and they don't have to rush out right away and get a fix. They smoke a couple cigarettes. I mean, it's a very useful thing for people, as is cannabis, as is other things that people rely on. So yeah, people, I do think that's a key point, that at this point, most people believe that nicotine has no benefit, that people are just doing it to stop them from craving more, and they should just stop. So yeah, we need to establish that it's an important thing for people to have. It's their right to have it, and we need to make it as safe as we can for them.
Thank you. Yeah, I've promised. The mic.
Hi, this is John from the UK. When I'm not vaping and doing all the other strange things I do, I'm a health services volunteer, and I've been working in hospitals, prior to the pandemic and during the pandemic, looking after all sorts of different people, and I wanted to pick up on something that one of the earlier commenters picked up on, the harm reduction opportunities in hospitals and prompt interventions. And we are very lucky in the UK that there are a lot of hospitals that do have positive policies around the use of electronic cigarettes, even to the point in some cases of having stores. However, one of the prompt interventions that I made, there was a lady who was incredibly ill with an IV stand outside the hospital, smoking away, and I was there vaping, and started having the conversation with her about maybe you try something else. There are these things, and she started to engage, and she was asking questions, and I said, I've got a spare one, you can have it. Just at the point that she was going to say yes, scream from the stage left, "You can't do that here!" Can't do what? Vape. Why not? Oh, it's like smoking. Yeah, but your hospital has a policy that this is okay. I don't care. And with that, the opportunity was gone. And my question is, okay, so we're talking to politicians about stuff, but Mark, the rest of the panel, how do we change the public perception? Because if anything else, you can run as many poster campaigns as you like, to try and ban vaping, but there's the problem. It's the hatred. It's not just stigma, it's hatred. How do we change that note?
Yeah, well, I think we're unpacking years and years of propaganda, and actually it's quite stark. I don't think, obviously, illegal drug use is not particularly popular, but I don't think it actually carries the same amount of hatred that tobacco does. And time and time again, you hear stories of people switching to vaping, and then they say, oh, my family told me not to do it because we don't know what's in it. And it's weird because when I smoked, I don't remember anyone coming up to me and saying, oh, you shouldn't smoke. That was obvious, but the amount of times if I got some snus or vape, the amount of times someone's made a comment on it. So yeah, you're absolutely right, and there's a big disconnect actually, and Britain is doing well, but if I'm honest, Britain's fairly top of a leaderboard, but only because everyone else is doing so awfully bad. And I speak to doctors as much as I can. It's not necessarily my field, but through friends, and there's a huge disconnect between the NICE guidelines, which is very supportive, and Javed Khan in his review pointed to that, and actually what doctors understand, even on things such as nicotine risk. What do we do? Well, really it's the role of the government. They should be pushing more information out to doctors, and I think the amount of education people get at medical school is very small, but even then, it takes years and years for that build into the doctors' population. So, is there a role for others? Absolutely. I think UK VIA are doing some work on trying to educate doctors. I know Dr. Sud's doing a magnificent job. But yeah, I mean, maybe when we go to our dinner parties, we need to be a bit more confident about nicotine, and doctors can be wrong.
Mark Tindall, would you like to comment on that?
Well, I think that's a kind of a lost cause, trying to get doctors to get on. Like, it's really got to be a groundswell of people who have an interest in this, and to push policy and make it happen. Do medical, one of the Australian idea that, they may allow nicotine if it's prescribed by your doctor or some crazy thing like that. Meanwhile, they're selling cigarettes at the corner store. I mean, if we try and go the medicalized route of this, I think we're missing the boat. The only reason cigarettes are medicalized is because they cause all this disease, but it's not really a medical product. People who smoke don't consider themselves having a disease necessarily. And so I think the change has to happen, like we're trying to do with grassroots organizations and people demanding their rights and people going that route rather than trying to medicalize it. I mean, both have to try and happen, but if that was the strategy, let's let the medical system fix this for us. No, it's not going to happen. And being a you know, being a physician for so many years, I mean, even I would, you know, if you ask everybody if they smoke or not, you just put a checkbox in their chart if they do. You may mention, have you ever tried a nicotine patch? And they'll say, oh yeah, I've tried that, didn't work. And then you just go on to the next question. I mean, so doctors don't really have any real interest in it. It's ironic to me that some of the most vocal critics of vaping are like respirologists. We wouldn't need you respirologists if there wasn't smoking. I mean, they you know, they should be the ones that are going, this is obvious, we need to reduce the risk of cigarettes, because all my work is around people who smoke, and they seem not to be the people like that are pushing for safer products. So it really is not something that's going to happen anytime soon through the medical profession. I think it's really got to happen through people demanding their rights, and people really pointing out the fact that this is a safer thing to do for people. I just want to make one question too about like a scale up of things, and that's one of the, although I said up front that I think we need to work with industry to do this. If we wanted to go to like poorer countries, and the person from South Africa was talking about, how is it ever going to happen with commercial vaping products or commercial heat not burn products? I mean, it is never going to, be affordable for people who can, buy a cigarette for 2 cents or something. Then it's got to be like a sort of a global effort to get access to people. So they need to have, no patents, no commercial, just like we did with antiretroviral drugs. If you really want to get them out there, these drugs that are in North America are $30,000 a year. You get them for $300 a year, and you have factories built that produce these safer technologies and allow people to access.
Thank you.
Yeah, thank you, Rafi Castillo from the Philippines. Thank you, Mark, for this very insightful talk. And it made me reflect on the question, is the social stigma on smokers a good thing, or is it a bad thing, or is it a good, is it a good thing in some respect? Well, definitely it's bad if it causes low self-esteem in the smoker, and it throws them into the pit of depression, and makes them shut down to all offers of help, harm reduction, for example. But to some degree, it can be a positive thing, because it can be a compassionate rebuke, which will motivate them to really consider smoking cessation and things like harm reduction. I think it's all a matter of mindset or perception of the public, particularly of the healthcare professionals, as pointed out earlier. Because if we look at the smokers as a social deviant, a social norm deviant, who unknowingly causes harm on themselves, not only on themselves, but also on other people, then definitely the social stigma will be very negative, and it can be exaggerated or magnified. But if you look at the smoker, particularly recalcitrant smokers, as actually patients, and that personally I would consider smoking as an addiction, a behavioral disease. And recalcitrant smokers need all the compassionate care that we, particularly healthcare professionals, can possibly give them. Then I think the social stigma will be different. And it will be a positive motivational factor. I must confess, I humbly confess that I fell into this trap. I think yesterday, or was it the other day, I shared that in our clinic we used to have a very harsh policy against recalcitrant smokers. We gave them 6 months to quit smoking. We gave them all the support that we could give them in the clinic. And if they don't quit, we don't give them an appointment anymore. we courteously refer them to other clinics, and our attitude is good riddance. But we reconsidered this over the last couple of years, and just with a change of mindset, our strategies, our approach towards recalcitrant smokers, it really changed completely. So we're now more compassionate, we're now more tolerant. We offered them more options at helping them quit smoking, or at the very least mitigate their harm, their health risk, and also mitigate the risk that they're offering the public, as in secondhand smoking. So that's where we really have to, I think, reflect also on the question, how much social stigma is healthy for the smokers, something that is positive to motivate them to quit smoking or to consider at the very least harm reduction, and how much social stigma would be negative that can lead to negative long-term mental and physical outcomes. Just a thought, and I would love to hear your additional comments on that. Thank you very much.
Which one of you?
I mean, if I'm hearing you right, I mean, I think there's very little room or very little positivity for social stigma. I think that with drugs or addictions, people are using them to self-medicate, and if they're feeling bad about themselves, they'll continue to self-medicate. I mean, that people stop smoking, and in my experience, when they get an epiphany and they decide that they want to make a change, they want to stop, and usually when it's on a positive note, when people are feeling terrible about themselves and feeling so stigmatized and isolated, it's not a motivation at all. It's a motivation to keep smoking more, because that's what they're self-medicating for. So I see hardly any room for a non-compassionate and a non-helpful way if we're really trying to help people to stop smoking. And making people feel worse about themselves is one of the reasons why they're doing it in the first place. So it makes no sense to me to shame and stigmatize people. It won't make them change.
Thank you. I think we have room for one, maybe two more questions.
Hi, Mark. It's John Oyston here from Toronto. I'm a little disappointed that as a fellow physician, you've maybe given up on the medical profession. And I accept that physicians aren't going to take the lead on this, but surely we need at least to educate physicians enough so that when their patients switch to vaping, they say, oh, that's a good thing, congratulations. And also for those people who do choose to go to medical smoking cessation clinics, then those clinics should be offering vaping and snus and other alternatives. I think we have to move at least that far with physicians, don't you think?
Oh yeah, definitely. So I kind of went a little too far. I really meant the leadership. Like, if this is what we're going, how we're going to make a major transition to leave it up to doctors, I think is not going to happen. So, but certainly, the work that you do so well with physician groups is super important, and doctors can have a real negative impact on this if they remain steadfast in their opposition to vaping. So it's clearly we need to get them on side, and colleagues of mine that I know in smoking cessation clinics who are still not even suggesting alternative nicotine products. I'm just it's terrible, costing people they're costing lives. So definitely the education is very important. But my comment was more referring to, if we want to make this happen in a quick, scalable fashion, then we can't rely on doctors to do it.
Okay, one quick question. We can accommodate, and one, if not, so I'm still blinded, so I don't see if anyone wants to. No. Okay, so we have 2 minutes for your final comments and thoughts, if you are happy to share some additional remarks. Okay, Mark Tindall. I
I wish I was there so I could talk to people face to face, but you know, I'm very committed to you know, to pushing this ahead, and I think that you know, we really need to recognize that that people have the right to nicotine. It's useful for a lot of people. We'll continue to use it, and that we need to offer people a variety of options to get this done. And it's you know, we're all in the room talking to each other that pretty much are on the same side, but we're unfortunately a small voice in this, and there's a huge push. You know, things are getting worse. Like, you know, these GFN conferences have been going on, and I mean, I think we were more optimistic 2 years ago. You know, we didn't expect countries to like announce like total bans, and the WHO not to make any movement and be so obstructive and damaging. So the work's cut out for us for sure. And you know, it's got to keep pushing on and climb that ladder, I think. So.
Thanks. So I would like to, I think we might, it's 1:15 and the voice in my ear says we should end. So thank you very much for joining us today, and a coffee break, yeah? This is what waits for us. Thank you.
Thanks.
they can save it in its lives, but they're going to die from smoking.
Okay. Thank you all for coming here and being part of this session. And it's very interesting indeed when you consider that the theme itself for this conference was tobacco harm reduction is here for good. And it's not going to be here for good if we don't understand what the basic requirements are, which are human rights and the legal challenges that are facing all of us. And that's why all of us have been coming here together to exchange ideas, to understand which each of us countries have been going through, and what the state of tobacco harm reduction is in each one of our spheres. Now, each one of us here has been a former tobacco user, and we have found various means to quit that habit and move to safer nicotine products, but then our right to use these products, the right to these safer alternatives, is under threat and challenge. I'm Jagannath. I'm from India. I represent the Vapers Association of India. I've recently been drafted into the board of INCO, so thank you. And I'm here for this really, hopefully very engaging debate, because this is something that we haven't really talked about or looked about, because we have always taken our human rights for granted until somebody steps on them. Right? So with me is Thomas Gorman, who's another member from INCO. He's a lawyer. Jerry here, he's, well, no introduction needed really, I mean, because he's been there, done that, and he keeps doing it. And thank you so much for being here, Jerry. Right? Fiona, thank you for being here. Your insights on what goes on behind the closed doors of parliaments when we discuss and debate such things would be very, very insightful as we look at legal challenges. And David, thank you for being here. Your wealth of experience hopefully will enlighten this room with some ideas. Okay. Perhaps we can briefly start with talking about what we have presented. I hope all of you have seen the videos that our panelists have put forward. I'm not supposed to be talking much, so I didn't put out one video for myself. But having said that, if you could just kind of briefly touch upon the reasons for you picking what you did, that I think would be a good start off. Thomas, if you could start.
Yes. Well, I'm Thomas Orlan from Proapeo, Mexico. I'm a vapor, I'm a consumer. And when I was honored to participate in this panel, I was just thinking what human rights related to safer nicotine. Because the first one that comes to mind, as I say in the video, is the right to health. That's what we listen through the whole GFN. That's the subject or the right that it's always argued by tobacco control. But there are others. There are other human rights, because dignity, human dignity is one, and the several aspects of the person cannot be fully developed, or happiness cannot be achieved if we don't protect all the aspects of the human being. And then after considering right to health, it was the right to autonomy, or the freedom to the development of the personality, which, by the way, has been recognized by the Supreme Court in Mexico when they declared the unconstitutionality on the previous ban of commercializing cigarettes. But there are others. The right to information, because this right is instrumental to to exercise the right of autonomy and the right to health, and therefore the right to harm reduction, which I'm sure Jerry will talk about, and here is the presentation. Because the right to harm reduction itself enables the best way to exercise both autonomy and health, right? And finally, I introduce one more, which is the right of consumers to have a significant participation in the design of the harm reduction policies and e-cigarette regulations, because smokers were not allowed to participate in the creation of the FCTC. They are not allowed, or were not allowed to participate in the creation of anti-tobacco laws, at least in Mexico. And as Jacob Cryer says, they consider smokers are as per people that are to be acted upon, not to be listened. And I think it is time for vapers, for consumers, to be listened and to have this meaningful participation in the creation of regulations and provisions that in every country will regulate vaping.
Thank you, Thomas. To just kind of take that perhaps just a little forward to continue. Unfortunately, the way it appears to be that the minute you picked up a tobacco product or a smoke, we seem to have surrendered all our rights. That's what seems to be the general practice, isn't it? What are your thoughts on something like that? In your quest for rights and trying to determine what are those rights that are indeed available to us as consumers and our quest for safer nicotine products, why is it that a tobacco user seems to have given up all these rights? Any kind of ideas on that one?
No, actually, when someone smokes, he's exercising his right to autonomy. He's being punished because of he smokes, but maybe we don't have a right to smoke, but we have a right to choose smoking. Now, I think that the problem is that in tobacco control, they are focusing only on one right, which is health. And when you don't consider the other rights, then you don't care if the interventions and the policies you are designing are interfering with other rights. So it's not that we waive our rights. They are just not recognized in the creation of these policies. And the thing is that there is this mantra that human rights are universal, indivisible, interrelated, interdependent. Well, yes. Then why the FCTC only focus on health, right? There should be limits, and well, they don't want.
Thank you, Tomas. David, perhaps if you could touch upon what you have presented and where you come from thought-wise on this one.
Sure. I've been involved in doing work to reduce smoking for 40 years or more. And I spent the first part of my career with a group called the Non-Smokers' Rights Association, which was like the most effective anti-smoking lobby group in the world. And we were making the case for rights, the right to be protected from secondhand smoke. You can be on an airplane without feeling ill. If you had medical conditions aggravated by smoke, you should not be subjected to that, et cetera. And in those days, cigarette companies would set up groups called smokers' rights associations to try to argue for the right to smoke and to smoke wherever you want. And we'd make the argument that if you're actually talking about rights, smokers' rights should be things like the right to proper information, adequate information to make informed decisions, the rights to have alternatives to the products that you have, et cetera. And we're still there. And I think this is pretty basic stuff, because when we talk about human rights, or in law, when we talk about people's fundamental rights, I think we can take it back a long way, because the concepts are really straightforward. We go back to the sort of stuff Karen Armstrong has written about in the book The Great Transformation, her studies of religion. And 2,000 to 2,500 years ago, worldwide, major religions got into this idea and philosophy of the golden rule, that, empathy, you should care about other people, that they aren't just objects in your way. You need to understand how they feel about things. Do unto others as you'd have them do unto you. And those principles have been well established. If we look at the Enlightenment and the role not just of science and reason, but of humanism. We care about people. We want a better world for people. And when we think of what we've accomplished with the principles of the Enlightenment and, conflicts disclosed, I'm a fan of the Enlightenment. I think it's a way better idea than things like inquisitions. Inquisitions can be more fun, granted. But the whole idea of saying, let's respect individuals. Let's pursue humanism. Let's do the sorts of things that public health has adopted, because it's not just public health in law, but we see this in professional ethics. We see it in constitutions, because it keeps reflecting this idea that human beings have fundamental rights. So public health comes down to basic things like try to understand people's lived experience. Why are they behaving the way they are? Right? And do things like meet them where they are, rather than saying, I'm going to tell you what to do. And empower them to make better decisions about their own health. Give them the information, give them the options, work with them. In fact, the very things that the World Health Organization has in its charter from 1946, that, and to quote, informed opinion and active cooperation on the part of the public are of the utmost importance in the improvement of the health of the people. It wasn't like the World Health Organization suddenly thought about that at the end of the Second World War. It's just, this is basic stuff about humanism and human rights. It's been established over centuries. It's now reflected in constitutions of various countries like my own. It has been used in countries like Canada to pursue things like the right to a safe injection site for people who are using drugs. The right to the attainment of the highest possible standard of health, the right to life. A respect for individuals, meet them where they are, and be pragmatic. This isn't a matter of telling people how to live, it's a matter of doing what works. And job number one is reduce the likelihood of death, injury, and disease. How do we do that? And rather than being judgmental, we just simply look at the things that work. So I think that these principles are really well established. We've seen them used many times as the booklet that's just been passed out before this meeting talks about on things like HIV/AIDS, the ACT UP groups to push for human rights on AIDS. We've seen it in other issues of drugs. In Canada, we have litigation that not only gave us safe injection sites in medical marijuana, but litigation that is now being pursued on things like safe supply of drugs and decriminalization of drugs. Because the decriminalization of drugs reduces people's choice. It forces them to use something that's more hazardous. They're more likely to get sick and die because they're not being given the safer product. They do not have access to the safer product. Criminalization adds to harm. Well, how is that any different than the arguments that are being made, including in Canada now in litigation, on things like access to vaping products? That it's simply a denial of rights. It's a denial of the right to life to say, we are going to create a situation that forces you to use a more hazardous product than what you'd otherwise want. Like, how can you justify that in a rights-based society?
Thank you. That was incredible. To just go back to a couple of a point that you had made, wherein, like for example, tobacco companies actually put together these things about the right to have a smoke and so on. Now, we are a people's movement. Literally, that's what we are. We are all former smokers. We are all or tobacco users of some form or the other. All of us are consumers, and so here we are fighting for our rights to do these things. And the minute that we do, then we seem to have these kind of large interest groups that seem to be clamping down hard on us. In fact, even denying us the right to assemble, even things of right to research. For example, in India, they have banned research on tobacco harm reduction products. And then they're going out and telling us there is an absence of research. How does these things work, And So what would be your idea to kind of throw into that thing? I mean, do we join smokers group and say, hey, we have picked a safer product and, you know, why don't you back us up or something like that? I don't know. You know, it is just an idea, you know.
Sure, as a lawyer, I'm very keen on the idea of precedent. And there's a tendency to look at any problem that comes along like, my gosh, this is something new. You know, nobody's ever encountered this before. What on earth are we going to do about it? My experience that much in life is like a Shakespearean play that you've already seen 16 times. And if you're sitting down to watch the play and the person next to you says, hey, you know, I think Caesar's going to be okay this time. They don't get it. You know, the same sorts of things go on and on and on. So I would look at what's happened in other cases. You know, there used to be tremendous stigma over things like, what if a woman wanted contraception? Oh my God. I mean, you know, how do we prevent this from happening? There was opposition, as some of you may know, to women riding bicycles. They might wear bloomers. I mean, how could civilization even survive something like that? What if a couple is courting and they're on bicycles? They get out of sight of the chaperone, and you know, what would happen to their reputations, the reputations of their families? I mean, and that's before we get into things like HIV/AIDS and what, you know, we were hearing this morning about the stigma. And it's been repeated, you know, what we see on illicit drugs. You just say no. You know, just stop doing that. And when we look at how rights have been enforced, in many of these cases, it has been from the individuals who are at risk taking action. And in many cases, they're human rights actions. So when, you know, how did we get safe injection sites in Canada? Litigation from people who are otherwise going to die if they couldn't have access to these things. People like Mark Tindall playing a key role in it. What was the role of public health? To wait until the decision of the Supreme Court of Canada on whether the safe injection site was going to be able to survive when the government was trying to close it down, with padlocks ready to put on the door, assuming the Supreme Court would say you couldn't have safe injection sites. They didn't think anything beyond that. The Supreme Court ruled unanimously people have a right to life and that the safe injection site was okayed. How did we get gay marriage? Litigation by people who wanted to get married, and the law was saying you couldn't. And human rights. I mean, we've seen these things happen so many times on so many issues that, again, it is like that Shakespearean play, and, you know, cut to the chase, Caesar doesn't do okay. You know, it is the same thing over and over again. And I think we can learn a whole lot from that, and that's why I like the idea of sort of looking at the historic flow to say what has worked historically, because those sorts of things are going to work again. And that human rights don't end because somebody uses a particular type of product rather than another type of product. If you've got a right to life, if you've got a right to be able to communicate accurate information, you've got a right. And we see the progress that's made on things like that, and it's a matter of staying with it, and then as litigation works in some places or legislation works in other places, it gets picked up elsewhere. And we can see good policy is contagious. Good legal reasoning is contagious. It starts spreading around the world.
Thank you. Fiona, one of the things that we've noticed, at least from the Indian context, is when legislature have to take difficult decisions, we normally kind of just push it to the courts to decide. And so you have somebody coming up with a public interest litigation, and that's how the matters get debated. In fact, even things like moving from diesel fuel to compressed natural gas in India, for example, it took a court to take a decision and not the government, because it was a difficult decision, and so there were many people. And so now the courts really aren't the most knowledgeable. They are going to discuss a point of law. And so when you are looking at this and this divide of a legislator needing to cope with difficult decisions, how do you keep championing this, and how do you keep going on? I mean, you know, that's something that I'm curious about.
Thank you. And I think this is such an interesting subject, and it's, you know, in Australia, in my state of Victoria, we have a Charter of Human Rights and Responsibilities, but it has absolutely no teeth. And in fact, I'm on the Scrutiny of Acts and Regulations Committee, and every fortnight before Parliament we meet. We go through the legislation that's being presented that week, and it's tested against our Charter of Human Rights and Responsibilities. And quite often it's found lacking. But that doesn't stop the legislation going through. It just says, well, yes, I mean, it doesn't actually meet the Charter of Human Rights, but we're going to do it anyway. So in Australia, while we sort of assume we have human rights, the courts are not going to be able to protect them. So we actually have to do it via legislation. And I think back to how we do it, and I've just recently been able to decriminalise sex work in Victoria. Now that took 30 odd years to get us there, but it was a human rights argument, and everyone accepted it as a human rights argument. And in actual fact, as part of the legislation, we had sex work included into our charter as a protected attribute. When we looked at when I was campaigning for the medically supervised injecting room, again, we argued it as a human rights issue, that right to life. In the end, it wasn't the human rights of people who use drugs that got us over the line, I can assure you. It was the NIMBYism of people not liking people overdosing on their front porches that actually won the day. But it has saved millions of lives. And I don't think, when I've been campaigning around vaping, I haven't really run that human rights argument. And I think this has really jogged my mind on this, and to start making that argument, because we did in medicinal cannabis as well. You know, in all of these other areas, in LGBTI rights, in marriage equality, we've argued it from a human rights perspective. And I haven't done it on this. I've done it on drug decriminalisation. You know, but for some reason, even myself as a vapor, as someone who's campaigned on harm reduction, I haven't put the human rights into this argument. So I'm really pleased that we're having this conversation, because I'm already starting to think how we take that back and how we challenge this around the right to life, around the right to good health.
Thank you. That's incredible, because championing it, we normally have this, perhaps we just kind of take it for granted, and it kind of hits a blind side, and these are some aspects that kind of just slip through. And when we look at it, and when we have an audience like this who are hopefully going to throw up some good questions, which all of us can take back, mostly you and all of you who are there in ability to change.
Yeah. And I think it goes to the stigma of smoking. And I think it goes to the shame of it that we were talking about we've been speaking about over the days. And so even as someone who vapes, as someone who quit smoking, I didn't actually think that I had a human right. You know, I think that shame and stigma, it has infiltrated some of our conversations around this.
I guess that's what it has. Thank you for being so patient and waiting, Jerry.
Best for last.
Yeah, exactly.
Do I get the difficult question?
We'll start off easy here, okay? to kind of ease you into it, to perhaps shed some light on, you know, your video presentation and what got you into looking in this direction this time.
Well, yes, I mean, you know, I'd echo what's been said about how important it is to have this discussion. I think this is probably the first time in any conference you've had a panel on the right to health and the right to tobacco harm reduction. And we're at very early days in developing those arguments. And I think everybody on the panel would admit that they're no human rights expert, but have been involved in human rights issues in various ways, which has led them to be here today. For me, it's a sort of a bit of a long story, because as many of you know, I was involved in research on HIV/AIDS and drug injecting way back, and doing work on needle exchange and so on, and you know, very interested in access to you know, safer injection sites and so on. But when I gave up academic work, my first retirement in 2004, I just got fed up with doing academic research. I headed the International Harm Reduction Association, and I hired in some human rights experts. And you know, part of that was to look at the very serious abuses that occur to people using drugs around the world. I mean, I've been to countries where drug users are chained to the bed, to help them through detox. There are extrajudicial killings. In many police forces, forced withdrawal is used as a way of encouraging people to confess to things. So there's clearly a lot of very serious abuses and the need to protect drug users from those sorts of abuses. And one of the things we did was we started to track what was happening in UNODC, United Nations Office on Drugs and Crime, and the projects they were supporting, and we discovered that some of the outcome measures for their cross-border projects and so on resulted in more drug users going to prison, resulting in drug users being executed. So we thought, this is madness. So we took it to the donors, because UK was funding projects which resulted in people being executed at the end of the day. And we took it to UNODC, and all the shit hit the fan, because UN is an anti-capital punishment organisation. So there was a big lesson there about how to use that to bring about change within the UN system. And I'm not sure if there are parallels now, but we used the UN bit of human rights as a pressure point to get change in UNODC. But then there was a further development, so that's kind of protecting drug users from abuse. But there was a further development, which I think is very interesting and much more pertinent to what we're talking about today, which was about the right of drug users to have decent treatment, the right of drug users to have sterile syringes and so on. So we worked with the UN Special Rapporteur on the right to health, and over a considerable period, began to get an argument into the UN system that being a drug user doesn't deny you access to health. Some of this discussion we've had already here, being a smoker should not deny you, your rights. And that kind of, that gave us a bit of rights in practice, at least in the UN system, because working with the UN Special Rapporteurs on the right to health, and we'd also work with the Special Rapporteurs on extrajudicial killings on other issues. And that language permeated into the UN system, so that there's UN General Assembly meetings and so on, where the right to health for drug users was clearly established, the right to have access to methadone, the right to have access to sterile syringes and so on. So once you get that into place, you can then start to sort of pursue that through other bits of the international human rights system, which we might return to in a minute. But I think you can see kind of the read across to here, because the right to health is the right to resources to avoid damaging yourself. So the right to health with safer nicotine products is the right to have access to those in place of other products. So developing that argument, I think, becomes a stronger, we can develop a strong case, arguing against bans and inappropriate regulation and so on.
Well, I'm just curious about one thing. Now we seem to, nicotine really is just as good or bad as caffeine, okay? And it's more of a dependence rather than an addiction. We have a tendency to call these things addictions, which I think is part of the problem, because then we immediately start getting classified into the really harmful substances that we have. But then when we are talking, for example, on the kind of amazing work that has been going on now, at least in acknowledging and admitting, human rights of the drug users and the rehabilitation programs, and forming alliances with these people and looking at those for examples, how would you say that it would work, especially when you are actually lesser of the evils, if that were really a word? I mean, it's after all a dependence.
I think, and I've always thought, that the tobacco harm reduction movement needs to make strong links with other bits of the harm reduction movement. It's a slow business, because many of our drugs harm reduction colleagues and alcohol harm reduction colleagues are not really particularly interested in tobacco harm reduction. We need to make alliances there, and we also need to make alliances with people who are working in human rights organisations. They have the expertise, they've done the challenges, they've done the work on reproductive rights, access to AIDS treatment and all of those other things. So that's where we need to, there's a big gap in what we do at the moment. We've developed advocacy, we have big conferences, we energize people, and we've got nicotine consumer groups and so on. But we do need to kind of skill up in that respect. We do need to build alliances with people who've worked in other human rights fields.
Anyone? Fiona, could you add to something like this?
In my mind, I'm pulling together a to-do list for myself when I get home, and I know that so in the supervised injecting room in Sydney for a number of years now, they have been encouraging their clients to take nicotine patches as they leave the centre. It hasn't been very successful. I don't think it's actually helped a single one of the clients stop smoking, but they are very acutely aware that they are saving their clients' lives from a heroin overdose or using an overdose, but their clients will die from smoking-related illnesses. And however, when I have conversations with those same organisations that manage those centres, when I start talking about vaping or other safer nicotine products, a kind of a wall goes down, and we're not having those conversations. And in fact, I was speaking to a very senior harm reduction pioneer in Melbourne before I came, and I told him where I was going, and he just went, right. Now, this is a man who has advocated for drug law reform. This is a person who has advocated for the rights of the LGBTI community. This is a man who was on the International Harm Reduction Association with Jerry. And yet, when I start talking about tobacco harm reduction, this wall goes down, do you know the sort of people you'll be mixing with? It's sort of... I know, look, actually, I hope no one's photographing this. Oh, that's right, we're live streaming it, damn. And also the Human Rights Law Centre, who has been a great ally of mine in many of the other cases many of the other campaigns we've run. I've never spoken to them about vaping, and I will be when I get home.
Thomas, you've have faced some unique challenges, and you have actually overcome some of them in the Mexico context, when it came to vaping bans and so on and so forth. Now, we are LMICs, and where we come from, we have got this blanket ban sitting there. It's not that products are not available. I continue to vape. I'm sure it's the case in Mexico as well, because you're always going to find products making their way. I mean, if drugs are available, drugs are obviously banned, they're available. Here's a safer alternative. I'm definitely going to seek them out, which is what I've been doing and managing fine. How was it that you were able to actually pull it together? I mean, did you actually find the voice of reason somewhere, or was it, was it an epiphany or something? But how did this change actually come about?
Well, there haven't been any changes. I mean, the president just rebanned commercialization. The thing is that in LMIC's prohibition is like trying to stop a wave with an umbrella. E-cigarettes are a wave. They will become unstoppable, and the best way to help people to quit smoking is to regulate them, but they don't want to. Now, what happened in Mexico? In Mexico, we have lived since 2008 with provision in the anti-tobacco law, which banned commercialization in very similar terms that the provision contained in the Western Australia state law. It was not an express provision, but through interpretation, e-cigarettes were banned, not the use, the commercialization. Through time, the Supreme Court, in several cases, in lawsuits called amparo lawsuits filed by merchants, by shops, they ruled that the ban, the blanket ban, was unconstitutional. And then, surprisingly, in 2019, the second chamber of the Supreme Court ruled that the ban was constitutional. We have a legal precedent saying that it was unconstitutional and a couple of sentences saying that it was constitutional. And then there was something, one of the ministers filed for this contradiction in order to determine which criterion should prevail. And on October 19 of 2021, the Supreme Court ruled that the blanket ban was unconstitutional. A great thing about that resolution is that all those precedents were based on commercial equality principles. But the ministers, during the discussion, they introduced autonomy, they introduced freedom of commerce, and other rights in order to come to the conclusion that these products should be regulated and not banned. We were very happy. We had, this last year was a good year for vaping. But on May 31st, we had a new decree, and our government, our president, insisted that these products should be banned. On what grounds? Health protection. Something, I know the Mexican ban has been commented in several moments at the GFN, but maybe you don't know that 2 weeks earlier, the government launched a maximum, that's the name, maximum sanitary alert against vaping. And one of the most prominent ideas to supporting that alert was vitamin E acetate. It just came 3 years later. So you can imagine the disinformation and the attitude of our government. But this is an LMIC, and with some difficulty, we are still able to get these products.
No, because LMICs are not, uniquely disadvantaged, because all the first world countries seem to be doing pretty much the same. And, and when you actually look at, for example, the problem that Swedish snus is having, right? And here is something that's worked. It's probably the biggest harm reduction tool there, with 100 years of data there to show that things are actually going down. But then the EU is looking at it, as something that needs to be kept away. And not too much effort is going on this one. And so if there are lessons that LMICs should take, in fighting such requirements, what would you have to say about something like this, David? And how does a first world country challenge it? And what hope does an LMIC have if, all the knowledge which is out there is not really getting put to use?
Sure, I think, again, it's that Shakespearean play we've already seen so many times. The same sort of patterns are repeating themselves, and I think it helps to think about some of them. Like how often, when someone comments about somebody being overweight, do they make a moral judgment rather than a public health one? How often, when talking about any sort of behavior, poverty, why are people poor? How many people make a moral judgment? And I think as a species, we tend, the fast and slow thinking, our quick response tends to be a moralistic response, a judgmental response. And then we have to actually engage our frontal lobes to think about, well, wait a minute, what's actually going on here and what can I practically do about it? And I think Swedish snus is a really good example of that. And a really good test that when you're dealing with people who are opposed to reduce risk for people who are using nicotine, to see, do they pass the snus test? Will they at least accept that Sweden accomplished great things by having an alternative? Because what you find is that they won't. And they won't because they're not in that reason frontal lobe category. They're still in that moralistic, I'm fighting evil category. They're still involved in the Inquisition, not the Enlightenment, right? They're not looking at science and reason and taking into account humanism. And I think that's the same battle that we have again and again. And it's This has been written up so well in things like Brandt's History of Venereal Disease, No Magic Bullet, of how we blamed individuals, the history of trying to get to auto safety. No, what you need is a spike right in the center of the steering wheel at the driver's chest. Because the reason people get into accidents is they're not paying enough attention. It's their fault. This is a moral failure on the part of drivers. I mean, that's true. That's part of the history. Look at the history of the Comstock laws in the United States on reproductive rights, women's rights, Anthony Comstock. Contraception was banned. And in fact, in many wealthy countries, including as I was hitting adulthood, contraception was illegal for single women. Now, do you think that was based on good, practical public health principles? Or maybe a little bit of moralism came in there? And so I think the patterns are there, and how do we focus people on getting pragmatic? And I think we can look at some of the history of these other issues of how people got around the rules, because when we talk about things like vaping products being banned or the restrictions on them, well, so were contraceptive devices. But families weren't huge back then. I mean, people found ways to get around the rules. When there's been bans on pharmaceutical products in various countries that are beneficial to certain people in those countries, they find them. The history of innovation, the stuff from Big Bang Disruption, Downs and Noons, which is that you can't stop innovation. It will happen. You can slow it down, and nothing can slow it down more than regulation. No form of regulation more than health regulation. No health regulation more than the FDA regulation. But even the FDA can't stop it. It's going to happen. People are going to get these things. So for us, the question is, how do you speed that up? And how do you do that in country after country? Who are potential allies? Who's standing in the way of that progress? So now I just think we're in a crazy situation where you've got, on the one hand, anti-nicotine extremists who think they're fighting the tobacco industry by preventing people from getting access to anything other than cigarettes, which just happens to be where the tobacco industry makes their money. And tobacco companies are making cigarettes saying we'd like to transform, but the last thing they're going to do is really facilitate the transformation by making available the evidence as to how rapidly people could transition off cigarettes, which happens to be where they make their money. I mean, how do we start getting rational discussions about these sorts of things? And again, engage those frontal lobes so people aren't just saying, I'm fighting evil, big tobacco evil, I'll fight anything they do. How do we get regulators, politicians to start thinking more deeply about these things? How did we get into this idea that the way to deal with anything to do with tobacco is a knee-jerk opposition to anything any tobacco company tries to do? Because most people learn by the age of 3 that simply disagreeing with someone, no matter what they do or say, doesn't get you very far. As a 3-year-old, where your older brother says, it's rainy outside, say, no, it's sunny. That's really funny, right? The grass is green. No, it's orange. And it doesn't take very long until your 5-year-old brother says, I think you're smarter than a rock, right? And wait a minute. And what's amazing is an awful lot of what goes on and what passes for a public health community hasn't yet got to that 3-year-old level of logic to realize maybe I don't do really well by simply attacking and disagreeing with anything they ever try to do. Maybe I should actually try to think of a broader goal here of what I'm trying to accomplish.
Jerry, you wanted to?
Yeah, because you asked a question about legal challenge and you mentioned snus, and of course the huge difficulty is in the ban on the sale of snus within the European Union, for which in fact the UK was responsible. So that's a bit of the damage we did to the European Union before we decided to get out of the European Union eventually. But that has been subject to legal challenge unsuccessfully, and there was a case started in 2017 brought by Swedish Match, one of the main producers of snus, arguing that the ban was discriminatory against the product, that it was against the principle of subsidiarity of nation states to make their own rules and regulations, and there were a few other issues as well. I was then working with the New Nicotine Alliance, and I was, unlike many people on the panel here, I'm not a vapor. I'm I tried to be a smoker years ago, but I never actually liked nicotine. And, and since, you know...
Moral failing there.
Moral failing, I know. And, you know, try harder, yeah. And, you know, when people say, well, it might protect against dementia, I tried again. But it doesn't work for me. But nevertheless, I was kind of an honorary non-vapor member of the New Nicotine Alliance. And when Swedish Match brought this case, we thought, it's interesting, because you can join a case as a third-party intervener. So the case had to be brought by Swedish Match in the UK High Court, but then when it was agreed there was a case to answer, because it's based on EU legislation, it had to be passed to the European Court of Justice. So the argument that the NNA developed was not the commercial argument that Swedish Match was developing, but it was a right to health protection argument, that people had the right to have access to a product which would help to prevent them suffering severe disease or premature death. And the principles were based on several elements of the Charter of Fundamental Rights of the European Union, about dignity, which is kind of autonomy, about right to health care, respect for private life, and elements of the European Charter about encouraging responsibility, individual responsibility for health, which is all good stuff. So we were kind of the add-on to the case, and it takes ages to do this. It's like 2 or 3 years, and it's quite fun, going to meet. I had to learn bits of law and all those other sorts of things, and going to the European Court of Justice, and some people in the room were there as my supporters when we were at the European Court of Justice. But it got knocked out. But it got knocked out really on the commercial grounds about, it was about the issue of proportionality. That, was it legitimate for the European Union to make law in this area to, prevent the sale of a particular product? And the kind of the human rights stuff was always like rejected as a kind of an add-on, and they sort of said, well, you can do some stuff and sometimes you have to ignore human rights to do other things. So it didn't really take much notice of our argument. But they can't really say that, but they did say that. But I think the lesson there was that perhaps we shouldn't have been pursuing this at the European Court of Justice, which is dealing with very fundamental commercial and other issues about European law, but we should have considered going to the European Court of Human Rights, and I think that would be an interesting step to pursue for those who want to promote the use or change the law about snus. And the kind of argument there would be that I am from maybe Sweden and I'm living in Germany, and I'm denied access to this thing that could, protect me from mental health. So I have a legal right to the product I was able to use in Sweden, and I should have that legal right elsewhere in the EU. I haven't really thought that one through, but I think that would be the kind of case that might be of some kind of interest. But of course, all this costs money. Lawyers don't come cheap, do they? two rich lawyers on the end of the panel here, they're very dear. They're not denying that. So, you need to get pro bono advice and so on, or get somebody interested in this. But I think we need to begin, I was interested, the Mexican example, and of course in India you've had legal challenges as well. And, I don't know how that was all paid for and all the rest of it, but we need to start making those challenges. We won't necessarily win.
In tobacco control and in tobacco harm reduction, what's the reason, or was it kind of missed or forgotten, or was it deliberate? I mean, that's something that still not been able to work out.
Well, I was under the impression that the Framework Convention on Tobacco Control had been informed by human rights, but then I read some material from one of the legal counsel to WHO at the time, Alan Taylor, and it appeared that the FCTs, the preamble refers to the International Covenant on Economic, Social and Cultural Rights, Article 12, which is the right to health bit in that international treaty. So it's there in the preamble, but the FCTC, the convention itself, is not informed by human rights. And I understand that in the development of the FCTC, this was never raised by countries or by NGOs. And there had been some internal discussions about avoiding this. because it was a kind of a dodgy area to get into, in particular because many tobacco companies had been pursuing the right to smoke argument, and it was thought, I believe, that there wasn't a strong enough case to try to get FCTC through countries on a right to health or human rights basis, but it's more on the interdependence of nations, economic interests, and public health. So it's not informed by, the FCTC is not informed by human rights or health rights thinking. And so that leaves a gap for tobacco controllers to work out what the human rights angle might be. And unfortunately, that's mainly developed along the lines of protecting people from the tobacco industry and protecting people from tobacco. It hasn't developed along the lines that we've been discussing here about the right to access safer products. And the absence of human rights in the FCTC is kind of also linked to the neglect of the harm reduction bit of FCTC. You know, I was in drugs work for years, in drugs policy work, and we never had the harm reduction language there, and it was always excluded for one reason or another. The United States, mainly the problem here, that you couldn't use the words harm reduction in any international agreements under there's something called the Commission on Narcotic Drugs, which is rather like COP in our field. And I've been in interminable meetings where people were jumping around. The UK and the EU wanted harm reduction in there, and the US and Russia and others didn't want it in there. And one meeting, I think, after days of discussion, harm reduction was defined as access to appropriate support services. Like this interminable wrangling over the language. So that, when I read Article, FCTC Article 1D, and their words harm reduction are in there, I thought, whoopee, as I did when I first came across tobacco harm reduction, I thought all my public health colleagues would be as enthusiastic as I am about this, but we know doesn't happen that way. So the harm reduction bit has been neglected, and also the human rights and the health rights bit has been neglected. So what we've got to do, there is a developing narrative about protecting people from smoke, protecting the kids, protecting people from the tobacco industry, protecting people from tobacco, but we need to grab a narrative, and there's a gap there. We need to grab a narrative which is about human rights and enabling people to make those choices to lead kind of safer lives. So I think there is a good opportunity to develop that alternative narrative and to offset that narrative, which is entirely about protection from the evils of the industry and the evils of tobacco.
Well, my government in India, at least, gives me the right to smoke. I mean, they own 30% of the largest tobacco industry in India, so it gives me the right to smoke. But taking it from there, Fiona, wouldn't that...
Sorry, it just reminded me of just a quick anecdote. Many years ago, I was a lobbyist for the adult industry, and I wrote to the Cancer Council one year and suggested that cigarettes should be restricted to adult premises, and that you should only sell cigarettes from age-restricted premises, and adult shops would be very good for that. By the way, I got a letter back saying, "Oh, no, that's a bit extreme." They thought that restricting cigarettes to adult premises or to places where children couldn't go was going far too far for the human rights of smokers, and that really it wasn't. That was far too restrictive. And this is the same organisation that is called, that has effectively banned safer nicotine products in my country.
So if smoking, and I do have a right to smoke, I mean, wouldn't it flow that I have a right to a safer alternative? I mean, the same argument, wouldn't it?
It should, and I think this is something, I don't know if someone can offer some assistance to me, because I've been thinking about this, and when I go back and I argue that case, what the response from authorities will be, well, you can get a prescription for it. So we're not prohibiting you from getting it. We're making it near impossible to get, but we're not prohibiting. And I wonder, so how do I tease out that argument that because they have given me access through a prescription process, that they haven't denied me my access?
David, if you
sure. I think important to distinguish between rights and privileges. Things like, my right to swing my fist is not really a right; it's a limited privilege. It ends where somebody else's face begins. Smoking can be seen that way. That you can do this, but you can't do it in a way that harms other people. When you get to a right to health, we're talking about an actual right. Something that's absolute and that ties into this idea of respect for others, the principles in public health about meeting people where they are, which answers Fiona's point about when somebody says, oh, you've got a problem, here's what we can do for you. So if I say, I need to get back to Canada very, very quickly, and you say, terrific, I can get you a bus to Berlin. Well, that doesn't quite do it for me. Just like for somebody to say, we can give you a patch. If somebody has a dependence on amphetamines, you don't say, I can get you an espresso. You're not meeting them where they are. You're not meeting their needs. And then that's a purely pragmatic aspect of public health, to say, where we find risk, we seek to reduce it. And we do that, like the World Health Organization says you're supposed to do, by working with people, informing people, giving people options, giving people realistic options. And that's why it doesn't make sense when you say things like, well, we don't need to make snus available because we've got a different product available. Well, what if that different product doesn't appeal to somebody and snus does? We wouldn't say things like, we're trying to improve the physical fitness of the population, and that's why we're going to build volleyball courts around the city. But that's all. No biking, no walking, forget about chin-up bars, no gyms. We've got the solution for you. You're all going to play volleyball. And we'll just tell you when you're playing volleyball and where you're playing volleyball. If you don't show up, you're going to get fined. That's the approach that we end up with on a lot of these sorts of policies. That ain't public health. That isn't pragmatic. You're not meeting people where they are. It isn't humanistic. You're not respecting people's autonomy. And it's those basic principles that work well. And I think we just have to keep applying these things to say, does that do it for you? Does this meet your need? Am I meeting you where you are? Am I understanding your experience? Am I empowering you to make a better decision about your own health? Because if you're not doing that, you are getting into the stuff about stigma and moralistic judgments and the just say no sort of thing. Or, if you feel that's your sexual orientation, you're not praying hard enough approach. We've encountered so many of these things, and again, it's the same pattern again and again and again. So the solution is the same things that have worked again and again and again.
Thank you so much for that. And I think it's time now to take the mics around the audience, and if there are any questions, I'm sure you. Okay.
Hello, thank you. It's been a great panel. I would like to ask, because in some countries, there's, it's kind of difficult, the engagement between THR NGOs and other harm reduction NGOs. Do you think that the problem could be that nicotine is not harmful enough?
It certainly kills more people than heroin in my country. Well, the device that provides the nicotine. I think it is really strange because, well, it's not. When we look at why people misuse heroin or misuse methamphetamines or other substances, we quite often go back to trauma. We go back to disadvantage, we go back to a whole range of reasons, and we haven't done that with smoking. And yet, in fact, but if you look at my country, disadvantage is an incredible predictor for smoking. the poorer you are, the more likely you are to smoke in Australia, and I'd say that's in every country. So I don't know whether that's it. I think we've all, just in harm reduction, we've all swallowed the evil of tobacco, the evil of the tobacco companies, and we haven't really considered harm reduction in tobacco. You know, we've just said, we've been handing out patches at the supervised injecting room where we're, allowing people to inject heroin more in a safer way.
I'd also point out that it is normal for people to, as they catch on to one aspect of human rights, to not get another one, right? And they have to go through that process again. So it's sort of like, I think it's wrong for Protestants to murder Catholics and Catholics to murder Protestants. Now those Muslims, right? Okay, now I get that, but what if they're gay, right? What if they drive an SUV? I think we tend to keep going back to these, moralistic things, and you have to work it through again and again, and it's the same process. I think that's just the nature of us as a species. That's how our brains developed. So we have to force ourselves to use those frontal lobes because our amygdalas get way too much work, and we have to sort of move it up and help people think this through. To look at the parallels, to say, well, isn't that a lot like? And I think that does help people, come around to it. Or why would you, not want to chain up somebody because they've got a mental illness, but it's okay to stigmatize somebody and force them out into the cold because you won't allow them to use nicotine in any way other than smoking it. That sort of thing that I think people can move on to it and get beyond the idea that it's a fight against evil. It's actually a fight for health.
Could we?
Thanks. I think this is enormously important to continue the work. And like with all these things, I think there's a lot of work to be done. But and I think there's sort of a couple of bits. First, I do think Jerry was right on the issue of why we haven't seen this taken on before. We need to also think back 20 years, where the smokers' rights issues were being pushed by the tobacco companies very heavily, and they were a threat to any form of tobacco control, whatever it was. So that was, partly forgivable. The second reason I think I've only come to see properly over the last few years is the fact that there's also a reluctance to address the personal aspects of cessation and everything that involved, and the real sort of diminishing the importance of health professionals in treating people who were smoking and wanted effective treatment, be it cessation or harm reduction. I think that is a big issue going forward, which also may give the clue to going forward. In those early years, there was actually a cross-UN structure where we would meet with the UN Human Rights Commission, UNICEF and others, and talk about coherent policy under the Framework Convention across the UN. And I don't think we stressed the human rights aspects enough for those reasons, but the one that did go a little further was UNICEF. And in fact, we managed to get funding to actually look at how the Convention on the Rights of the Child could be used to advance tobacco control. And a formal report was written. It's actually available on the website. But Carol Bellamy at the time didn't take it any further, so it died on the vine. And I don't know what happened to it. What I think now, looking forward, I would love to see is to really do a serious work, taking this really excellent draft report that we have, to look at where are the areas, the pressure points and opportunities greatest. And I think doing some basic data may very well help us ask whether we should link the access to nicotine replacement therapy to the access to harm reduction and non-pharmaceutical interventions together. And I say that because access to NRTs is accepted under the convention very strongly, yet, and it's on the WHO essential drug list, but work some of us have done have shown that the majority of low-middle income countries, the governments, have refused to actually act on that. So if they have failed to act on the access to nicotine replacement therapy, you can see that it makes it even tougher to think they're going to do this. But linking it together shows that the common thing is they're neglecting the smoker, which I think would be very powerful. Revising the access chart, and I would love to see a chart showing of all the countries that have signed on to the convention, which ones has government agreed to put nicotine replacement therapy onto the access thing, which ones have banned access to harm reduction products, where the similarities, and start trying to build the case to address both if we really want to accelerate the end of smoking, which is part of the brief. The last thing I'd say is that I think that very technical work would need to engage the UN human rights machinery. And there's no shortcoming. But while that's happening, I think this applies to most people in this room, the passion and the drive of building the NGO movement and case for that has to move ahead with politicians, and thrilled to have Fiona give us the guidance on that. And I would set an early goal to test this argument during the UN General Assembly the week. And there will be opportunities, and I'd be happy to talk to people how this might happen, even this year in September, because I think this could be a very powerful argument, particularly given that access is going to be very high on the list in the light of vaccine access being an enormously important issue. Thanks.
Thank you so much. Can we have the mic across to the gentleman there? One's going, yeah.
Hello, everybody. Well, this is more a comment from Panama, Latin America, which is actually happening right now. My legal mate in here wants to say some things in here. Well, in Latin America, specifically in Panama, the government has ratified many international agreements, right? Seems that there is a lot of internal or external interest in our country. These kind of agreements looks as a possibility to legalize this new alternative and provide well-made tobacco harm reduction policy, right? We have an article, the 15 of the International Agreement regards on economic, social, and cultural rights of 1966, this one is as an example. It does recognize the rights of Panamanians to participate within the cultural heritage and enjoy the rights of the scientific progress and all that applies within. But the economic interest influence into the decision over governance and also on the Latin American presidents, right? In Europe, we see that there exists a friendly regulation on a legal perspective. And we say friendly because at least there are some vape shops, right? But in Panama, that does not exist. Which kind of legal perspective was chosen, or which path was taken in order to make it effectively as it is? Kind of. Corruption exists all over the world, but there should be an effective way to achieve this. Thank you.
Thank you. Is there anyone else with some insights, perhaps?
And
Yeah.
sorry, at the same time, if you guys in there can at least shed a light on which kind of path was chosen in order to make at least the vape shops to exist.
If you ask for an Indian context, those don't exist. They exist underground, and we all have access to them. I mean, if that's of any help.
In Mexico, they exist because the original prohibition wasn't really enforced. There was some enforcement, but in the last month, they have closed most of them. So they are making a black market much more black, darker market. And yes, someone talked about cartels. I don't know if it was in the previous conference. That's a fear.
Yeah,
the fear is that now drug cartels will have an interest in selling these products, and well, you can imagine the consequences that will arise from that.
Yeah, we have an 87% of counterfeiting on tobacco, combustion tobacco in Panama. So you can imagine how it is right now in there.
Yeah. Just a very small point. I'm very pleased that there are people here from Panama because COP10 will be in Panama, and we need to help you make a lot of noise.
I think we might have just one question. Yeah, right.
Hello, I'm Ignacio Leiva from Chile, also from the campaign Vaping It's Not Smoking. My question is for Tommaso Gordman. We know the situation. What is your point of view in the future of Mexico? What you think there is something we can do there? It's so dark, and what will be the consequence that you can, in your perspective, what is coming on Mexico?
I left the crystal ball in Mexico, but you're asking the wrong lawyer. Juanito is other. But no, I think that at least against the new decree, we are collecting decrees. We have already 4 in this presidency. With this new decree, we have the ruling of last year from the Supreme Court, and I'm very confident that both stores and consumers will, I hope, really hope, will be protected by the judicial power from Mexico. The problem is that it shouldn't be this way. You shouldn't be forced to go to tribunals and to judges to defend your rights. At the beginning, when we were down there, I said that I think about law is that is, or usually is, mostly common sense. And harm reduction is common sense. It really is. But as Mr. Schwinner says, when your motivation is ideology and to impose your moral views in the world and to decide how other people should live their lives, well, the first thing that goes to the toilet is common sense, right?
Just a little thing in the same question. Do you think that Bloomberg presence there, we have people like the president and Gattel, that it's directly connected to Bloomberg. Do you think that we have an option to fight when they are that powerful in Mexico, in the political scenario?
I think that vaping associations and people promoting THR are in a very asymmetric relationship with tobacco control. Whether it is money, whether it is political power, whatever. The relationship is profoundly asymmetrical, and well, as long as they keep trying to unlawfully enforce the 5.3 clause of the FCTC, this asymmetry will remain.
I would also point out that money doesn't win a lot of these battles. I mean, having worked with a very small NGO and taken on big tobacco and won repeatedly, I like the line by Ernest Rutherford, which is, gentlemen, we've run out of money, we have to start thinking. And when you look at creative responses to this, and one that immediately comes to mind when we deal with Mexico, how many people in Mexico have died from violence because of US prohibition on drugs? I think it's about 250,000 people so far this century. And the response of the Mexican government when dealing with another drug is that prohibition's a good idea. I mean, I think that's something that's worth airing to say, where does that get us? What's the history on these things? We have seen the history of the US, of the stuff that Lisa Magura talks about in her book, The War on Alcohol, where US alcohol prohibition came from, which is the tendency to want to use the power of the state to impose your moral views on the behavior of others. It's just, this has happened repeatedly in U.S. history, not just in alcohol and birth control and narcotics and nicotine and but they have the resources and the culture to say we need to not just impose this on the people in our country but the rest of the world, which is why Jerry's had to deal with things like UN protocols on illicit drugs, saying you're not allowed to talk about harm reduction. I don't think it's a hard sell in Mexico to get people to say maybe we should stand up to some of the morality coming out of the United States. So I think that there are various arguments that can be made, but my history as a lawyer and an advocate is to look at the ideas. What are the things that might work here? What could get people's attention? Essentially, what takes us to the frontal lobes so we get people to start thinking?
Thank you.
And I think we win on that because we're right on the science. We're right on reason. We're right on humanism. The Enlightenment's on our side. How do we move this forward? And I think that there's always a way to do that, and there's lessons that we can learn from the history of other issues and the experience of other countries.
Thank you, David. I think that pretty much sums it up for us. I've already had a couple of warnings in my ear, but it was just a little too engaging, and so I kind of ignored it. But thank you. So thank you, everyone. I'm not going to hold you back from lunch. Thank you again.
Welcome to the commentary section of the conference, the last half of the conference program at the Global Forum on Nicotine in Warsaw, and it's a pleasure and honor for me to have two distinguished experts in their own areas of work related to nicotine and tobacco regulation. I'm Sudhanshu Patwardhan, Director for Center for Health Research and Education based in the UK, working in the UK and India in tobacco harm reduction. And I have with me Dr. Marina Foltea from Pacts, MD of Trade Pacts, Geneva-based consultancy firm, expertise in international trade law and public affairs. Welcome, Marina. And I also have Sam Hampshire, director, US-based Botech Analysis, a policy researcher and specializing in the unintended consequences of regulation. So that kind of gives a flavor of what we're going to have in terms of discussion. And it's perfect timing because we just managed to, between the three of us, attend the sessions before this. And just to read out what you all have been seeing around the world, and I've been told that at least 70 countries, people are watching this live, and that again kind of brings us to the point of this is a global forum on nicotine, so it has to have a global flavor. Why don't I start with Sam, and then I kind of work towards Marina in terms of what you saw in the previous session, what you think about how the conference is going. I believe this is the first time you're here?
This is the first time, yeah. So very happy to be here and grateful for the opportunity for speaking here. What a great conference. I mean, as you said, this is a global forum, and I think in order to do that successfully, you need to bring in multiple different disciplines, different perspectives. So having participants, viewers, an audience of 70 countries, Mark Tindall's pyramid of different researchers, activists, disruptors. I don't think that was his word, but let's call them disruptors. Shows some of the different kind of perspectives that are kind of being brought together. That creates a great discussion, which is exactly what's needed.
Yeah, no, I think you, and looks like both you and Marina managed to attend the session, panel 6, the prohibition by stealth,
Correct.
Using tax and regulation to block tobacco harm reduction. Marina, what was your kind of immediate takeaway from the kind of discussion happening there?
Well, why prohibition by stealth? Why is it called by stealth? Because we can call it prohibition, meaning that there will be a law saying that something is prohibited, so saying that EVPs are prohibited. But there is a whole category of measures there which are not called prohibitions in practice, but by being quite restrictive in their nature, they do have quite a prohibitive effect on the industry in case. So that's why the session actually looked not only on what we know as prohibition, that, for example, you take completely a product out of the market or you deny access to the market, but the product may be in the market, but it's regulated such that the effect on consumption almost amounts to a prohibition of that product.
Yeah, and look, I mean, you make a very good point, and this is very close to my heart in the work we do at CHRE, our center, and we work in disadvantaged populations in the UK, where this sort of string of words we like to keep on talking about, and affordability, availability, accessibility of products, tobacco harm reduction products, or safer nicotine products, call it what you want, but something that's got a scientific rationale for being safer than the current forms of risky products. And we see that any of these things are missing, be it accessibility, affordability, or availability. Mm-hmm. And ultimately, the consumer, current consumer, is definitely going to be impacted.
And I would add appeal to that list as well.
Appeal, of course. The 4 A's, I forgot. I was wondering, what's the 4? I was like, what am I missing? Thanks, Sam.
Well, no, I mean, I think it's important because, I mean, and as a distinction, I think it's important to say that when regulators choose not to prohibit, not to actually ban, either as a de facto or as a de jure approach, the unintended consequences that they're looking to avoid are not they're not foregone. So in terms of creating an illicit market, creating unintended health consequences, suppressing the opportunity to age-gate sales, these are all things that might stem from bans. They're also things that we see to be associated with overly stringent restrictions. Absolutely. And if you take desirable characteristics, that's the affordability component, if you take desirable characteristics out of the market, or if you take certain markets away from certain groups, then you're going to see those unintended consequences.
So how does this fit in? I just want to sort of throw it open for conversation. We talk about taxation has been touted, and there's enough scientific evidence base about how taxation has played a big role in reducing the tobacco use prevalence globally over the years. Would that be something you would agree with in principle?
Yes.
Yeah. And so affordability was definitely understood as a criteria for nudging people towards healthier behaviors or whatever the agenda was, but at least that was the instrument used to get people to have lesser affordability for risky products. And of course, that logically means that for them to have access to safer products, but affordable, you would think that the tax regime that's applied to this suite of harm reduction products has to be much more lenient. Is that right? Would that be the argument from a proportionality point of view or differential point of view?
Yes, the whole point of taxation would link to actually the risk, because the idea of excise has some risk element in mind. So the argument here is that the less risky the product is, the less the tax should be. And that's the economists that say that. Indeed, the high taxation is one of those measures which can inhibit the affordability. You can have the accessibility, meaning the products are there in the market,
sure.
So there is no trade per se restriction to import. They can be placed on the market, but then you make them unaffordable, and the effect is just the same if you do not consider the risk profile in taxing.
Any thoughts on that, Sam?
Yeah, I mean, I very much agree. I think that using regulation to create differentials to encourage consumers to switch to safer products has to be the goal. The key component of being successful in that approach is, I think, to also take steps to protect against uptake by non-smokers, particularly non-smoking youth. And I don't think those are exclusive trade-offs. I think there are ways that you can create differentials with nuances to signal to non-smokers that this isn't a product for them. And a lot of my work focuses on how to kind of outline that, how to detail those. Another thing I'll say about the creation of policy differentials is that we know these are substitute products. So when we're creating the differential, we're not only focused on what the details of the policy should be towards e-cigarettes, but what the details of the policy should be towards more dangerous alternatives, so combustibles. And if you have the availability of accessible, affordable, safer alternatives, that can actually allow you to ramp up restrictions on combustibles as a way to nudge consumers to safer choices as well. So as an example of that, I'm lucky enough to work with an econometrician called Jim Prieger, who's a professor of public policy at Pepperdine. He and I did a piece of work with some colleagues looking at the EU, and particularly how the availability of e-cigarettes attenuates smokers' tendency to respond to increased taxation by embracing illicit markets. If you make these products more available, more accessible, that tendency is reduced.
Yeah.
So if they're sufficiently available, then that unintended consequence goes away, which means you can get the desirable kind of health consequences.
It is so complex, isn't it? I look at this, and coming to the GFN, this is a decade plus of GFNs happening, and I've been there since the beginning, and I realize how the discussion, the complexity of the issues, but the discussion around all these issues have been now, there's a spotlight put on all of these, and I think what I love about the GFN personally is that there's a very clear attempt and successful attempt actually to bring these together in the same forum, the same place. And it really excites me to see consumer advocates who have always been a mainstay of this conference, which is important because, hey, what are we doing this all about?
Yeah.
This is about the consumer, right?
Yeah.
The current consumer who is struggling to get alternatives which are affordable, available, appealing, and accessible. And what are the roadblocks to do that? And I think legal arguments, international trade arguments, Marina, as you are an expert on and you have been analyzing, policy choices that governments and policymakers have to make. And I think not just policy choices by policymakers, but also folks at different levels of the hierarchy of decision making. Yeah. So, for example, I look at choices made by healthcare practitioners, and that's a topic that's close to my work, my heart, and that is, how do they make choices? Are they informed to make those choices? And it often comes down to what is being fed to them through emerging science and how they are responding to it. One thing I really loved about what David Sweener said in the other session that I was watching, and this was the one about safer nicotine, human rights and legal challenges. And that was a fabulous panel, and I wish we could have all of these happening one after the other, because with parallel sessions, you're always having to make very hard choices.
Yeah, trade-offs.
Trade-offs, hey, of course, yes, indeed. And that just shows that this, again, the breadth of the issues we are dealing with requires us to do this. I mean, I'm hoping that the conference stretches to at least 3 or 4 days from next year, which allows even longer and deeper discussions on a whole wide range of topics. But what David said, there was everyone should be engaging their frontal lobes. And of course, David is a lawyer, but he also has very clever analogies from medicine and from literature. He was quoting Shakespeare in one sentence and then giving such very smart insights into human behavioral decision-making sort of things. And I think that's a call he's making for policymakers, but also from the argument was about human rights and accessing products. And I think for the first time, all the panelists were saying that for the very first time, we are actually having clarity on the need for raising the profile of human rights, the natural right of a consumer to want and need these products. And often we have, over the years, kind of forgotten that consumers are even there, and there's a lot of stigma around it. Any thoughts from your expertise in sort of international trade, but also how does human right and trade and international law come in? And then maybe after that, Sam, you can touch on how does policy making and analysis around that fit with that? Marina?
Well, it's interesting that human rights is supported by a very complex web of international treaties. And when it comes to human rights and what is relevant for this debate, in my view, apart from the fact that access should be had to the products, it's actually the right to health. And the right to health has certain elements inside, and one of the elements is actually information. So every time the government feels or has data to show to the consumer that something could reduce harms in certain circumstances, they actually have the duty to inform the consumer. And in this situation, we see we have a bit of a challenge here that things are not really accepted, and as a result, the governments are not the ones to do their job in terms of information, because this should come from information. But governments have actually this obligation which arises from these specific treaties, and the right to health specifically. And then we move from health, we can move to another regime which links more to economics. We can say it's more pragmatic trade, so on. And that regime, if we speak about international trade law, the bans actually are a bit of a problem under this regime, because you shouldn't be banning products for trade. So they shouldn't, you have the right to export, to import, etc. And there should be certain very serious circumstances that you ban a product. And then an interesting element to add to that is that I have looked into discrimination, comparing the status of cigarettes compared to the new product, to only see that in some countries the e-cigarettes, e-vapor cigarettes are more regulated than cigarettes, which again misses the point of harm reduction and the fact that regulation should be based on risk. And this basing of the risk of the regulation emerges from different areas and different international regimes. And this is human rights, this is international trade law, this is investment law, and even humanitarian law. You know, when we conduct, not we, but when some people conduct war, the attack should be, or the counterattack should be proportionate to attack. Mm-hmm. So this same philosophy applies actually in all the other areas of law. And with regards to specific products like e-vapor products.
Sure, and I think if I was to just extend that analogy, I think you very specifically mentioned about e-vapor products because that's the area you're working and researching
Exactly,
on.
yeah.
And I think when I look at harm reduction, I actually I take a step back. And Sam, I want to come back to you on this question, but I just want to just mention one thing which struck me as a very strange paradox because I was looking at the right to health, the human rights angle in that session, and it reminded me of this fact that the WHO, the World Health Organization, has, you may or may not be aware, has an essential medicines list. And nicotine replacement therapy products are on that model essential medicines list.
Exactly. Yeah.
And then countries which actually have now effectively banned certain types of products also have they're copy-pasted because that's what the expectation is. The WHO has a list, and then countries take on things from there which is relevant to them. For example, India, where we work, has nicotine replacement on their essential medicines list. Now, that doesn't translate into the fact that nicotine gums and lozenges, at least, let's move to e-vapor products afterward, but even the basic approved nicotine replacement products are not available. They're not affordable, but they're not even available, and they're very rarely available in pharmacies. And then, of course, healthcare practitioners are not even trained enough to prescribe or advise their patients on how to use them. So we suddenly get into a space where, and then the same global organizations, and the same global organizations are also, for some reason, at the forefront of prohibiting harm reduction as a principle. Forget specific products. What is influencing the policymakers, Sam, and then we'll sort of wrap up.
So much to say here. Let me go back to the first question and then try and come at the second one.
We have about a minute and a half, by the way.
A minute and a half. Okay. Well, let me try and make it very quick. Anyone watching this will recognise that this is a polarised debate. Through that debate, there has been one persistent line, and I'd say line rather than lie, but that there isn't evidence. There is evidence. And when we present this as a debate that's detached from the evidence, it becomes about values. We all have, there are different values. What we're talking about here are different elements of the conversation, and there are different values that might be attached to that. But we need to keep it about what the evidence suggests. So that was one of the reasons why the conversation about stealth prohibition was so effective, because we can begin to see the unintended consequences of regulation. We can begin to see the unintended consequences of not educating stakeholders, not educating consumers, not empowering healthcare providers to have those conversations. And so the path forward is increasingly clear. And I think one of the reasons why it is clear is because we've provided a forum to have that conversation.
No, absolutely agreed. I think what I see as the kind of where to from here, we all pack up at the end of the day today, go back to wherever we are working, you to the US, you in Switzerland, I'll go back to the UK and to India for every so often to continue our work in this space and trying to sort of bring sense to the conversation around harm reduction and how it should be practically implemented. I am looking forward to the next few years of hopefully what we have seen and started here over the last decade, but it getting amplified and really use the network effects of what we have started talking about. Always with the consumer at the center, I hope. That's the key. And I keep on trying to remind people, and of course, it's not for just one or two of us to do that. I think we should look around and we have to be reminded that this keeps us sort of
accountable.
Yeah. And I think it's also a very objective debate. We shouldn't let emotion overrun this. It's about engaging the frontal lobe to say, look, let's just be objective about the decision-making process. But what a great thing to have such diversity in terms of expertise and geographical spread as well, in fact, I realized later.
Absolutely.
It's a great event and brings in people from different backgrounds. So it's quite unique in these terms.
Yeah, I wouldn't have imagined 20 years ago when I finished medical school that I would be sitting with an international law expert and an international policy expert and discussing tobacco and nicotine, which was always sort of just a problem, solve it, tell a patient to stop, and that's it. But
I also never imagined I could sit in the same room with psychiatrists, for example.
Yeah, that's true. I think it's so many different stakeholders, right? And they all have a role to play. But look, I will wait for getting the signal to stop this. Until then, I will keep on talking, obviously.
Let's do it.
Good. So look, thank you so much, Marina and Sam. And
thank you.
I will let those who are watching this live and hopefully people watching this later on to catch up and pick up on things. All the best for their contribution to tobacco harm reduction, because let's not forget, all the stuff we do here should be with the mind that 1.3, if you count the smokeless tobacco users globally, 1.3 billion people will be positively impacted by your actions. And not just 1.3, in fact, because they are the users and their families, their social circle, their society, their country are impacted equally. And so let's do that. Let's keep that in the mind in every action we do. So with that, I will pass on to the production team, and thank you so much for listening.
Thank you.
Thank you.
Thanks.
everyone. Welcome this afternoon to our third and final keynote session on community, regional networks, and tobacco harm reduction consumer advocacy. My name is Chem. The keynote is from Nancy Lucas. She's a global tobacco harm reduction advocate who is passionate about consumers having their voices heard in the narrative of tobacco harm reduction and public health policy. She's participated in developing a number of consumer and advocacy groups, including the Coalition of Asia-Pacific Tobacco Harm Reduction Advocates. She was also instrumental in the coordination of the SCOPE live stream events that ran during the FCTC COP9 in 2021 and on World No Tobacco Day in 2022. After Nancy has concluded her talk, I'll be delighted to ask Amanda Wheeler, who is the president of the Rocky Mountain Smoke-Free Alliance in Colorado, to share her thoughts. But for now, please welcome Nancy Lucas.
Okay, I feel like I'm being interrogated. These lights are really ridiculous. Thank you, Chim, and thank you for the GFN organizers for inviting me and giving me this opportunity. And hopefully we all learned something and I don't screw it up, because I'm the only keynote being done in person, so you get the live experience with me. Can we get the slides up, please? This happened the last time I did this too. It's me. Okay. There you go. My presentation today is about community. It is about how regional advocacy works by having different organizations in one region working together to get to the goal for tobacco harm reduction in policy and regulation, and educating people about it as well. Let's see if I screw this up. Yay! Okay. We have these organizations. Now, I'm not going to go through each one, but we have organizations in the Philippines. We have an organization in Thailand, which is ASA. We have a couple in Indonesia. We have New Zealand, which is AVCA, which is where I got involved in all of this. We have Korea, Hong Kong, Malaysia, and we have Factasia from Hong Kong, but actually it's in Thailand as well. What did I do? Did I break it? Okay. Oops. CAFRA represents and supports all advocates and issues in the wider Asia-Pacific region. Now, we do have organizations, but we also support individual consumer advocates. So we're not like, you must be in an organization for us to help you. Because we understand that what happens in one country impacts another country, and we also remember being solo advocates out there. So when we think of CAFRA, don't think of just the organizations, think of all the advocates, because we're here all to help each other. A country doesn't, because because sharing knowledge is the key to winning this war. Now, when I talk about Asia Pacific, and I think I screwed this up, we know that tobacco harm reduction saves lives. In low and middle income countries, and I'm just going to put this out there, even though I'm talking about Asia Pacific, what I'm talking about also relates to Latin America and to Africa. And when we talk about lower and middle income countries, we're talking about developing countries. I do not like the term LMIC. To me, it's derogatory. Whereas if you say developing, it's more hopeful, okay? So you'll hear me say that. The majority of the global health harms from tobacco happens in low and middle income countries. Now, focusing on Asia specifically, okay, of the 1.1 billion smokers globally, 664 million of them live in Asia Pacific, okay? So that is, it works out to approximately 60% of people, mainly smokers, and I don't mean to just not include oral tobacco, unsafe oral tobacco in India, but 60% of smokers globally live in the Asia Pacific region. People have asked, why do we do regional advocacy? Why did you guys get together and set up to do this? There's a couple of reasons. Even though it's a vast region and it covers a lot of area and it covers many different languages, many different cultures, and many different religions, the similarities are stronger than the differences. Now, in Asia Pacific, we share challenges, the same as what they're dealing with as well, like I said, in Latin America and in Africa. Most of the countries in the region, like I said, are in the developing world. And we share the same socioeconomic issues. We influence each other on policy. And when I say that, I'm thinking to myself about if something happens in Malaysia, it actually winds up happening in Indonesia and vice versa, okay? It's I want to say codependent, but that's really not the right word. It's just, we influence each other with what we do, okay? Most of the countries in Asia Pacific, not all of them, but they do have tobacco manufacturing, governments have interests in tobacco, and some countries also have interests in pharmaceutical. And this is part of the challenge of tobacco harm reduction. We're also, all of our countries are also targets for, what do we call it? Philanthropic colonialism. I can never say that right. Okay. These are all messed up, guys. There's something wrong. I'm just going to read from here. It's me. Sorry, guys. Here we outlined the government interests in tobacco growing and manufacturing, okay? With the exception of Oceania, Brunei, and Singapore, tobacco is grown in most Asia-Pacific countries, okay? And the biggest tobacco company in the world is the China National Tobacco Company, followed by the India Tobacco Corporation. You can see the numbers there, 2.13 million metric tons, 804,500 metric tons annually. That's a lot of tobacco. In saying that, as well, Latin America and Africa also have the same issues with tobacco production and government interests. Let's talk about the elephant in the room. The elephant in the room is foreign influence in the development of tobacco control policy. We've all dealt with it. We've all heard about what's gone on. What you might not know is that this is part of a wider plan by these certain billionaire philanthropic people to influence policy against nicotine, okay? And what they do is they're taking advantage. It's actually predatory if you really think about it, because you have countries here that don't have a lot of money, they don't have the resources to develop their own policies. So when these people come in, and they know this, they come in and say, hey, we can help you with this, with a scripted policy, you can implement this, and we will help you implement this. The problem with that, okay, is you're taking a policy that was devised in the developed world and bringing it into a developing world without any consideration for culture, economics, and what these people really need. Governments, for the most part, with the exception of the Philippines, which I'll get into in a minute, think it's manna from heaven, and they accept it. It serves their purposes as well, especially if they have tobacco interests. We all know that China, India, these countries have gotten awards from the WHO for the tobacco control policy, and it makes no sense. It's cognitive dissonance, because these people are actually manufacturing and distributing tobacco, and they benefit from it. So there's this whole miasma, okay, of just hypocrisy, okay? And nobody thinks about the people. Nobody considers what is best for the people. Now, Asia Pacific, I keep hitting into this thing. Asia Pacific, from a cultural standpoint, shares a collective mindset. Now, this is what separates a lot of the people in the developing world from the developed world. In the developed world, people operate from a very individual rights perspective, okay? Whereas in these developing countries, it's a collective mindset. Some would say tribal. I don't want to go there because it doesn't apply for everybody, but it does in some. And when you're dealing with the collective, people operate as to what is best for the group as opposed to the individual, okay? I remember growing up in the United States in the previous millennium, that this was kind of common then too, okay? It changed in the 80s, I'll let Amanda get into that, but a collective mindset is we do what is best for the whole, not for the individual. So the individual is not king. This helps us, I'm blinded from the light, by the way. Can we turn that light down, please? Literally, I'm blinded by the light. Sorry, we're gonna have to do it this way. Sharing, because of it's a collective mindset and because of the lack of resources, one of the things about regional advocacy is that we can share what we have. If one country has research that we can use and share in another country, that's what we do. If one consumer organization has someone, for example, in the Philippines, we have a lot of lawyers. They understand law, okay? It may not be the law that's happening in New Zealand or the law that's happening in Malaysia, but we have someone who understands law. In Thailand, we have someone who understands healthcare, okay? New Zealand, we have someone who understands research and scientific research and reading papers. Sharing resources. This is probably the #1 benefit of regional advocacy. One of the first things that we decided that we needed to do was to get ourselves an expert advisory group. Now, these are tobacco harm reduction experts, scientists, researchers from within the region, because it is much easier to have somebody who is in that region, who understands the context, who understands the culture, to go to someone in government and say, hey, listen, this is the science. It also doesn't feed into colonialism. And a lot of these countries now don't want a foreigner coming in telling them what to do, not in that way. They'll take the money, of course. We're not going there. But you know, they want their own research, because there's many times people have come in and said, well, how does this relate to us? As if the physiology of a human being changes from one country to the next. It's happened. So this way, with the expert advisory group, we've got a local person who has local knowledge, local context, and can go in and talk to these people, and they can't give you those kinds of excuses. Now, right now in Asia Pacific, unlike the rest of the world, and it's kind of odd because I never would have expected this to happen, we're in a paradigm shift. And what I mean by that is we're going from a place where there's bans and restrictions or no regulation to now countries are beginning to consider and actually implement regulation. If you'd asked me this 2 years ago, I would have been like, no, that's not going to happen. And here we are. It is happening. The way we did this, and we actually all sat down and talked about this, is how did we manage to do this? Well, networks. In a collective society, network is key. Not money, network. Who do you know? And how can you get to that person? So if my cousin knows the Minister of Health, I'm going to go ask my cousin to give me an introduction to the Minister of Health, okay? By doing that and explaining, listen, this is what we want to do, this is why we want to do it, but most importantly, this is how this will benefit you, we were able to do this. And I'm thinking of Malaysia. I kind of wish Sam was here to explain it to you, because it was a very long process, but we got there in the end, okay? So when we think of advocacy and we think of we want what we want, one of the things that we did, and I don't know if other countries have done or other regions have done this, one of the things that we did was, let's focus on how this will benefit them. You couldn't use the healthcare argument because there's no real socialized healthcare in the region, but you could use the argument of, hey, you know what? You could tax this pragmatically, and especially in light of COVID, okay? You guys have lost a lot of money economically. So if you tax it, you'll gain some money back. And I think that's how we managed to get it past the post in Malaysia. I would say probably 95%. So the benefits of regional advocacy. We share knowledge, resources, and information. We support each other with submissions, testimonials, and commiseration. What I mean by that, if there's a submission in Thailand, CAFRA will submit something, ECST will submit something, OVCA will submit something, the Vapors will submit something. So we all hit them at once, okay, from the region, okay? Again, if I have science or a report comes out from, say, New Zealand, and it'll be beneficial for Malaysia or Thailand, I'll give it to ASA. I mean, the regulations for New Zealand, I wound up handing it to, like, I think every country, because here's your template. And they were able to take it, adjust it, and present it, okay? that is a resource that is pretty priceless, I think. And having people that you can talk to and having people who understand what's going on and accepting the fact that, here, like for New Zealand, for example, I handed those regulations over to the Philippines. And I said, guys, this is what we did. This may not work for you. Do what you have to do with it. I don't own it. No, none of that. Just here is what we have. We have an example. And everybody adjusted it and amended it to their country. And I think Asa would probably say that that helped him get through to the ombudsman in Thailand, because here it was done for them. You know how the philanthropists go in there and try to create restrictive regulation with a script? We hit it the opposite way. We want regulation, here's a script. And we find that that works, because we were playing their own game. I did it again. Okay. I do have a final point, and there's something that I think we need to acknowledge. I don't know how many people are in here because I can't see a damn thing because of the lights, but regional advocacy is something that can make all of us better, okay? It's not been easy for us to do this, but one of the things that we've noticed is that we've had people from Africa come to us and we've had the people from Latin America come to us, and we help them, okay? Because we know where they've been and we know where they're going. We're gonna try to help them get where they want to go, okay? Because of the collective mindset, I think this is something that needs to expand out globally. I think we all need to work together and kind of leave our egos at the door. I think a lot of times, and a lot of the problems that we all run into is because of the ego thing. Collectively, we don't deal with that. I mean, we've had a couple of issues, but we all understand that we're all in this together, and we carry each other along. And the nothing about us without us, that has to be all of us, okay? It can be done. It's not the easiest thing in the world to do, but if you approach it with respect, if you approach it with understanding, and you give people the consideration they need to just be who they need to be, I think you can get it done. I really do think we can get it done. So I just want to thank everybody. I kind of ran through that really fast because I'm really nervous and I'm blind. Thank you for joining us. And I guess, Amanda, you're up next.
Myself situated here. It is very bright up here. Thank you, Nancy. It's really wonderful to hear about all of the amazing progress you guys have been able to make in the Asia-Pacific region, and I think that's very inspiring to those of us around the world, very much so. My name is Amanda Wheeler. I'm a working mom and a small business owner. I'm also a former smoker who could not break free of cigarettes even after surviving cancer at a young age and going through chemotherapy. Cancer was not enough to get me to quit smoking, but vaping was. That's why I'm very proud to lead on this issue and speak for our cause, especially if that helps shatter the stereotype that vapers are either oddball eccentrics or hypnotized teenagers. I'm also grateful to be here because this conference is exactly what open discourse and deliberation on public health science ought to be about. Ideas are presented and challenged. There's a wide variety of stakeholder voices. Policy proposals and ideas can be tested by the intellectual marketplace of public debate. I'm here to carry the voices of our many small business members in the United States and to support the countless consumers that rely on their help and guidance to quit smoking every day. But that spirit is not what is happening in the broader public conversation about vaping and tobacco harm reduction. Outside these halls, it is unaccountable, domineering institutions like the World Health Organization, the Food and Drug Administration, and Bloomberg philanthropies that dominate the discussion. We owe it to both consumers and to one another to speak out candidly about the suppression of public discourse that is taking place. By their every action and policy dictate, you can see a consensus among these powerful organizations to impose a prohibition regime on vaping and to shut down, intimidate, and criminalize anyone who dares to object. The WHO is on a global march to outlaw vaping, knowing it can strong-arm developing countries that depend on its resources. Just days ago, after WHO officials descended on Mexico to cajole its government ministers, that country criminalized all vaping products. Bloomberg Philanthropies works hand in glove with the WHO and shovels them tens of millions in annual funding. Bloomberg's fingerprints and front groups are visible in the prohibition schemes being decreed in every corner of the globe, including, most recently, a partnership that his front groups touted with human rights monster Rodrigo Duterte in the Philippines. As of just a few weeks ago, the Food and Drug Administration in the US now has gained a comprehensive stranglehold on all vaping products of every type of nicotine in the United States. The agency routinely lavishes funding on pseudoscience to hype theoretical harms from vaping, while reflexively downplaying vaping as a smoking cessation method. They have denied millions of products from the market, while Bloomberg's front groups brag openly about their close rapport with the most senior FDA officials. And notice, please, that these groups don't seek to persuade. Their aim is to dictate and enforce. Although they may show up occasionally at conferences to mouth platitudes and pretend to take part, the real proof is in how they ostracize and disregard the very people who are the most negatively impacted by their policies. I invite you to take a casual look at the social media feeds of these organizations where they make their pronouncements to consumers and the public. There you will see an endless scroll of ordinary voices pleading with them for dialogue on both the science and their individual experiences of how vaping is helping people every day to quit smoking. But there is zero engagement. These groups never reply. They don't even attempt to offer meaningful acknowledgement. Forget about empathy or accountability. When he was asked about these public complaints in a recent interview, the new head of the FDA, Dr. Robert Califf, simply laughed. He declared, quote, "I'm 70 years old. I'm relatively impervious to critique. After surviving a harrowing confirmation process," he chuckled, "what are they going to do to me now?" And while he was on a comedic roll, Califf also added that he has a few quips about the public input. Quote, "The intensity of the heat emitted by what I call the Twitterati, people who like to comment on FDA decisions, is inversely proportional to the quality of the evidence. And like that, we are all dismissed." This is breathtaking arrogance from a public health official, and it ought to outrage every one of us. It reveals the actual undisguised attitude that our public health overlords have towards tobacco harm reduction. In their eyes, we are just the little people whose lives they can manipulate like tiny avatars in a video game, if they even think of us at all. My organization, the American Vapor Manufacturers Association, has written both Dr. Califf and his predecessors repeatedly, and we are routinely ignored. Dozens of the leading tobacco science thinkers have written Bloomberg asking for a private conversation about the latest research, and they too have been utterly rejected. Many of these same thinkers signed an open letter to the CDC chief, Rochelle Walensky, urging her to set the record straight on that the Uvalde outbreak was not caused by nicotine vaping. But unsurprisingly, she said nothing and did even less. When FDA was granted sweeping control over all the remaining nicotine vaping in March, it was done with no public hearings, zero debate, and inserted as a midnight rider into a completely unrelated spending bill. Here's the worst part. Agencies like the FDA and CDC know better. FDA has been forced to admit that a handful of nicotine vaping products are, in their jargon, appropriate for the protection of the public health, precisely because the science shows they are vastly safer than cigarettes. But the FDA has done nothing to promote that life-saving message. And if I say to one of my customers that vaping is a great way to quit smoking, that same agency says that I'm violating the law. The CDC itself investigated the Uvalde outbreak and found that it had absolutely zero connection with nicotine vaping. And yet they sit idle while the vast majority of Americans remain deceived by the agency's own misinformation. The one safeguard we are supposed to have against unaccountable power is the news media. But they are not merely failing in their duty, they are sucking up to the very people they are supposed to be scrutinizing and pushing clickbait scare stories that have vilified the most successful smoking cessation method ever devised. And I'm looking at CBS News, the Associated Press, Politico, the New York Times, among many others. They refuse to hold FDA or the CDC's feet to the fire, even as the public is being egregiously deceived. More than 70% of Americans now wrongly and falsely believe that nicotine vaping is as or more dangerous than smoking, a figure that has gotten worse in each of the last 5 years. Where are the stories on the countless people using flavored vaping products to quit cigarettes and how the FDA is stripping those products away from them? Where is the coverage of how vape shops that are helping marginalized communities to break free of cigarettes only to have their businesses crushed by arbitrary regulations? Where is the investigative reporting on how the most rabid vaping opponents in Congress are major investors in tobacco stocks? There was a time when a story about a maniacal multi-billionaire hijacking public health policy with bribes and deceit would have been a bullseye target for the press corps. But now that kind of reporting is completely absent, to the immense disgrace of journalism. So let's say it plainly. The activities that I am describing are corrupt, they are unethical, the prohibition policies that are being imposed on the public are actively causing immense harm. And that means that in the big picture, the period of prohibition arrogance we are in today will soon be remembered as one of the worst episodes of regulatory malpractice in modern history. And shame on us if we sit on our hands while this neo-prohibition scheme steamrolls the communities that are counting on us to lift their voices. I know that there are some here who have urged conciliation in this crucial public conversation, but that diplomacy requires a good faith dialogue, a two-way street that respects the input and dissent from all stakeholders. However, we are way past that point now, and it's plain to see that this prohibition is an absolutist posture. It thrives on hubris and moral certainty. It mocks critics, and it demeans individuals in favor of the collective. But everyday consumers don't need a history lesson. They can see with their own eyes how the prohibition juggernaut is crushing their right to switch to nicotine vaping and take charge of their own health destinies. Consumer groups like our friends at CASA in the US have gathered tens of thousands of those consumer testimonials. A common theme in nearly all of them is a hardening anger that their voices and their very lives are treated as irrelevant. Not a day goes by in my vape shops when senior citizens, soldiers, veterans, moms and dads, customers from every walk of life don't voice their indignation about how their own choices, about their own lives are being stolen from them. The scientific case for tobacco harm reduction has been amply made at this conference and is well known to all of us here. What's more, we are talking about a fundamental human right to make our own lifestyle and healthcare choices. That's why my advice to advocates and consumers is let's speak up louder. Let's join arms with others facing the same challenge. No one, not a pope or a king or the New York Times or some unelected bureaucrat, has the right to control what I do with my own body. The only way those forces will succeed is with our obedience, and my answer to that is no. That is also why everyone here has the same moral duty to say once and for all that enough is enough. Thank you.
Yeah, that was brilliant. Thank you very much for a truly inspiring presentation, Nancy, and a fascinating response, Amanda. Now let us move on to our Q&A session. For our audience online, please put your questions in the Q&A box. I'll read them out for you. And for the questions and comments in the room, please just raise your hand and the mic will come to you. Yeah, let's start with questions from the room. Yes, I see a hand over here already.
Michelle Minton from the Competitive Enterprise Institute. Nancy, I wanted to ask you a question of, a lot of your work involves advocates and advocacy within developing nations. And I was wondering if you can describe or talk about any of the challenges that you might have encountered in terms of technology, of helping these advocates on the ground, these groups connect with, just, the actual ability not to coordinate, for one, to have resources to engage in advocacy, but then just to have the ability to speak with or communicate with the people in the power structures where they live, the people, the decision makers where they live.
Okay. in some of the countries, and I'm going to use Thailand as an example, you know, it was very difficult, and I really don't want to speak to it too much because Asa is here. However, I will say that, again, in some countries, it's a network thing. If you know, if your cousin knows this person, and that's how you get to the top to talk to people. In other countries, it's a matter of the way you do it will enable you to be able to do it. And you know, in other countries, it's you have to do it through the back door. You know, we're not talking about democratic countries where they have an electoral system and they have an MP's office or a congressman's office that you can contact. A lot of it is done grassroots. A lot of it is people doing protests within reason. A lot of it is talking about it within reason. You know, I'm here to say to them, listen, whatever you need, you tell me what you need, because there's so many different ways of doing things, and it has to be appropriate for the person in their country within the framework that they have. As far as technology is concerned, they've got better computer equipment than most people, let's be honest, okay? Internet can be an issue, but you know, graphics, computers, things like that. The people in Asia Pacific are probably the most creative people I have ever seen, as far as graphics, as far as creating things, as far as, you know, online webinars and things like that. They know how to communicate and they know how to do that well. But a lot of what they do, they have to do it more, I don't want to say occult, but I want to say it's more getting people together and then doing it differently than it's done in the West. And I hope that answered your question.
Thank you.
Right, let's go to the next question. Right, all right, I see a hand over here. Right, and another one there, so we'll go from here, then we'll go there.
It's not really a question, it's kind of a thank you to Amanda for let's see if that's working. Okay. So it's John from the UK. A thank you to Amanda and to Nancy for speaking and sharing what you've got going on. I wanted to just speak to something that you raised about, you know, people blocking the truth, the real science. People may have noticed that there's a number of people that are missing from this event that we normally see, that we normally hear from. And the UK is regarded as being a good place for tobacco harm reduction. The reason that most of them aren't here is they're having negative pressure applied to them by organisations within the UK. Just wanted to make people aware of that, you know, actually we haven't won the fight in the UK, nowhere near.
You know, something that I find very interesting is, you know, the countries that we all looked up to, that look at how open they are and look at how free they are and look, you know, how pragmatic they are. It's almost like everything's been turned upside down. And that plays to what you're saying, John. You know, I mean, we use references from the UK to get New Zealand going, you know, but yet, you look at New Zealand and then you compare it to Australia and they're worlds apart. They're just across an ocean from each other. This pressure that's coming down, okay, it's insidious and it's in every level of public health policy. And I think Matua has covered this, it's the McCarthyism session. When you have your scientific researchers and public health people and people who are really motivated and have integrity and they want to do the right thing by people, and that is being held back by these people that want it done their way, we have failed and we are failing. And I mean, looking at the UK, it actually depresses me because how did this happen? When did this happen? And it just shows you the power that these people have. And that makes it very important for us to raise our voices, such as what Amanda said. Okay, they may not listen to us, but if enough of us are loud, there's enough of us, and we are loud enough, they can't ignore us.
Right. Thank you very much. We have a question from our online audience. I'll come to you later on, but. Let's just quickly take one of the questions from the online audience, and it's going to both of you. And the question is coming from Paul, and he asked, what can the Australian advocates do better to have their voices listened to?
Well, so Nancy and I had some conversations about our presentation here beforehand, and as someone who advocates on behalf of small businesses in the West, I really wanted to understand where she was coming from and what the differences are throughout that region, because the challenges where Nancy is at and the strategies that are successful, while they may have some things in common, there are very significant cultural and societal differences that we can't really ignore. And so, I don't want to overstep on Australian policy. I have never even been to Australia, and I'm not quite sure what their government structure is like. I think Fiona's probably the best person to speak to that subject, really. But I can say what has proven successful in the U.S. and if any in the successes that we have had in certain areas, and if anybody from Australia can benefit from any of that information, if it would apply there, I think that would be wonderful. I'll talk about my state association in Colorado and the big fight that we had this year with the attempt to ban flavors in the state, which has been going on for several years, both at city level. We've had about 45 of these city fights throughout Colorado. We've lost, I think, 8 of them, which, it's always very painful to lose one of those, because not only are people losing their businesses, the people who smoke in that town are losing their options. And so, but we have been fortunate to win quite a few of those city fights. And then on the state level there, we were successful in defeating the flavor ban there. And that was a combination of things. One, Nancy brought up when she was talking about this taxation argument, which is a problematic discussion, I understand. But, for better or worse, we fought the tax fight in Colorado and we lost. And so, for a number of years, we've had a very steep tax there. And it was helpful during the flavor ban, because that money in Colorado is used to fund universal pre-K, which was one of the governor's key campaign promises. And so he's loath to have that revenue lost and endanger one of his central programs that he promised to the people. But beyond, sort of a cynical money argument, one thing that we've always done there is we've built a very big and very large and vocal coalition of mostly small business owners, but most of us small business owners are consumers, and we own our businesses because we're passionate from our personal experience. So we have a very large coalition of all types of small business owners, women-owned businesses, minority-owned businesses, businesses that are owned by immigrants that came to America to pursue their dreams and have succeeded, and consumer voices as well. And we're also very fortunate, and a number of policy experts are in the room here that assist us and come speak out in those fights. So between having PhD public health experts, policy and think tank experts that really do great in-depth research on the consequences of these things, consumers, small businesses, we're able to put up a pretty strong defense. In Colorado, Campaign for Tobacco-Free Kids built up this 100 organization coalition that had something in the range of 200 lobbyists representing them. The newspaper there said it was one of the most heavily lobbied bills in state history, and everybody was assuming all of those lobbyist numbers would be coming from the big tobacco side, right? But in reality, if you look at everybody that was opposed to that flavor ban and the number of lobbyists that they all had collectively on it, we were outnumbered about 3-to-1 with Bloomberg-funded lobbyists. And so I think the way that we really held our own is by getting everybody that had a common interest in this together, and to put their kinds of petty beefs and differences aside and focus on what was really central, which was preserving harm reduction and flavors in that state.
And I agree with everything that Amanda just said. And I think because I do have some knowledge of what's going on in Australia. I think what has to happen is everyone has to try to get along. The vendors need to understand that without the consumers, they don't have a business. The consumers need to understand that without the vendors, they have no access. And Australia is a very strange situation because as of last October, they're a medicalized system. Okay?
Thank you so much. Let's move on to the next question. I think we had a hand over there. Then we'll come to you, sir.
Thank you. Thank you, Nancy. Thank you, Amanda. They were both really informative and really great presentations. I had a question. I think it's probably more directed at Amanda, but Nancy, you might also be able to help. Has there been any research into the work that vaping shops do? Because the stores themselves play an intrinsic role in rolling out this harm reduction. And it just struck me that we don't seem to talk about that enough, the importance of the conversations that you have with your customers, the link, the way that vaping stores quite often link consumers to bring consumers together so that they can advocate. And I was wondering if there had been any research on vaping stores in general, on the work that they do, or if there's any plans underway to do that.
You know, there may be, you know, a few isolated things that aren't coming to mind at the moment, but as far as I'm aware, our segment of the marketplace and of harm reduction activity is very rarely looked at, right? And there are a lot of reasons for that. You know, on the anti side, you know, it's not in their interest to acknowledge that anything other than big tobacco exists in this space, right? And on our side, you know, we haven't been fighting these big flashy political fights for decades. You know, we're sort of learning the things that we need to be doing and the kinds of data that we need to be collecting and what we need to be putting out there, because, you know, we're you know, it's been a long fight. It's going to continue to be a long fight, and I think we're evolving and learning new things all of the time. One thing that I would recommend to anybody who hasn't seen it was during the recent e-cigarette summit in the United States, a wonderful vape shop owner by the name of Mark Sliss gave one of the best talks I've ever heard in all of harm reduction advocacy, and it was exactly his firsthand experience of what occurs in his vape shop and just how special that is. And it was so moving to me. I mean, it just really stands out as one of the best talks I've ever seen. And so, you know, I think I was so happy to see his voice elevated at that event and for him to have the platform to tell that story. And so, you know, my hope would be that more of those types of stories continue to be told, because you will be hard-pressed to find someone more passionate than a small business owner who works with his consumers, his customers, face-to-face. You know, small business owners, when we see our customers pull up in the parking lot, when we see their car, we're pulling product off the shelf for them because we know what they want. We know their spouse's name. We know their children's name. We know what they do for a living, you know. And not only that, but when people, you know, want to start looking into vaping for the first time, it's an overwhelming experience, and it's very easy to have that first experience with vaping be with the wrong product. And people will walk away and say, well, I tried vaping and it didn't work for me. And it just turns out with a little more tailored help, they would have had a lot more success. And that's really what's special about the vape shops, is that is that place of expertise and knowledge, and it's not factored in. And the FDA places no value on it. As I mentioned in my response, you know, it's you know, almost a criminal act for us to, you know, say certain things to our customers. And so we have to be very careful about how we advise and guide people. And I think it is something that should be looked into, because vape shops should be able to tell their customers the truth.
I think you should document it.
Yeah.
I mean, we did that in New Zealand, okay? Before the new regulations came in, we were doing tracking of the people that came in, and we were getting their stories, and we were getting their information. And then the vendors at that time, the one that comes to mind is Mike Brader. He became a resource for the Ministry of Health so that they could see the effectiveness of what they were doing. I mean, like Amanda said, the majority of the vape shop owners, pretty much all of them, okay, they're former vapors and former smokers. And the reason they got into this is to help people. And that's one of the issues with Australia. And I know it's not your fault, Fiona, but that's one of the big issues with Australia is people helping other people. If you medicalize them, you turn them into patients, they're not going to want that. And that's a lot of what's, the problem is in Australia, going back to what Paul was saying. And that's how a lot of these people actually wind up moving from being people who smoke to being people who vape, is people helping people, everyday consumers. It's hard to track in some countries because, again, as you know, it's illegal, okay? And the problem with that, of course, is because it's illegal, it's black market. And it makes it even harder to trace. But I can tell you in a very unofficial way, that's how it happens. It's not through any kind of official means. It's through the vape shop owners because they understand, because they've been there and done that.
All right, thank you very much. We have another question from our online audience, then we'll come back to the room. The question is coming from Sarah. She says, thanks for this session. To the whole panel, here's the question. What do you see as the biggest challenges for tobacco harm reduction consumer advocacy?
I think burnout. You're constantly fighting with people. You're constantly, sometimes it feels like you're going one step forward and 2 steps back. That's one of the big issues. The other issue is the isolation. There's a lot of people out there that are fighting for this and don't have support. They're sitting, in a back bedroom somewhere, or we have to all come together. We have to be a community. I mean, when I first started this, it was 3 of us in New Zealand, and we didn't even know that GFN existed. We didn't even know NNA UK existed. We only found out about this because Madawa was kind enough to take us kind of under our wing and say, oh, guys, the biggest threat right now is burnout. I would say absolutely.
I would agree with that, Nancy. And a couple of things come to mind. Number one, I think stigma is a huge challenge. Obviously, our consumer advocates that are here at this event aren't necessarily deterred by that, right? But for your average person, there's so much misinformation going around. People. I remember not so many years ago when people were very proud about their stop smoking journey and the fact that they vape, and it was something that was a badge of honor. And I don't know when this happened. I think maybe it was during 2019, during the whole Uvalde disaster. It almost became something that people were wanted to hide, right? That they couldn't be as vocal on or as out there about anymore because there was so much judgment going on, especially in the United States around that time. So just a lot of stigma. And number two, the process is hard to engage in. And that's why, as small business associations, it's hard for us because we're always underfunded, but I really feel for some of the consumer groups because I imagine that problem is even worse in consumer advocacy because especially with our political system in America, if you don't have a significant amount of money to throw at it, good luck engaging and getting anyone to take the time of day to deal with you. So I would say those 2 things and probably lots of others.
Right, thank you very much. And I would also like to share my thoughts. Being someone who is coming from Africa, Malawi, a developing country, one of the challenges that we face is what, according to Nancy said, we sit at the exporting end of, let's say, policies, same as misinformation, just like Amanda has just highlighted. So, in Africa, or in developing countries, we sit at the exporting end of misinformation. And when the media comes with such kind of misinformation, it is usually coded with fear-mongering frames, and it attracts public attention. So it's very difficult to correct such kind of misinformation, to clear such kind of misinformation after they have already been flooded by the media. So that's one of the challenges that we face. And on top of that, accessibility of safer nicotine products. Like we don't really have locally feasible and socially or culturally acceptable safer nicotine products. So like in Malawi, the only safer nicotine product that I know is electronic cigarettes. But these are very expensive for an average income earning smoker in Malawi. So as advocates in Malawi, we kind of find it difficult to just advocate for one safer nicotine product which other people in the country cannot really access. So it's a little bit tricky to advocate for something that does not necessarily exist in the country. We can't really talk too much about snus where snus is not available. We can't really talk about nicotine pouches, too much about nicotine pouches, because by the end of the day, people will ask, where are these products? Would like to see them. So that's one of the challenges. Now let us move on.
Jim, I want to say something.
Right.
I don't even know if this thing's on. Hello? Okay. One of the things that's a big difference here is in America, you had, previous to what's going on now, you guys had access and choice.
Yep.
In the developing world, we don't have that. And that's kind of what Chim was saying. And we, in the developing world, we're sitting here fighting for people to have what you guys had. And it's then like what John was saying, it's very disheartening to us to see you losing and the UK losing. And we have to sit here and wonder, it's like, well, where are we going? And that's what causes, that's one of the hard, I think that's the hardest thing for being a tobacco harm reduction advocate, especially in a developing world. Because we see other people that have had it, we want it, we can't get it, and then the people that we're looking up to, they're losing it.
Yep.
And that's where the burnout comes from.
Thank you very much, Nancy. Now let us move on to the next question in the room. We had a hand over here.
Thank you. H from Factasia. Just before I launch into whatever I launch into, let me just say, Amanda, that was phenomenal. Had I not seen you do it before, I'd be on the floor flat out. That was brilliant. Nancy, I love you, girl. Brilliant. Jim, I want to hear more from you. My question, which obviously has a lead in, with the what you were discussing about the struggle that you faced in the US, which sounded to me like there was some litigation involved, which is normal, I guess, for the US, but also very expensive. Nancy, I happen to know that litigation is just simply not an option for you. Jim, I'm assuming that litigation is equally impossible. But I also happen to know that CAFRA is completely unfunded and has no funds at all, so couldn't involve, and that would be the same thing for all the associations, including ours, that are underneath it. So litigation, going to court to try to address this thing, even though it might have some logic to it, is not appropriately, it can't be done because there's no money. And Amanda, you pointed out that litigation is something that you kind of have to follow from time to time, and you don't always win. But equally, in Malawi, as a tobacco-producing country, we know that Bloomberg has been funneling billions into undermining everything that we need and want, and smokers desperately need access to. We know that there are very powerful individuals in the countries throughout the region that I live in that have some significantly corrupt vested interests in tobacco production, in importation, sales, what have you, even in countries where products are completely illegal but available widely through the black market. Somebody's making a lot of money out of that. Do any of you feel threatened by the vested interest, the powers that be in your countries? How do you cope, sorry, there's a couple of questions here. How do you cope with being unable to go to the courts to fight your battles? And is funding an important, necessary, or irrelevant component in consumer advocacy?
Loaded question.
It is a loaded question. Funding would help. It's like anything else, you know, money doesn't make, you know, money isn't everything, but boy, it sure helps, right? I can't talk about the litigation, as you know, because even if there was a mechanism, half the countries it's banned, and you know you could go to jail just being caught. So I can't talk to that. I think I'm going to hand this one over to Chim.
Well, that's crucifying me, and
I'm sorry.
I should be honest here. I think I wouldn't really be able to give a good answer to your question at the moment, but I'm happy to discuss afterwards. Thank you. Right.
Yeah, and on that note, so it's interesting. So, you know, FDA went through and denied, you know, 98, 99% of all of the applications that were put in by the small businesses. You know, as an association, in the U.S., you have to have something called standing in order to redress your grievances in court. You know, our association, you know, doesn't have standing, right? And so it's really unfortunate because all of these very small businesses have to take on that litigation on their own. And, you know, and it's a huge gamble because you never know how that's going to go. And it's a major financial commitment. And I talk very closely with a lot of the companies that have undertaken that effort, and I mean mostly they're just pissed, and so they're going for it, and I think they're very grateful to have that avenue available for them because unfortunately, you know, we've tried to win on the facts. You know, we've tried to be persuasive in the court of public opinion. We've gone to our lawmakers who are supposed to defend our rights, and all of those things failed. And so now many of them are making their last stand in the court system. And you know, I support them, but Lord knows how it's going to go. You know, any lawsuits that have ever come from our small business sector in the past haven't had, you know, a ton of success. But you know, I'm hoping that maybe some of these will be different, and there has been some very early, you know, positive outcomes in many of those cases. So hopefully they go well. But yeah, that's I think that's the one last possibility that we have to possibly be treated fairly.
Right. Thank you so much. In the room, is there anyone who has got some comments on what has just been asked or discussed? Is that a comment? Or a question? All right.
I actually just want to respond to Fiona and her question about research and vendors. Putting my researcher hat on for a moment, through the Centre of Research Excellence, Indigenous Sovereignty and Smoking, we've actually got a pilot training program running at the moment called Squirrel. Now, I've had to get it out because it's not spelt like squirrel. So it's www.squirral.net. Now, the first thing we did was actually we surveyed vendors in New Zealand to find out what their knowledge about nicotine and addiction and all that sort of stuff was. So we used that as the basis for the program. It's primarily designed for people with no training whatsoever or knowledge. But part of what we do in that is we're gathering baseline information so that when people enrol in the program, whether they're vendors or tobacconists or however they're delivering, we get all the baseline information about their attitudes and beliefs. And the process uses gamification, so we're not lecturing them about, it's not the normal process. And so we're going to track them and see how they develop their skills and whether that actually affects their ability to be more effective in helping smokers stop smoking.
Thanks, Chaga.
Thank you for your contribution. All right, we move on to our next question coming from online. To the panel, what can be done to energize certain states in the US to get back to advocacy?
I'm sorry, I didn't hear that.
All right, what can be done to energize certain states in the United States to get back to advocacy?
What can be done to get certain states to get back to advocacy?
Energizing advocates.
Oh my gosh, I wish I knew the answer to this. I spend a large amount of time trying to, cheerlead and keep people motivated because it's hard. I mean, there are days when I want to go crawl in a hole and never come out again. I don't quite know. I think right now, people are looking at what's going on with the Food and Drug Administration and all of the product denials, all the things that have been taken away, how it's being, either, driven away entirely or driven onto the gray or black market. And I think people are taking a minute to grieve right now. And I hope that, when that minute is passed, people will kind of be re-energized because we can't stop fighting. If Nancy can have these kinds of victories in the Asia Pacific region where things were totally banned and come back from that, certainly we can make progress even with this dark point that we're in right now. So I think our advocates need to really come together and support each other. Just like on the panel of scientists yesterday, they in that area, I think advocates really need to support each other.
It's like the 7 stages of grief. You get sad, you're in denial, and then all of a sudden you get angry, and that's when things happen. Would you agree with that?
Yeah, I think so.
Right, thank you very much. Next question in the room. Right, we have a hand at the back there.
Thank you, Sam Hampshire from Botec in the States. Amanda, this is for you. We both live in states where consumer and other stakeholders have moved the policy needle with direct democracy, so referenda, plebiscites, ballot initiatives, and I'm talking about cannabis legalization. What is the opportunity and perhaps the threat for direct kind of consumer advocacy at the ballot?
Well, this is a long discussion about how ballot initiatives work in the United States. That's probably going to get way too much in the weeds, but it is so expensive. You have to get something on the ballot, and I can only speak to this may not be the same in all 50 states, but in the states I'm familiar with, there are 2 ways to get to the ballot. You have to pass a referred measure through the state legislature, or you have to do it through signature collection, and there are a lot of rules and specifics surrounding how many signatures have to be collected, where they have to come from, the criteria those signatures have to meet. You have to collect extra over and above the target because a large portion of them will always be thrown out. It's very time intensive to collect them. It's very expensive to collect them. It's a whole very complicated, very difficult thing. It can be done, but I don't think that is something that would be very easy for a consumer organization or a small business organization to take on without some kind of support, just because of how complicated that is. Like what you're talking about in Arizona with the cannabis legalization that went through the ballot measure, that was done with the financial backing of the entire medical cannabis industry in that state. That then, and it was problematic because they wrote the laws so that only the medical people could have the recreational licenses. So it was this very monopolistic thing because they were the ones that were spending all the money on the ballot initiative. And so it's one of those things that it's just so expensive. It's almost like it's an avenue reserved for big businesses, or if you have Bloomberg funding, which, sadly, that is not the position most of us find ourselves in.
Right, thank you very much. Nancy, would you like to maybe add anything on that? Yeah, on what, all right. Right, thank you. Any other questions in the room? Right, we have a question over here.
One last question, and I promise I'll leave you guys alone. For all 3 of you, I would love to know, thinking about the research community, and that includes both academics and think tankers like myself, people who just write policy, or who write about policy. I wish we wrote policy, we do not. What can we do? What would you like to see more of from academics, from the research community to help support you? Or alternatively, what would you like to see that community, the research community, stop doing or back away from, if there's anything that you from your position as advocates on the ground, if there's anything researchers, pro-tobacco harm reduction or harm reduction researchers are doing that's hampering your efforts, or what we can do to help further?
Would you like to tackle that? What kind of research might be helpful?
Yeah, it is a hard one, but let me just try to attempt it. And yeah, maybe I should start by the academia in general, not just tobacco harm reduction specific researchers. I am aware that there are certain journals that don't really accept anything related to, anything to do with tobacco harm reduction. So, like, to the academia in general, journal owners and everyone, I think I would really have loved to see if they can be able to accept any paper that is tobacco harm reduction related, not just because it's tobacco harm reduction, then they push it away and stuff like that. I think I have a number of colleagues, I personally know, people whose papers have been rejected just because it is a tobacco harm reduction paper. So I really would have loved to see the academia in general, the researchers, the journal owners accepting each and every paper. Secondly, when it comes to the tobacco harm reduction researchers, I feel like there are certain regions, countries where you barely find information on tobacco harm reduction. For example, in Malawi, one of my colleagues was doing a literature review on snus. You find nothing, zero something on that. Another one was doing was writing a paper on media framing of tobacco harm reduction in Africa and in Malawi. There were no papers on that. So I think this is something that maybe researchers can look into and maybe try to diversify their research areas and countries in which they can do their research, because like for policymakers to make informed policies, they need such kind of well-written papers, peer-reviewed and well-published. So yeah, that's what I can say.
What I can say from my research background, Michelle, is a lot of times when we're talking about academia, okay, and we're talking about research, you need to publish or perish, and I'm sure you're aware of this, okay? And a lot of times when you go to apply, you want to do a project, you have to go to somebody above you and get approval. Now, if tobacco harm reduction is contentious, which it is, okay, a lot of times you're not going to get funding. You're not going to get funding from NIH unless they have a specific, program towards tobacco harm reduction. You're not going to, obviously, the American Lung Association, American Heart Association, they don't want to hear about it, okay? So it's hard to say what can the researchers themselves do, because their hands are tied, really. Because the funding is going to come from outside external sources who do not want to actually acknowledge what tobacco harm reduction is. So I would say, ultimately, creating consortiums, and I believe there is a magazine where they can publish their studies, but it's not, quote unquote, peer-reviewed, but it is. But it won't never be a first-class journal or peer-reviewed, acceptable thing. It depends on the editor of the journal. It depends if you're in academia, if your higher-ups are going to allow you to do it. Most of that money would probably come from private foundations to be able to do that, and most private foundations, I hate to say it, are very much anti. So their hands are tied.
Thank you. Amanda, would you like to add?
Michelle, all I'll add to that is just really a thank you, because our think tank researchers in the United States are some of our very best resources and allies, and that's people like you and people like Lindsay and many others. I'm not trying to play favorites. I just see you two right up front, and you all are incredible. But you know, I know that you guys are always right there with the data and the facts, and you know, ready to talk through consequences of bad policy, and you know, weigh things, you know, pros and cons of different things. And you know, same for the scientific and academic researchers. I know that, you know, I wish there were more of them, but I'm very grateful for the courage of the people that do the work in this area, despite, you know, career consequences and funding challenges and all of that.
Right, thank you very much. I think we have got room for one more question or two. Any other questions? Right, I have a question for you too. Right, so my question is, how crucial do you think it is for advocates to work with a unified, in a unified manner, getting everyone on board, women, men, everyone should be on board, and avoid stepping on each other's toes?
I think we all have to work together towards a common goal, and I think the approaches, I mean, I see differences in approaches between developed countries and developing countries. That comes down to a lot of cultural considerations, like I mentioned earlier. There are women in THR. There are a whole bunch of them. But the thing is, again, going back to culture, there are a bunch of women working in India. There are women working in Latin America, okay? But you don't see them. And if you don't see them, don't just presume that they don't exist, because they do. They're not loud and proud. They're the people behind the scenes doing the things at Sugar, right? For example, okay? She's a vapor, she's an advocate, and yes, she's also a researcher. She's not any less valid than I am. Actually, I'd say she's probably more valid than I am, okay? But we do work together, and I think there is this idea that because you only see the guys and you only see the cloud bros, right? You know, where are the women? Well, we're here. And we do work together. I mean, I know we do. Would you say the same in America?
Yeah, female advocates are wonderful because we all work together very nicely. Our organization is largely female run. We have one male board member, and you know, we didn't construct it that way intentionally. It's just kind of like, you know, there were those of us that were just naturally were able to kind of check the egos and work towards solutions. But you know, to answer your question, I think, you know, we all have to work together. You know, the anti-harm reduction contingent is so organized and so coordinated and so on the same page. They have this mega force that they've assembled. And, you know, in order to even come close to being able to counteract that, we're going to have to all work together.
And everybody has different strengths. And that's another thing, too, is focusing on everybody utilizing their strength together.
Right, thank you very much. I think that was brilliant. Ladies and gentlemen, allow me to extend our warmest thanks to Nancy and Amanda. I think I enjoyed this session, and I hope you also all enjoyed it. Thank you very much.
And thank you.
Thank you, Tim.
There's been 15 sessions, and some people have been to side events and satellite events over the 3 days, and there's been an immense range of speakers and input from various people. But I do hope you've all enjoyed it. So this is the final plenary session, which will reflect on some of the key points in learning from the last few days. I've got a great panel here. Angeles Montadas Prim Lafita from Spain and INCO. Cecilia Kinstrand Isaacson from Swedish Match in Sweden. And Konstantinos Varsalinos, who everyone I'm sure will remember from the very brilliant Michael Russell oration he delivered at the beginning of GFN. Now, this is an opportunity not only to, to reflect on what's happened over the last few days, but also to think, reflect on that in terms of the title of this year's conference, Tobacco Harm Reduction, Here for Good. And very clearly that's got two meanings. Clearly, tobacco harm reduction is good for people, good for individuals who would otherwise be smoking. And it also here for good in that it's not going to go away despite the best wishes of some people who would hope it would all vanish and they wouldn't need to deal with it. Which brings me to, I'm going to borrow a phrase that Thomas Gorman used earlier, that trying to prevent people using safer products is like trying to turn back a wave with an umbrella. But progress can and is being delayed, and we've heard a lot about that, including in the last session. And that's detrimental to very many millions of people. I'm now going to pass across to the panelists and take a seat in this very nice comfy chair, because my legs are a bit tired. I'm sure that's the conference and nothing to do with what's happened after the conference each evening. Each of the panelists are going to provide a little bit of context on where they see things are, and I've asked them to highlight 2 or 3 of the key highlights for them from the conference so far. And then if we've got time at the end, we will come out to the audience. So you may wish to start thinking about what your highlights are. Well, sorry, Angela, start you.
Well, hello, my name is, well, you already said my name. Well, I think talking about harm reduction, I'm absolutely sure that harm reduction is here for good and it's here to stay. But we're facing many barriers, and I'd like to have the chance, if I may, to talk a little bit of what's going to be going on in Spain in the coming months, because we got from the Ministry of Finance, they've presented this draft bill in which they want to make vape shops disappear completely. That meaning that if vape shops want to continue operating, they have to transition into tobacconists and being forced to sell combustibles. On the other hand, if, of course, no vape shop is going to go through this transition because they're not going to be selling combustibles. But, for instance, tobacconists might or might not sell vaping products. I mean, it's up to them. Well, this means, I mean, the government wants to monopolize the nicotine market. And this is weird. A country which is a member state of the European market wants to monopolize a free and independent market. That's going back in time to where Spain wasn't even a democracy, or even if we go further back, it's like going to the Spanish Inquisition. So that's horrifying because not only for consumers, which are going to be forced to go to a tobacconist to get their products, as many as they can find, because it's up to the tobacconist to what they're going to be selling. But it's also like trying to have, it's like forcing an AA meeting to be held in a liquor store. So, and also, I mean, if we think out of being like thinking as an advocate, it's also going to mean the loss of 1,200 direct jobs and 3,000 indirect jobs, plus all the families that are going to stay without any income. So we're facing that, and right now we're on stage number 3, which means an open public consultation, and all submissions are very welcome, because we really want that as soon as this draft bill becomes a law project and is to be voted on, we really wish, that it doesn't pass. Because if this law passes, all vape shops will only have 6 months to notify the Commission of the tobacco market that they want to transition into a tobacconist, or else we're only going to have the tobacconist, stores to get whatever we find. Result, black markets, disobedience, and lots of people going back to smoking. I just wanted to tell this because I think it was a very good opportunity for me, because tobacco control in Spain, and Constantinos knows very well, it's one of the fiercest and most stalled in the European Union. They defame the countries that stand for THR. One of the worst things I've heard lately is that coming from official institutions saying, how are we going to trust the UK if they have their car wheels on the right?
Tobacco control movement in Spain, it was shocking to see. I think it was in 2014, their first assault on vaping, that for 1 year they completely destroyed the cigarette market based on the fallacy that glycerol in electronic cigarette liquids causes lipoid pneumonia. Lipoid pneumonia is an inflammation of the lungs caused by lipids, but glycerol is an alcohol, it's not even a lipid. So if you ask a secondary school chemistry student, you don't need any more knowledge on chemistry besides that. Everyone knows that glycerol and anything that ends in ol is an alcohol. So an alcohol cannot cause lipoid pneumonia. We would call it an alcoholic pneumonia, not a lipoid pneumonia. But it worked perfectly in Spain. They destroyed the market. And I wonder, why don't you get a tobacconist license without selling combustibles and selling only e-cigarettes as...
It's mandatory.
Yeah.
You have to sell combustibles, and you have to have...
That's a nice argument.
Yeah.
That the government mandates us to sell cigarettes. Why don't you use that as an argument? It's a very interesting argument that we are obliged, according to the new rule, to sell cigarettes, while we've never sold cigarettes until now.
Yeah.
That's what
you
should
of
use.
course, online sales will be knocked out because, you cannot sell or buy combustibles online. If a vape shop wants to transition, they're going to have to send combustibles and state stamps.
Yeah. I think you've given us a really good example of just how difficult the situation can be. And it's the second time today the Inquisition has been mentioned, which is interesting and slightly worrying. I'm sure someone in Poland got in a lot of trouble for suggesting something about planets in the orbit with the Inquisition, so I guess it's... but I am going to press you now to maybe reflect on some of the things from the conference that you think some of the most important, or the things...
As usual, GFN is always the place where you feel at home. You feel, yeah, absolutely. It's like where it's inclusive. Everybody comes here. Well, everybody is invited. Not everybody comes, of course. But yes, and it's a place where we, especially after 2 years of pandemic, where I mean, all THR advocates have been totally frustrated. So meeting everybody in person has been very, very gratifying, because it kind of brings up that spirit, like, let's continue the fight, because we're all burned out. But yes, I mean, as I was saying, I think that harm reduction, tobacco harm reduction, is a revolutionary movement held by consumers. So I think it's here for good, and it's here to stay, no matter what happens, no matter what type of legislation, because we're used to disobedience or whatever we need, but we're not going to, I mean, we, for instance, vapors or people that use safer nicotine products that have been using them for a long time, they're not going to go back to smoking. They have many ways of getting their products. But what will happen with those people who still smoke and don't have the chance to get all those products? And
yeah, it's a very, very, very good point. And you've certainly earned the check for the write-up about how much you enjoy GFN. The check will be in the post.
Let me expand on that, because, and I'm going to do my saying with what she said, using the Spanish example, in answering the question if tobacco harm reduction is here to stay. Yes, it is, but Spain and many other cases show the big problem that I also see. For what proportion of the people who need tobacco harm reduction, THR will be there? That's the main problem that we're seeing. Of course, the products will never disappear, but what matters in any harm reduction strategy for whatever, and of course, in this case, for smoking, what matters is to avoid inequalities. And inequalities in terms of accessibility to proper, reliable information, accessibility to the tools, so they are reducing accessibility to the products, appeal of these tools. People, smokers should like these products. They try to make them horrible. And of course, smokers will not try anything horrible, and no one is going to eat, drink anything which smells or tastes horribly. The problem is going to be access to tobacco harm reduction. The example of Spain, and that's the second time such an assault on vaping has happened in Spain. The example of many other countries where they always try to put hurdles in accessibility, they try to increase the cost through taxation, is that a small proportion of the people who need this strategy are going to have access to this strategy, because they make it more expensive, less accessible, less easy to use. They try to limit variability, which is extremely important. Everything is based on self-preference. And I think that this is what we should be discussing, how we will increase access to reliable information, which will translate in knowledge for non-experts. I'm talking about citizens, about smokers. Everyone deserves the truth. Even non-smokers should know the truth. And then end up with access to cheap, reliable, good quality products with the variability needed so that everyone will find whatever they want to use and they like to use.
Thank you. Cecilia, can I...
Yes.
Reflections on GFN.
So it's wonderful to be back. Teams calls are nice, but this is fantastic. Going on to the Spanish issue, I actually met with the Ministry of Health in Spain when I started to work for Swedish Match, because we had this fantastic data around smoking prevalence in Sweden, and we came loaded with a nice presentation, and they were like, interesting, we're not interested. Is tobacco harm reduction here to stay? Yes, because the consumers have rights, and we are right, and I think that's very important to remember, that we're actually on the good side here. but it's going to be a bumpy ride. I'm based in Brussels. I work a lot with EU legislation, and I think we all should be aware of the challenges coming out through the European Commission in Brussels. I'm sure you know that tobacco legislation will be opened in most of the EU member states because of a delegated act, due to the fact that heated tobacco has grown sufficiently enough for them to ban flavors. And I can only guess what will happen with EU legislation in member states when it's open. And I think maybe the strategy of the European Commission here is that they would like to see more negative regulation for harm reduction products in the member states during the time when legislation is open, because then they have to harmonize. So we are in a pre-harmonization situation in the European Union, and I think we all have to figure out how we can push harm reduction from a member state's perspective. Yeah, anything you want to know about the EU process, I can help with. Thank you.
Thank you very much. Konstantinos.
I think that we should also use the example of snus as a perfect example of the corruption of the authorities in the European Union. In 2019, snus was authorized by the FDA with a claim of reduced risk, not just exposure to toxins, but reduced risk for several diseases: oral cancer, heart disease, lung disease, COPD. And in Europe, it is banned. The only product in tobacco harm reduction with such a high quality level of evidence from epidemiology, not from laboratory studies, not from animal studies, not from modeling, from true science, hardcore clinical data. And in Europe, this product is banned. This shows the level of ethical corruption of the authorities, because it's an ethics corruption when a lawyer says in the European Court that Swedish men have low rates of smoking because they take paternity leave. This is corruption. This is nonsense. But he had the courage to say that loudly and publicly, and I suppose he's maintaining his position. She, okay. So, yeah. And she's Swedish. I didn't know that. That shows you who we are dealing with. And I think that the Michael Russell oration that I gave this year, I had the privilege to be invited to give you the lecture. It showed exactly that. It was about that. It was about the authoritarian mentality of the tobacco control movement industry and the authorities who are using the tobacco control industry in order to implement more and more rules, which are always more and more restrictive for the lowest harm products, even for the products with a proven record that another organization on the other side of the Atlantic Ocean has provided after many years of delays, of course, but finally, an authorization with reduced risk claims. And no one is discussing about this discrepancy between Europe and the US. At least in that would have been a starting point. Not that in the US everything is perfect. I mean, look at what's happening with the cigarette research. It's basically very hard to trust any kind of research coming from the US concerning electronic cigarettes. It's that crazy. When you see the health organizations there calling a disease caused by illicit marijuana products as e-cigarette or vaping-associated lung injury, so that they made sure that if someone doesn't understand the term e-cigarette, we will add vaping so that we will make sure that they are convinced it's because of electronic cigarettes. And they never even made a single attempt to change the terminology when they themselves admitted that it was because of illicit marijuana products. When I've seen, because I've been a reviewer, I've been an editor for journals, and I've seen people who, scientists, who were not willing to mention things by their names. I had a paper presenting data from marijuana products, and they were discussing about vaping products, and they did not want to mention the term marijuana product. And I had to start a fight with the chief editor of the journal and the authors in order to mention what they were reporting. Just mention the name of what you were studying. It's unbelievable. This is what is happening in science. This is what is happening in politics. This is what is happening in public health. And I think that the last 2 years of the COVID pandemic showed that this is overall corruption, you know, ethical corruption.
Sorry, Cecilia, did you want to?
No, and I think it's, if you read the endless commission papers, it's very clear where they want to go. And their goal now is a smoke-free Europe 2040, or a tobacco-free Europe. But obviously the risk and everything we see from the regulatory papers is that they're going to equate reduced risk products with smoking. And then they're on their way of destroying this category. I don't think necessarily they will win, but I think we also need to, there is a big fight in front of us. And Europe is a successful political project. They are also exporting regulation, and we see how they maneuver around the WHO, and that is why it's even more important that we really manage to push harm reduction in this coming legislation.
Can I just, and I think we've heard sort of some very good examples or outlines of what the blockages and the challenges are, you know, and there's political, there's bureaucratic, there's institutional. So the $64,000 question is, what can we best to tackle that? Is it what you were saying, Konstantinos? Is it improving the level of understanding and knowledge with the public? And if so, how do we do that? Or does it need more than that?
They will never vote on the next directive because that's not usually how they do it. But they will sort of feel the atmosphere in the room. And in order to get a blocking minority, if I remember correctly, you need 4 countries with at least 35% of the population. And if the Commission is very smart people, and they will not push countries into. They want to have an agreement. So I think we need to. Some countries are lost: the Netherlands, Finland, Spain, I think. But there are other countries where there is an acceptance of harm reduction, and we need to be smart about it. And we need to. And I think that's another important point. We need unity. There are some companies, colleagues of ours, that are throwing some certain reduced risk products under the bus because they don't have skin in the game. There is there are quite a number of interests who are just defending what's important to them. And if we can't be unified for all the reduced risk categories, we're going to lose in the end. One example, for example, is the flavor restrictions on vaping, which we don't really care about because we don't have it. But it's going to impact what's going to happen on pouches. So it would be stupid for us not to care about it. And I guess you've seen, but the Swedish Parliament is most likely going to vote against a flavor ban on vaping products, which is a first in Europe. So that's positive. But we have to protect the harm reduction, not only category by category.
And on harm reduction in the broader context, it's very depressing to hear Netherlands being in that camp when in the UK we've often looked to the Netherlands for developments around drug harm reduction. It's a bit like Australia,
It's
really.
a bit of a hypocrisy, you know. But I think we need to differentiate what the industry is doing, because there are other types of vested interests in the industry too. And of course, in many cases, they have a common interest with the public, and what the consumer is doing. And let's not forget the experience from 2013 and 2014, the first EPD, where the consumers played a very important role in applying pressure to the authorities, to the European Commission. In this instance, we've lost the biggest consumer market in Europe, which is the UK. So we've lost the power and the influence of the authorities there, which were at that time probably the only ones who had endorsed these products to a large extent, and then even more later. And that's going to be a big problem for the EU. But I think that we need to mobilize consumers, and consumer power is undisputed, and it's not influenced by any conflicts. That's also very important. And so they cannot use any justification to ignore the consumer's opinion. So, but I think that they will be prepared for that, because they have the experience from 2013, 2014. Still, I think the consumer plays a huge role, and they should be mobilized themselves independently of what the industry or even the scientific community is doing. They have to use their own arguments, and they have to exercise their own right to have products available that will protect themselves. So the Vapers Association should become organized. Consumer organizations like INCO, they should be more and better organized. I don't know, they must be a bit creative, finding ways to apply pressure to the EU. I remember at that time there were vapers coming to outside the European Parliament with black balloons and so on, and exercising their right to have these products available. It worked at that time. They'll be prepared for that too now, but still we need to act in a more aggressive way. And I say we because I'm also a consumer, and I'm also a smoker who failed to quit with everything, and I had tried everything. Of course, I was successful with everything, but for a few months. And it was with an e-cigarette that I managed to quit and stay off tobacco cigarettes for 10 years now, more than 10 years. So, you know, they can discuss about whatever science or science in quotes they think, but they cannot deny reality. And the reality are the millions of people who have managed to quit smoking with electronic cigarettes. And this is a fact. Nothing can change that.
Has anyone got any good, and I will come back to it.
I just wanted to add something to what Cecile said, because recently also the Czech Republic has jumped on the wagon of standing for tobacco harm reduction, which is also very good. But also, for instance, right now we had the call for evidence, and which, organizations and consumer organizations took part. But also, I think it was important for consumers individually to also tell their story, because what's more evidence than how this has helped you give up smoking? And regarding flavors, I was still a little bit, I had some hope in that they, maybe from the European Commission, they were kind of going to recommend banning flavors in the various member states. But right now, I think that the prohibition might come directly from the European Commission. But I don't know if France would be too happy with that, because, of course, as Constantino says, we've missed, we don't have the UK anymore. So, but anyway, and then...
We need a substitute for the UK. And France is well, I think, a candidate.
Yeah, and I hope we can also have some hope in Greek, too, soon. But anyway, yeah.
That leads in the point about the Czech Republic changing their position. I mean, it does feel to me, and this is probably, you know, the fact I was a civil servant when I had a proper job, a bureaucrat, but, you know, this is, to me, a lot of it's a political problem, and it's very hard. I know lots of people have tried to engage politicians, but I've been involved in other things where you plug away for years and years, but then something happens and you can go, and you do get that political buy-in that allows things to happen. And there's a little bit in the UK, I think, you know, the 2030 target has actually helped because people are going, that's not very far away now, and anything that helps us do it. And so, okay, and I think we've probably got a critical mass. Things are not perfect in the UK at all, as many people in this audience will testify. But it would be almost impossible to row back very far.
But I think Martin made that comment yesterday. It's not a harm reduction country, it's a vaping country. And you would think that they would look at the evidence you have on snus, which is in abundance, but no, because they don't want a new tobacco product on the market. So I think when it comes to politicians, I think the tobacco policy is sort of quite straightforward, and it's been outsourced to civil servants. They're extremely well organized. So, and going back to the European Parliament, if it wouldn't have been for the consumers that actually got the members of the European Parliament engaged in the issue, we would have had a de facto ban on vaping in the EU today. So it's public choice. You need to find the politicians that feel that they have a pressure from their voters. But without that, the civil servants are just going to ram it through.
You're right to correct me, because actually, politically, on drugs or anything, harm reduction has never been a popular phrase in the UK. We can put things under the category of harm reduction, but it's never something you see in a political manifesto. Rarely gets mentioned by politicians in speeches. But there must be something we can do, or at least we have to keep plugging away at the different politicians who are in a position to make a difference. But how do we do it better?
I think MEPs are misinformed. Well, that for sure. Not all of them are informed. Just keep in mind, for the revision of the TPD2, the SKIR report.
Oh, yeah.
I know, I mean, I'm not a scientist. He can speak better about it, but it was terrible.
They didn't know that snus existed as evidence on long-term nicotine use, and they were using, you know, animal studies, cell studies to present the risks that don't exist with snus, while we know that snus users obtain the same or even higher levels of nicotine than a smoker. So, and that's a very common misperception among scientists who are not really involved in this arena and are doing it, you know, as, you know, let's do something with nicotine and that's it. I remember a few years ago I was in an American Heart Association conference, and they were presenting some studies from the 90s and the 2000s about mice with their aortas exposed and showing the atherosclerotic lesions from nicotine. And I was a member of the panel, and I asked them, you know, why don't we see with long-term cohort studies with snus, why don't we see an increased risk in myocardial infarction? And it's not just one study. There are studies for myocardial infarction, repeated studies. There are studies with stroke, again, the same story. And they said they acknowledged the discrepancy. And then I asked them, and it was a rhetorical question. I asked them, do you think we should trust the mice and the laboratory cells, or the data we have from human epidemiological studies? And, you know, no one answered, because they realized that that was a question that didn't need to be answered. But that shows you the approach. I was never invited again, of course, because they don't like being embarrassed through a question, especially when the FDA, an FDA representative was also there at that time, next to me. So, you know, it ends up being a one-sided debate, basically not a debate, you know. We're just saying, you're great, you're saying everything excellent, you're excellent, because we have the same opinion. Unfortunately, the same is happening here, but the difference is that here at GFN, we have tried repeatedly, and I know Jay at some point when I was also an advisor for the program, We have tried repeatedly, and they have tried repeatedly to bring people who have different opinions here and present whatever they want for as much time as they want to. They never even responded to such invitations. So it's not us who avoid the debate, the dialogue. It's them. And there is a reason why it's them and not us.
Yeah, no, I just, the Skinny report was horrible, but there was some nuggets in there which they, of course, misrepresented in the executive summary, and no one reads the reports, or very few people read the report, but they read the executive summary, and I think we have an equally bad example with the SHARE report on vaping, and I remember reading the Public Health England latest evidence report, and they said we can't use this because it's just crap. But it doesn't matter, because this is the foundation for future legislation.
Do we need something like nicotine for dummies? It's a really simple, nicotine for politicians who may also be dummies, I guess, but do we need something really basic as a sort of basic tool that we can get to various politicians? Yes, I think we should. The problem with the timeline of the directive is, of course, that it's coming out, if according to plan, early 2024, and that's after the next election to the European Parliament, so you don't know who is still there, or if you have a lot of new people. But of course, I think with vaping last time around, it became obvious for the MEPs that this is just strange and weird. So that has to, of course, to be repeated again with that, providing that information. Because if you present the arguments, they're logical. We are right. It's obvious that we're right. It's just that at the moment they might not be interested. They are only interested in what's on the agenda today. But if you know MEPs, if you have contact with them, it's never wrong to provide information. Okay, I think we should come out to the audience with particularly acceptance of accepting compliments about the conference, but we also want to hear specific points, your highlights. So who would like to say something, any particular issues that people would like to raise reflecting on the last few days? Gentleman here.
Thank you, Rafi Castillo from Manila, Philippines. So again, going back to the question, is THR here to stay? Definitely, I believe it's here to stay. But if we want THR to really advance forward and not to linger somehow in limbo, I think we need to realize that it has gone, the issue, the debates, the discussions have actually gone beyond the academic or scientific realm. And I believe it's now more in the legal realm, and that's, I think, where we need to build ourselves up. I'm a relatively newcomer in this field. I must, as I admitted, more than 2 years ago, I was more towards, I and my group were leaning towards tobacco harm reduction. But, you know, we had to contend with reality, with real-world issues, and we believe that THR is a more pragmatic solution if we want to get rid of the smoking problem. But as soon as we made that realization, we also discovered that there's really a whole set of barriers which are impeding us. And initially, we thought that producing more data would be one major answer, but we realized it's a lot more complicated than that. We tried to produce several papers. We were able to complete 3 papers. Of the 3 papers, we tried to get it published, but only one got published, and we got all sorts of comments from peer reviewers, from editors about the 2 papers. Yeah, it's really difficult to get our papers published. So I think again, it's not anymore confined to the scientific realm. I believe we have reached the threshold of evidence. for THR, but I think it's more on the it's now the fight is now more on the legal side, as pointed out. I think we need more lawyers here in this movement, which can actually protect the rights of smokers who want to try vaping. For example, the mandate now being proposed in Spain, I believe it's something that is contradictory to the international Bill of Rights. You know, it may not be within the Bill of Rights, but it's akin to that. The right to free market is, I think, enshrined in most constitutions. So we need to build up our arguments at this level. So not only in the scientific realm, but more on the legal aspect. So just an impression, an observation which I have, which I think we may have to consider. Thank you.
Thank you very much, and I'm sure the panel will agree that, you know, we are convinced there's enough data. It's top secret, so I shouldn't share it, but in the GFN laboratories, they're actually working to clone David Sweena, which would address the particular point. So we're hoping to have a production line rolling off David Sweena's very shortly. Are there any other questions or points that people would like to make? Oh.
I'm Bengt Wiberg, founder of EU for Snus movement. I have a question for Cecilia. I mentioned earlier the European Tobacco Harm Reduction Advocates made a survey, the biggest nicotine user survey ever performed. 39,000 responses, 35,000 nicotine users in EU countries. And there were massive evidence of, for example, when it comes to those 6,000, if I remember correctly, who were smokers, sole smokers, 30% of those were 60% of the smokers wanted to stop smoking, and 30% of those would like to try snus if it was available. So my question to you, Cecilia, having a more in-depth sight of the work going on in the European Union, has this survey results, 35,000 respondents, has this been ever discussed among the politicians in Brussels?
Not that I'm aware of, and I would guess not. I think it was brought up earlier today that in the last panel that consumers are stating what they want, but it doesn't really register with the policymakers. The view of the policymakers is that people should just quit with tobacco and nicotine. That's it. There is this smoke-free goal 2040, less than 5%, and that's the decided goal. That being said, the last time around, TPD2, the consumers, not the industry, it was the consumers that made the impression. It was the consumers that changed the trajectory for vaping. And I just hope that there are more of you and that you have more energy next time around, because it's going to be needed.
Yeah, fully agree, as I said, but I want to answer to the suggestion that we should engage more lawyers. Well, in Europe, there was a case in the European Court for snus, and you don't need any more level of evidence than what you already have for snus. It's been used traditionally for decades in Sweden, in Scandinavia, and not only in Scandinavia, but the most important thing was that all of the studies on snus were not coming from the industry. It was basically all the epidemiological studies, 0% of them were coming from the industry. So they had a very, very strong legal case. They lost. It's that simple.
We actually, it was the second time we took that case.
Yeah.
We lost both times.
Yeah, and don't forget what happened just before TPD1, the current TPD, I think the current TPD is TPD2. What happened just before TPD2 during the negotiation process, with that, the Director General of Health from Malta. I don't remember the name. Can you remind us the name?
John Daly.
Yeah. For those who are not from the EU and don't remember, I think it was Swedish Match which said that that he asked for a few million euros.
60.
Yeah, in order to add snus as an acceptable product for the European Union. And, he was just removed from his position. We never heard anything about any inquiry on whether that was right or wrong. But I think that a few months later, he was caught with 10 million euros in financial heaven somewhere in Cayman Islands, I don't remember when. But there was never a single inquiry in the EU on whether that was valid or not, on whether there was something wrong, doing something illegal or whatever. He was just silently left the position, someone else came back, and of course, snus was banned once again through the TPD2. So legally, I agree with you that we need also lawyers, but no, it's not enough. Even when the case is as obvious as it can get. You can't get anything better than snus. No other product has anything even close to snus. Still, even the FDA, which finally authorized the lower risk, it happened in 2019.
Just to clarify, we reported something that we found very extraordinarily strange. And then there was an inquiry by this anti-corruption agency, Olaf.
Which found what?
They found that there was unambiguous circumstantial evidence. I think the term
Nothing.
was,
Okay,
nothing.
thanks.
But just going to the FDA, which is also interesting, I'm puzzled by the claim, because we can communicate the claim on our products, but we still have to keep the warning labels, causes cancer. So I don't think that it's the most effective claim ever.
I agree, but but there is a huge discrepancy between banning the sales of the product in a whole region where tobacco cigarette sales are perfectly legal, and on the other side of the Atlantic Ocean, you have a country and a health organization which at least allowed a reduced risk claim with all the problems of that decision, which I fully agree, because risk aversion is the new ethical standard of politicians. They want zero risk, so they basically advocate for inaction, which means don't even look at harm reduction, which means that we keep the status quo of the highest risk product, which is the tobacco cigarette. So in reality, the inaction in a risk aversion strategy produces much more risk than action, which may include accepting a pretty minimal, in some cases not even existent, level of risk. So it's a hypocrisy by definition. It's the exact definition of hypocrisy.
Yeah, it's like it's black or white. Quit as we want you to quit or die.
Yeah. And in reality, they are supposed to support the white, but it's a Trojan horse for the black, for tobacco cigarettes. All they're doing is protect tobacco cigarettes from having any competition.
Yes.
Even what you mentioned in Spain, these products should be sold only by tobacconists, who of course would prefer to sell the products that they traditionally sell and would have no motivation or incentive to sell a THR product, especially a product which is not even a tobacco product like the electronic cigarette, right?
But Angelis, you said something then.
Yes.
And it was a point that was really made very strongly, I think, in Mark Tindall's presentation today.
A bit louder, please.
I'll hold this closer to my mouth, that will probably do. There was the point about quit or die, and it was an issue that was raised in Mark Tindall's presentation. How is it we've got to this situation where there is such a lack of empathy for people who are going to die or be seriously ill? I can't think of another category of you know, there's lots of things people don't get treated as well as they might, but there's nothing quite like smokers. What could we do about that? Because I don't really know quite how it's come about, given that so many people who have got those attitudes, you know, their parents, their grandparents, they must have known people who smoked, who, you know, what do we do? How do we address that empathy deficit?
It is very complicated, because at least in Spain, I mean, it's super that people can continue smoking. I mean, they don't really care. I mean, they just still increase revenue, and people in tobacco control maintain their jobs, which is pretty good. But how to convince them that white is also there?
Well, I think that what you're mentioning is a typical example of how the tobacco control movement has been very successful in misinforming citizens. Because, and I mentioned during my lecture that in 2017, when we did a population representative study survey in Greece, less than 5% of smokers believed that electronic cigarettes are significantly less harmful than smoking. And more than 40% believed that they are equally or more harmful than smoking. Well, they've been successful, I mean, based on what they wanted to do is create aversion for these products in the population. They've been successful, unfortunately, even among smokers. And that's the problem. How we are going to communicate proper, reliable information when we are competing with a giant who has all the money, all the power, the political power, and the political will to follow the tobacco control, you know, scenario.
I think the main argument they're using is we have to protect the children without any consideration of the parents or grandparents of the children. And I don't know if there is any credible study on gateway from reduced risk products to smoking. I haven't seen anyone, but I think the gateway is still, that's an area we really need to create a narrative around. The other thing is, I think it might be that some in tobacco control have a challenge to understand the difference between hazard and risk. I once tried to talk with an official in the European Commission about the difference, and he said, I don't know what this is all about. And I think that might be the sort of underlying problem with this debate, that they're not that knowledgeable, but they have a mission, and they are effective civil servants, and they're supposed to do what they're supposed to do.
I'm very conscious of the time. Is there anyone out in the audience, any last minute comments, thoughts? That anyone, gentleman here?
Yes, just Claude Bamberger from France. And yes, there is a study about the gateway, or more exactly the non-gateway effect of vaping to smoking in France, with 40% reduction in smoking rate, daily smoking rate in later teens if they vape before, between 15 and 17. And this has been published twice. It's from the same source, which is a very large study. And it was published with two angles. I've got a small question. I've seen as a vapor some of what you describe in the academic publication with surprising low level, because I'm not an academic and I can find huge failures in the publication that should be just authorized in a exercise at school, and that are published in papers that are taken into account by people like Scare Report. The thing is, when look at some other subjects, because I'm still a citizen, I also see these patterns in other fields, like considering natural gas is very green to avoid CO2 emissions. Don't you think that convincing millions of ex-smokers that globally the political system and the scientists or official authorities don't care, convincing millions that people concerned about environment, that politics don't care, on the part of the scientific authorities don't care, is very careful. Careful for the future of elections?
Yeah, I think, well, thank you for the point on gateway theory there, and those of us from a drugs field background spent years struggling with people who were convinced by gateway theories, and then we found there wasn't a gate. And I think that point about caring, and it's very difficult to get people to take on board information if they don't care, is a very valid one. I'm now going to be really unfair to the panel and ask you to each come up one take-home point or action you would like to see people do, or a presentation that you'd particularly like to highlight from this year's GFN.
For instance, something that I'm like last message, right? Totally free? Well, what I really would like is especially institutions to stop lying, governments to stop lying, stop stigma, and of course don't demonize nicotine. Nicotine is not that bad.
I agree. Nicotine is not that bad, but it is the new black when it comes to a regulatory approach. I think this was an excellent conference, reinforcing maybe my own biases on what I know about reduced risk products, but also underlining the fact that I think we have history on our side, and we might be sliding sometimes when it comes to truth, but we're not lying like they are.
I'll try to avoid making wishes which can never become a reality by themselves. So I fully agree with everything both my colleagues here mentioned, but we need to fight for that. And the fight is tremendous, and it's not only science, it's politics, it's mentality, it is political philosophy, it's our approach to what society is. It's much, much more than pure data analysis from studies in labs or in the population or in a clinic or in cells in animals or whatever else. It's much more complicated than that. We need to approach it from the perspective of political philosophy and what we want society to be and what's the role of the individual in a society. Should we respect individuals or should we use individuals as servants of society? This is the question, and we know the answer to this question by the tobacco control movement. I think the whole political movement globally is moving to a direction that individuals don't like it, and that's why I chose to avoid presenting any data in the Michael Russell oration this year, and I preferred to approach it from a sociological and philosophical perspective. So it's a very strong fight. Everyone has a role to play. The industry with their own vested interests, the consumers, the scientists, every citizen as a political subject, because, you know, not only professional politicians are politicians. Every citizen, every active citizen is also a politician.
Thank you very much. Well, I took from that, we've got to fight stigma, got truth on our side, individuals matter, and history is also on our side. That sounds like a very, very good way to end the sort of, if you will, formal part of GFN 2022. So please join me in thanking Angeles, Cecilia and Konstantinos. Very well done to all of you for maintaining your stamina. And I now need to ask Charles Gardner to come up to the stage. Charles, the time is now. This isn't in the programme. Do not panic.
Where shall I?
Yeah, all yours.
All right, this has been a fantastic meeting. I'm Charles Gardner. I'm the Executive Director of INCO, and INCO has the honor of presenting an award. We give out awards every year, but we've never given this award before. This is an award for extraordinary achievement in tobacco harm reduction, and I am delighted to give this award to Jerry Stimpson, Professor Jerry Stimpson. Jerry nursed us in our cradle and carried us on his shoulders for a long time. And we are beyond being toddlers now. We're ready to play rugby. Thank you so much, Jerry.
Well, for once, I'm truly lost for words. That's really wonderful. Thank you, Charles. Thank you, INCO. And thank you, everybody else who comes here and works in tobacco harm reduction and makes it all possible. Thank you.
Hi. For those of you who don't yet know me, I'm Jessica Harding, and this year, for the first time, I've had the pleasure and some pain of being Conference Director for the Global Forum on Nicotine. Before we close, I need to say some thank yous. Firstly, thank you to our keynote speakers, panellists, hosts, respondents, and GFN.TV commentary teams. Sessions that until now only existed on paper have been brought to life by your engaging and thoughtful contributions. Thank you for being with us. I'd also like to thank our 5 GFN22 media partners, Filter, Planet of the Vapes, eSig Intelligence, Vaping Today, and Vape Poland. We are very grateful both for your ongoing coverage of our conference and of the important issues in tobacco harm reduction. And of course, I need to thank the incredible GFN22 conference team. For months now, everyone has been dedicated to delivering our first full event in 2 years. From the technical and audio-visual work to the administration, registration and logistics, the team has worked so hard to make GFN 22 happen, so thank you. To those of you here, thank you for your generous donations to support Ukrainian refugees. Many of you are wearing the beautiful badges made by 13-year-old Sonia, who arrived in Warsaw from Kyiv in March. Together we've raised over 6,000 zloty, which is over £1,000 or $1,300. And if you would like to donate, but you haven't yet, Kasia will be standing by the stand after the session. So please empty your pockets on the way out. And finally, after this hiatus from in-person events, it's been fantastic to spend time in Warsaw with those of you here in the room, while also reaching far and wide to those of you via our online platform. So my last thanks goes to you, our audience. Thank you so much for joining us. wherever you've been watching from. We rely on your feedback to help us plan for next year's event, which is set to take place here in Warsaw again from the 22nd to the 24th of June in 2023. There is a short link shown on the screen, perhaps. Is that? Yes, there it is, for the feedback form. It's also on the website, and it will be in your email inboxes next week. So please let us know your thoughts, maybe when on your way home. So all that remains is for me to say to those of you here, have good journeys home. And to everyone watching, we look forward to seeing you in person or online at GFN 23. Thank you.
Well, hello. We are at the end of a long and fruitful conference. I hope you've all enjoyed seeing, hearing, whether you're out there in the Zoom world or whether you're here. You've been with us in Warsaw, in the hall as well. I'm very pleased to have with me well-known faces in this field. Marwa Glover and also Brad Rodu. Thank you for joining us. Thank you for your resilience. Your resilience at sticking it to the bitter end.
Wouldn't listen.
So let me start with Marwa. I mean, what's important for you at this kind of conference? What makes you hopefully look forward to it?
Oh, it's really important, especially being blacklisted, being excluded from many other conferences, to have a conference where I can come together with other people who are also experiencing that kind of anti-science behavior and to be heard, to be able to let people know about the research that I'm doing, to hear other people's research. And what I found during the pandemic was that, because as researchers, you're thinking up new research ideas all the time, you're identifying sort of priorities for research. That'd be a cool study. And there was a period there where I just had a blank. It was like a blank. Mm-hmm. And I realized, well, I'm not getting any of that interaction. Going to conferences, you're listening to people, and that's where you get ideas from. That's where you hear even stuff before it's published. People are presenting research and saying, oh, but we still don't know this. And then you go, well, we can find out that. Yeah. So it's an important source of information about what are the gaps, what further research is needed. You hear people present some research and you go, that's not right. And so, again, that's another source of ideas. Don't you think, Brad?
Well, this is a growing field. And meetings like this, you see that it truly is growing. And what I appreciate is the diversity of the participants. Mm-hmm. We have professionals who have been in tobacco field for years, but we also have consumers. That's super important to have contact with the people these products are going to help. And then also there's company participation. And I think that's vital because we need to know what these products, how they're going to develop, and the company's commitment to safer tobacco for smokers.
And it's what is so ridiculous about the Article 5.3 and all of that stuff that actually puts barriers between the industry and the consumers and the academics and the clinicians and the scientists who want to write about the products. There has to be that interaction. Everyone needs to be in the room. I mean, I always think in this respect about things like the Framework Convention on Climate Change. Everyone's in the room. The environmental groups, big oil, big gas, big everything. You know, they are all talk. What comes out of that, of course, is very political, but nevertheless, everyone's kind of round the table. What about takeaways? So this has been like, you know, we haven't done this since 2019.
Well, again, listening to the consumers and their concern that they're not being listened to, that much of the research that is being done is serving an anti-vaping agenda, an anti, tobacco agenda, and consumers are being targeted and being misrepresented. Their experience of using the products is being misrepresented by much of the research as well. So hearing that, I think that one of the takeaways from me is that somehow, and maybe it is researchers that need to help, they need to be able to voice and or put together what are their research priorities, what would they like to see research on. And, I think we both talked with consumers about this topic, and I would encourage them, we need to work with them more, and I think I'd like to see more participatory action research where consumers are setting the agenda, they're involved in learning how to do research and driving research themselves.
Excellent.
Well,
What about you?
I always take home much more than I bring to meetings like this. And it's really amounts to enthusiasm. Enthusiasm to keep this work up and to keep pushing ahead, because there is no question that in the long history of the world, what's right, what's safer, developments happen, and there's no question that the cigarette is on a short history and safer tobacco products will reign. There's no doubt about that.
That's great. So picking up on that hopeful prognosis of yours, where do you think we could be? I mean, it's a short history that we're doing, but where do you think, reasons to be hopeful? Where would you, if we're sitting here hopefully in 2023, what do you hope, where do you think we'll be? Where do you hope we're going to be in a year's time?
So again, one of the, I think, takeaways is that there was a little bit more, I thought, content talking about the benefits of nicotine, so a little bit more recognition that there are ways in which nicotine does help people, and maybe medicinal ways, or for various disorders, like we already knew about Alzheimer's and Parkinson's, but consumers, and listening to consumers, we're finding out that there may be other conditions that are helped by nicotine, and there was a session on the benefits of nicotine, and okay, it might not always work for each person, but it may work for a lot of people.
Right.
So I hope that we do see more research being done on the potential benefits of nicotine and how it can be used to help people who have particular mental health conditions or even inflammatory conditions. So that was good. I think that's a kind of there's a potential future there in terms of, because let's face it, at the moment, the many in World Health Organization Framework Convention on Tobacco Control and Tobacco Control, they're aiming for elimination of the plant altogether, no use of tobacco or nicotine in any way.
Right. I mean, right, do you think that, just thinking about medicinal cannabis and the way that maybe it's helped bring cannabis per se sort of from the margins and kind of more into the do you think there's nicotine can come in from the cold, so to speak, through biochemical, the pharmaceutical industry, even not even necessarily developments in the tobacco industry? I mean, is there a moment, a tipping point for nicotine?
I don't think there's any question, Harry. With a drug that's not that dissimilar from another widely used drug called caffeine,
right,
I think that nicotine can be rehabilitated. In fact, I think the biggest challenge is the correction of the misinformation. And from my discussions with colleagues all over the world here, it's a dominant phenomenon. Yeah. Everybody misunderstands nicotine. I think that's something we all can work on.
Right.
But on the other hand, I think there's hope, because our Food and Drug Administration, which is no friend of tobacco, has already approved several products as appropriate to be sold on the American market, smoke-free products that are vastly safer. So we now have a regulatory structure in these states in which that can be done. And I think that we have to continue that development.
Right. Okay. I think I've probably held you here for long enough. Is there any concluding statements you want to make?
In terms of your reference to cannabis and what we see happening in that field, I mean, one of the key turning points was the technology that allowed CBD and THC to be separated, so that you could extract CBD from cannabis and the THC. Yeah. So you have now a lot of people in the general public kind of understand that, and we already can do that with nicotine. Nicotine can be separated from tobacco. You know, you don't have to smoke it to get the nicotine anymore. This has been the case for a long time. Yeah. But I think that what has happened around cannabis, that you can use CBD without THC, the public understand. And certainly in New Zealand, in the research that I do, we had a referendum on cannabis, and there's this kind of, everyone's like, but why would you do, they said they wanted the country to be smoke-free, but they're trying to legalize the recreational smoking of cannabis. And it's creating a confusion, and it's a contradiction in the public's mind. And so I think that there will be some flow over from what's happened with cannabis. The public will probably lead this because they don't have the agenda that politicians have. They don't have the agenda that academics have. And they're the ones that understand that, what's the issue here, you know? So
absolutely.
I think that's a very good point, and we will see a change.
That just leads me, finally, Brad, to just ask you one thing, and it kind of, you picked up on it on the kind of misinformation and the ignorance about nicotine. We've talked quite a lot about, journals not accepting papers and academics not being allowed to this and this. But you've kind of held journal editors' feet to the fire, haven't you, on more than one occasion. So it's the opposite of decent science not getting into the public domain. It's rubbish science, junk science. And a lot of that is based on, I'm assuming, confirmation bias, not a lot to do with the science. What on earth is going on out there? Just in summary, what do you think?
Well, I think the solution to this, as in many fields in medicine and science, is full data disclosure and access and post-publication review. It's that simple.
Right.
If we have that, we'll fix all of the issues.
And is there resistance to that?
Absolutely there is. Absolutely there is. And some data sets are confidential or have special properties, but most data sets don't. And in fact, some fields, when you submit a paper or a study, you submit the code so that it can be reviewed and reproduced almost immediately. And that's what this field needs very, very seriously.
Well, that's something I'm sure you'll be keeping your eye on in the coming months.
And I would add that, the scientists and academics, we do need everybody to be declaring their conflicts of interest. And we need that recognition. as scientists know, we're always constantly trying to reduce bias in our analysis and our results and our research. And there's so much bias now that is not being disclosed. It's not just about who you're funded by. It's also the position you're coming from, your beliefs, and I think that we need to have much fuller disclosure of sources of bias. And be requiring, like that strengths and limitations section that people have to write. It's almost like a, you know, a dot point. Template, put this, put that. But, you know, there are some sectors where, you know, being reflective and being more open about your biases is kind of expected, and that needs to be happening in public health. We need more critical public health being done.
Right, great. Well, that's tremendous. Thank you very much for some very lucid analysis at this very late time in the day, sitting next to the windows with the sun coming.
Yeah, it's been a great conference. Thank you.
Okay, people, it's time for us to kind of sign off, but just a couple of comments to make. During the course of this conference, we've launched our the right to health and the right to tobacco harm reduction. The next thing on our agenda will be the 2022 Global State of Tobacco Harm Reduction Report, which is coming out in November, which is actually going to track the history of tobacco harm reduction, how we got here, where we're at, and the real tricky one, where we think it's going to go. But that's called the right side of history, because I think we would all agree that everyone in this community is definitely on the right side of history. I'm just reminded about a scene in Jurassic Park. Bear with me on this one. Who the dinosaurs are in the international tobacco control community is probably a conversation for another day. But at one point, the dinosaur scientists say to Jeff Goldblum, they say, well, there's no way these dinosaurs can reproduce because they're all females. You know, what can possibly go wrong? And Jeff Goldblum puts his head to one side and he says, no, he says, life will find a way. And of course, life did find a way in the end. If you watched all the sequels, which I have, then you'll know life did find a way. And I think we will find a way. We are finding a way. We've come from nowhere around 2006, a handful of vapors, maybe the odd cigarette, to now 100 million people using safer nicotine products and a vast array of products to choose from. So we are definitely here to stay, and I hope you are going to join us again next year. Hopefully more of you will be able to make it, but we'll be online again, because we are definitely here for good. Thank you very much.